She is on the way. Dean Madam will be coming after some time. So we will start the program. A warm welcome to Department of Medicine and State GSMC KMH, where we are really enjoying our centenary celebration, and we thank all of you to be a part of this. So without any further delay, I request the dean and the team to start the event. We will break when one of the lecture is over. Madam is free from that particular, because there's a protocol with AMC coming, she has to be there. So we will start, and she has told us that she will definitely come and be with us, right? So let's start. Thank you.
Thank you, sir. Thank you for your kind words and best wishes for this CME. Good morning, everyone. Respected dignitaries, esteemed speakers, faculty members, mentors, and all distinguished guests. On behalf of Department of Medicine, St. GS Medical College and KEM Hospital, I extend a warm and hearty welcome to each one of you. It is indeed a proud moment as we gather here to celebrate the centenary year of this glorious institution and inaugurate the Critical Care CME, where compassion meets expertise, clinical expertise, and excellence.
We are privileged to have with us Dr. Sangeeta Rawat ma'am, the Dean of SET GSMC and KEMH, Dr. Santosh Salagre sir, Professor and Acting Head of Department of Medicine Department, SET GS and KEMH, along with all our eminent speakers and dignitaries. We will now start with the first session.
For the first session, I would like to invite our chairperson first. I would like to invite Dr. Amita Athawale ma'am. She is professor and head of Department of Pulmonary Medicine at St. GS Medical College and KM Hospital. She has experience of more than 30 years in teaching undergraduate and postgraduate doctors, and she has been guide to MD Pulmonary Medicine candidate in MUHS, and she has more than 5 chapters as publications and 60 journal articles, and she has life membership of ICS, IAB, WAB, IMA, and member of ERS. She has been awarded as an Eisenhower Women's Leadership Fellow in Viatech Scientific Article Contest, first prize in 2013, and Dr. A.N. Supe Best Published Paper Award in 2018, Navdurga Samman in 2021, and she has interest in obstructive airway diseases, diffuse lung disease, genetics and lung disease, sleep medicine, and climate change, and lung health. I would like to welcome ma'am. Welcome. For the second chairperson, I would like to invite Dr. Jayraj Nair sir. He is professor and head of Department of Respiratory Medicine, LTMMC and Hospital, Sion, Mumbai. Postgraduate Guide to MD Respiratory Medicine, MUHS, member of European Respiratory Society, American Thoracic Society, Indian Chest Society, Indian Association of Bronchoscopy. He has more than 30 publications in reputed journals. Welcome, sir. Now I have the honor to invite our speaker for the next session, for this session, Dr. Vishal Gupta, sir.
So we invite Dr. Vishal and me have been associated, I think, for more than a decade. And I should tell you, during MICU days, more of a teamwork. It was Dr. Karnik, Dr. Vishal Gupta, get a call, and before the call reaches you, we would have the consultation done. And that's the way we probably worked. And let's hear from him, the much awaited person.
Thank you so much, Raina, for those kind words. It's a privilege and definitely coming back home. And to have your name among your teachers, your mentors, feel great. Thank you, Department of Medicine, for calling me. So, this topic I've chosen as ARDS because I think that this is a topic which we frequently come across. If you see, during the time of monsoon, I'm sure around 80 to 90% of the patient of MSL will be your ARDS patient. Even in the seasonal season thing, even your 50 to 60% of patient will be ARDS. Yeah, so we all know we have all come across ARDS so many times. So, for the intern sitting over here, it is very important that, we get to know about ARDS very well in our educational journey, so we don't miss out. Even if you go and specialize in other discipline of clinical medicine, you should be able to diagnose ARDS well, and you should know what are the protocol which we can do early to safeguard the patient interest. We all know that ARDS is a type of acute diffuse lung injury. It's a very heterogeneous in distribution, which is associated with recognized risk factors, characterized by inflammation, increased vascular permeability, and loss of aerated lung tissue. So each component is important, and you can see there is a lot of pathology involving the airway as well, the circulation as well, and the alveoli itself. It's though it is so common, but I was amazed to find that it was first described so late in 1967 by Ashbrook as a syndrome of acute respiratory failure in adults, to differentiate it from the pediatric neonatal age group where the surfactant loss was more commonly seen as a respiratory distress, characterized by non-cardiogenic pulmonary edema, right? Manifested by severe hypoxemia caused by right to left shunting through collapse, fluid-filled alveoli. Regardless of the cause, the diffuse alveolar damage is considered the histopathological hallmark of ARDS. Presence of hyaline membrane, which was seen during the biopsy with Oshberg, interstitial edema, cell necrosis, proliferation, followed by fibrosis or later stages characterized. And I said that it has evolved over a period of time. So during our residency, the definition of ARDS was different. It was the AECC definition of ARDS. Then came your Berlin definition of ARDS, and now we have got a new global definition of ARDS, which we'll discuss subsequently. So the latest till the global definition was there, it was an Berlin criteria, and how it differed from AECC was now it had a time limit, right? So the injury should be at least 7 days. Within the 7 days, there should be a radiographic evidence. Earlier it was only X-ray chest, which was in AECC. Now they have got CT scan as well. Now this bilateral opacity is not fully explained by effusion, lobar or lung collapse or nodules. This origin of edema is non-cardiogenic. It is from respiratory and there is a respiratory failure. How it is defined? It was defined by PF ratio. So mild was 200 and 1 to 300, moderate was from 200, 100 to 200, and severe was less than 100. So now we have come to a ESICM definition or global definition of ARDS, whereby now the time limit still remains 7 days. So there is bilateral opacity of X-ray chest or CT was in Berlin. Now with this new definition, now we have got a ultrasonography used as well. So we were the earlier user of sonography during our residency as well. We were fortunate to have ultrasound machine standby in our MICU. And Kanik sir has done a lot of work and has called international faculty as well during those early times for lung USU. So the origin of edema is not due to cardiac failure or fluid overload. Now this allows cardiac disease, but the ARDS is the main cause of hypoxemia or the infiltrate which you see. Oxygenal criteria remains more or less same, but now they have introduced a saturation upon FiO2 criteria as well. Because in a resource limited country, you may not always have a PO2 ABG machine available as your diagnostic tool. Yeah, so ventilation requirement, earlier the definition required at least a PEEP of 5 for that PF ratio. Now those PEEP requirement has been taken out, and now even also patient on HFNC and NIV are also included for definition of ARDS. It is just making it more simpler, so that a treatment option can be given early. So as I said, that SpO2 requirement is, and in the resource restricted countries, now even that PEEP requirement your PO2 requirement, your intubation requirement is all taken off. Right? So this was whatever I said before, it is all included in your new global definition of ARDS. So again, the non-intubated patient ARDS, you can have a PO2 of PO2 FiO2 ratio of less than 300 or SpO2 FiO2 ratio less than 315 in a non-intubated patient, and the intubated patient remains same. And now we have got a saturation of one FiO2 criteria included as well in ARDS, definitely along with your bilateral opacities and injury with 7 weeks, 7 days of limit. So as I have said earlier, ARDS is caused by diffuse alveolar capillary injury resulting from various direct. Most common cause we have seen was pneumonia, and we have seen during COVID time how severely it can affect. It can have an aspiration as well, or it can be indirect, like in any sepsis, trauma, pancreatitis. This also can cause ARDS. The process is multi-pronged. It requires inflammation, immune dysregulation, endothelial epithelial damage, and a disrupted coagulation. Right? So how does it start? So there is an immunoinflammation. Whatever trigger, whether it is a septic or aseptic, pathogen or cellular injury, there is activation of both innate and adaptive immunity. All the cells are involved. Mechanism is alveolar macrophages polarizes to M1, which is a pro-inflammatory, and it releases interleukin 1/6 TNF alpha. And we have been measuring that during our COVID time, ARDS of IL-6 is important as a cytokine storm, as we used to call in those days, associated with ARDS. So there is also endothelial activation, right, toll-like receptor cytokine storm then perpetuates the inflammation. So this is the initial immunoinflammation. Then there is the immunothrombosis. So there is a crosstalk. So whenever there is an inflammation, it also triggers your coagulation. So you got a lot of microthrombosis in pulmonary capillaries, which cause again impaired perfusion and oxygenation. Right? So there is endothelial barrier dysfunction, breakdown of tight junction protein, which lead to increased permeability and a non-cardiogenic pulmonary edema. We also have a cell-free hemoglobin, which is also triggers the inflammation, and it promotes the leukocyte endothelial adhesion and oxidative injury. Again, we have got a decreased alveolar fluid intake. Then you've got a cellular pathology going on: cell death, apoptosis, pyroptosis, ferrosis, synthesis, and dysfunction of the inflammatory mechanism of lung. So this is in short how the inflammation and the coagulation triggers your ARDS and how you need to handle each of them. Right? So what are the clinical risk factors we are seeing? So the commonest which we come across is definitely pneumonia or viral pneumonia. Definitely in our setup, we see a lot of dengue, malaria, leptospirosis, undifferentiated infection, which also lead to ARDS. Inhalation injury, aspiration, fat embolism, which all can lead to ARDS. Extrapulmonary is sepsis, definitely, trauma, burns, pancreatitis, etc. So now this ARDS can be progressive. So we have seen it usually progresses from day 1 to day 7, which we have got alveolar damages, hyaline membrane edema. So you got acute hypoxemia with bilateral infiltrates. From 7 days onward, most of you must have seen improvement in ARDS, but some of them can go into a proliferative phase with a type 2 pneumocyte hyperplasia, fibroblast proliferation. And now here you start getting a more stiffer lung, decreased minute ventilation, and increased force and work of breathing. And beyond that 21 days, then you can have a fibrotic phase, and I'm sure you must all be getting so many post-COVID patients with fibrosis in your OPD stage. Now, how is our ARDS in India different from a Western world? Definitely, as I said, I'm sure that I've also worked in similar settings. So, around 90 to 100% of patients in your monsoon season will be your ARDS. But if you see the whole things around, it will be around 10 to 15% of ICU admission. Most of them will be because of pneumonia, that too commonly the viral pneumonias, and mortality rate as considered compared with Western population, we are having a higher mortality rate. So definitely we have got a challenges. Thankful, should not be a thankful thing, but COVID has definitely increased the number of ICU beds available. Prior to that, there was a severe infrastructural deficit. There used to be a diagnostic delay. There is a technology gap, so nowadays, though we are talking in terms of a resource restricted setup, but now there are so many other modalities available as well, like ECMO and all those things, which may not be usually available to all of us. And there is a socio-economic barriers, and the cost of health is going up day by day. And what about the risk factor specific to Indian context? We got a high prevalence of tuberculosis. So we on the treatment, the differential, everything will have a problem with that. Pneumonia, sepsis, our own tropical diseases, right? Chronic condition like malnutrition, diabetes mellitus. We are the diabetes capital of the world. And smoking, biogas exposure, everything, all this adds to extra burden as far as the lung is concerned, which can complicate ARDS further. And during our COVID study as well, we found a lot of alcoholics. They used to have more severe ARDS. Again, clinical picture, everybody knows that patient will be coming with severe dyspnea, cyanosis. There will be a diffuse inspiritic crackles on auscultation, tachypnea, tachycardia, diaphoresis, use of accessory muscle of respiration. That is the first thing when we used to go for a peripheral visit. So if you've got an accessory muscle, first put oxygen, then talk. Right? So that is the important thing. The refractory hypoxemia despite oxygen therapy. APG is important, chest X-ray is important, which will definitely show you bilateral infiltrates. Right? So this is the common X-ray, which I'm sure everybody must have seen. And we can see that there is a heterogeneous distribution of damage. So that leads to what is called as the concept of a baby lung, which have a therapeutic implication, right? So if you give a normal tidal volume to this patient, what will happen? The collapsed alveoli won't inflate, right? And whatever tidal volume extra you are giving will go to a normal alveoli, which will again got a increased ballooning and cause a shear force. So that can cause a barotrauma as well as a biotrauma, because those shear stress can release to further inflammation. Right, so we know the differential cardiogenic pulmonary edema, miliary tuberculosis is one of the differential. That's why that 7 days things are kept. Idiopathic acute eosinophilic pneumonia, interstitial lung disease, interstitial pneumonia, all those things will be a differential diagnosis. Now, definitely the learning of COVID ARDS, right? So now more and more uses of NIV and HFNC has come. Though we had a HFNC available with us before, but the use was very much limited. So now the management principle, I said, that will be a lung protective invasive ventilation if it is an invasive one. Rescue strategy for refractory hypoxemia I'll come one by one to it. Recruitment maneuver we don't usually promote. Prone positioning is something which we have learned so well during our COVID time. High frequency oscillation ventilator is also not advisable. ECMO and inhaled NO is something which we think about, right? So this is the HFNC machine. I'm sure everybody must have seen that. So it is very good and very well tolerated as compared to NIV. So the failure with NIV is much more, and there is a lower risk of intubation and lower mortality as compared with NIV. So what is the advantage of HFNC? The FIU values can be adjusted from 21 to 100%. So there is a reduced anatomical dead space, decreased work of breathing. It generates mild PEEP, process lung recruitment, and delivers warm, humidified oxygen, which is having a better mucociliary clearance and comfort. So there is some Rockstock index. I know that we all go more by clinical judgment by just scoring up, but definitely it is a good index, which is SpO2 upon FiO2 divided by respiratory rate. So post putting the patient on HFNC, how much is the Rox index, which will predict the HFNC failure or success. Again, this NIV, they are using some score like what is Hacker score, which includes the heart rate, pH, Glasgow Coma scale, PF ratio, and respiratory rate, which will also tell you about the use of NIV. Like, so risk factors in NIV failure will be shock, definitely a hemodynamic instability. We don't usually recommend NIV, metabolic acidosis, severe hypoxemia. So, and because we'll be just delaying the intubation, which can also have a problem with mortality. Now, this is important, and as I see many of the interns as well, with the first year resident as well. So, make it a practical point to use a low tidal volume. So, it is usually a 6 ml per kg is considered as a standard of care in ARDS. It minimizes the volumetrauma. High PEEP versus low PEEP. Now, there is no question about it. Definitely, we are using a high PEEP strategy to keep our alveoli open for majority of the respiratory cycle. Right? So you all have set up the ventilators in your ICU. Definitely we go with the predicted body weight. Males will be 50 plus 2.3 into height in inches minus 60. And we usually start with 8 ml per kg predicted body weight, and then gradually reduces to 6 ml. And then we set respiratory rate as per the CO2. The target is plateau pressure should be less than 30. Driving pressure we usually are not using. pH goal will be more than 7.2, which allow a permissive hypercapnia, and PO2 goal of above or more than 60. So this was a study done in our hospital, KM hospital, which we saw the predictors of outcome in ARDS and acute febrile illness. Dr. Archana, Nitin sir, and me, along with Anvita, had done this study. So this is a prospective observational study with 130 acute febrile illness patient with ARDS was seen, and we studied the SOFA score, PAO, PF ratio, lung injury, and saw the outcome of survival versus death during MICU stay. So this was in brief about the study we did, and the maximum patient we got were definitely AFI, H1N1, dengue, and leptospirosis. And malaria was less of it, but we had got a good outcome with patient with malaria. So mortality was highest in undifferentiated fever and leptospirosis, and we showed a better survival, definitely maybe because the patient maybe a better physiological. SOFA and delta SOFA were a reliable predictor for prognosis, and lung injury score and DSE didn't correlate very much with the problem. Now, this is again, as I said, that we have learned so much about the prone positioning in COVID time. So when the earlier they had done, so definitely we have got a improvement in mortality. Right. So initial early within 36 hours of ARDS diagnosis they used to do, and session duration usually lasted from 12 to 18 hours. So spinal instability, hemodynamic instability, cardiac abnormality, recent thoracic abdominal surgery were contraindication during their time. So what is the physiological benefit of proning? So there is a relief of mediastinal compression. Definitely whatever mass your heart gives to the lung decreases. So your dorsal portion of free wall movement increases. So it causes a homogeneous distribution of ventilation, uniform alveolar recruitment. There is a reduction in alveolar collapse and lower pulmonary vascular resistance. So better ventilation perfusion matching, leading to increased PO2, decreased PSO2, and thus vascular resistance also decrease, causing enhanced right ventricular function. HFOV is no more recommended for treatment of ARDS. Inhaled nitric oxide again sound promising, but it's not usually used. Similarly as prostacyclin. Now, neuromuscular blockade, definitely now with the new guidelines coming with ESICM as well as American Society, they have also now advised using a neuromuscular blockade for early treatment of ARDS. Definitely we have seen that dysenergy is reduced. Fluid strategy, we are aware that conservative fluid strategy is much better tolerated than liberal strategy. So maintain the blood pressure with the minimal fluid which we can be given to the patient. Don't go for a fluid overload, and vasopressors if necessary can be used. Now this is again a burning topic in use of corticosteroid in ARDS, and thankfully, with whatever evidence we got during COVID pneumonia, now because the earlier outcome where of COVID ARDS was much better in India as compared to Western society, because we were using empirically steroid for quite a long time, for quite a long period of time for various other ARDS as well. So now definitely we got a use of corticosteroid is now advisable in ARDS, but the patient selection is important. Right, so the recovery trial, which was important, so the dexamethasone, which was given 20 milligram for daily for 5 days, and then 10 milligrams for next 5 days, definitely it showed a better outcome as compared with the control group. Now again, to include the researches which we did in MSU, we had this efficacy of pulse methylprednisolone in malaria-associated ARDS was done by Smriti. And again, then because it was, I think, a pulse corticomethylprednisolone, so we didn't get any advantage of using corticosteroid during ARDS. So now the Western society are now moving to subphenotyping of ARDS. Okay? So there can be a hyperinflammatory, hypoinflammatory, and with the machine learning and AI as well, we can have a precision setting for the ventilatory setting of the patient, depending on the subphenotyping and AI ML based therapy. So these are various novel ways of now which they are coming up with the treatment, and definitely now with each lectures now AI and ML has become a compulsory slide. So there are various studies going on regarding use of CNN and ventilator pressure graph to have a precision ventilator control for the patient. Right. So here I am.
Thank you, Dr. Vishal Gupta. It was an excellent overview of, I think, the various strategies that are available in ventilation prone. A lot of it has come up more in COVID, HFNC also more in COVID. So all these strategies have been wonderful, wonderful perspective, especially of the, I think what extra we see in ARDS are the monsoon related illnesses. So your 23%, which was shown as a undifferentiated, I think a majority of them must be lepto who didn't come microbiologically positive.
That's right.
But clinically, they all looked
as well, and
lepto.
that's why our empirical way of treating the patient when it is AFI with ceftriaxone usually have helped the patient a lot.
Okay. Any questions from the audience?
So myself, Dr. Sandeep Patil, I'm a lecturer in MBGI Medical College, Nasik. So in corporate ICUs, we have seen patient diagnosed as ARDS. They have started treating with IVIG also. So what was the exact role of IVIG? I didn't understand. Patient was mycoplasma positive, whether to reduce the immunological burden or as a treatment strategy, adjuvant therapy for the ARDS.
Some of the patients, if they are having that immunoglobulin deficiency,
So as we said, immunoglobulin deficiency, that is possible with the lymphocyte analysis, which ICM are especially in tuberculosis. We have also had patients who have had primary IgG deficiency. So G, A, M, and E, all the immunoglobulins are checked, and if you have them deficient, giving them immunoglobulins in time improved the prognosis, especially tuberculosis patients with ARDS. We've had good recoveries when IVIG was used.
Yeah. It is a very limited setting, but not in general. It cannot be. There are no RCTs also, and they are used for this limited, set of patients. As he said, it is phenotyping. You find out which patient is what amongst the whole spectrum of ARDS.
Sir, one more question regarding IL-6. Sometimes, do you recommend to doing levels of IL-6 and routinely we don't do it?
More of a clinical diagnosis, as I said, the PF ratios and bilateral X-ray infiltrates.
Okay. Like use of tocilizumab or anything? Nothing. No, we don't do it. Thank you.
We had done a study on tocilizumab. We had a positive finding, but subsequently the WHO, Nikhil must be remembering this. So subsequently it has not. We had used, and definitely our study had a positive result. Maybe right now, so there is no recommendation.
Markers are going to be important if they are adding to our phenotyping of the patient. Since the therapies would come in, so what would you suggest? There would be the, though we are resource limited,
we had done in ICMR KM a study in severe dengue versus non-severe dengue. And there we found abnormal lymphocyte subset analysis as a predictor of mortality. We found very high cytokines in the people, and probably all this is genetically related. So why certain patients of malaria, leptodengue get multi-organ failure and have a poor prognosis in terms of morbidity, mortality may be directly linked to your genes.
So I think we'll proceed on because we are a little behind schedule.
We now request Dr. Amita Thawde, madam, to kindly felicitate our speaker, Dr. Vishal Gupta, sir. Big round of applause for our speaker, Dr. Vishal Gupta, sir, who is being facilitated by Dr. Amita Thawde, ma'am, and Dr. Jairaj Nair, sir. Thank you, sir. We now request our
This CME is a physical CME, and those all of them who have registered for MMC credit point, they need to attend the entire sessions. There is a lateral diversion here, so please be here so that the newcomers will be sitting. We have sent messages to all. UG students will be going after some time. All those PG students and external faculty and external people who have come to attend this entire day CME will be pushing this side so that the new people which are coming will be sitting. Yeah, please shift this side. Yeah, all of you, because the speaker, when they see empty chairs, they don't feel like speaking. So we want chairs in front of all of you. Please shift. All of you shift here, this side immediately, madam. So yeah, yeah, this is the sitting arrangement is better, and UG students can go from behind once their time slot is over. Huh? Right. Yeah. Right. So all my PG students will be pushing here this side and will be coming here in front, and they will be actively participating in this CME. Okay. Yeah. Please start.
We now request our next speaker for the session, Dr. Nitin Karnik, sir, who will be introduced by our chairperson. Though sir requires no introduction, I guess. Sir, please welcome.
I think Dr. Nitin Karnik sir does not need a slide. All of us know him well, and I have seen him since my UG days, and he has been an excellent teacher to all of us. Bedside manners, clinics, how to pick up, multi-system. That's not reflected in this slide which was shown about him. Okay, and he was also the part of the COVID task force, and how on our virtual meetings he helped us how to strategize, how to triage the serious COVIDs from the mild ones, all these things. And whenever there is a diagnostic dilemma, even my residents, anybody who falls sick, undiagnosed fever. The first thing it clicks to me, whether I was in KEM or Cyan right now, everywhere the first thing is, let's call Karnik sir. You know, that's the introduction for him, not this slide. Thank you.
Thank you, Jairaj. And it's a nice feeling to be back. I am a UGPG from KEM. I've been for 20 years in Science, then came back for 7-8 years in KEM and back in Science. I'm thankful to the medicine department KEM, Dr. Nadkar sir, Dr. Nitin Sarate for calling me here. I've just put this slide because some of the cases which I will show are from my tenure here. Now, what will be the objectives of today's lecture? Seeing the incidence and magnitude of community acquired pneumonia, the management guidelines and indications for ICU admission, PAP in ICU, the etiological and treatment challenges, and basically my aim is to just show you the plethora of pneumonia cases in MICU, their varied presentations, and of course a take-home message. Now, India accounts for 1/4 of the global pneumonia burden. So we have to be aware a very significant problem, and annual incidence of about 5 to 11 per 1,000 individuals, total annual cases about 4 million, and pneumonias account for about 40% of the ICU admissions. And unlike general understanding, the incidence of CAP in children is also significantly higher, highlighting a critical public health concern. Regarding the etiopathogenesis of CAP, now you'll see the difference in these two studies. Data from a study conducted in Pune where it showed that Klebsiella pneumonia and Streptococcus pneumonia were the leading causes, followed by Staph aureus, H. influenza. Whereas if you see a better done study which had probably better diagnostic access, they have 30% was Streptococcus pneumonia, almost 18% Legionella, influenza virus is 15%, mycoplasma 7%, chlamydia 5.5%. So if you have access to diagnose atypical pneumonia infections, then together they may account for almost 30% of the community acquired pneumonia. What are the risk factors for pneumonia? Age, environmental factors, smoking, prior CAP, malnutrition, COPD or chronic bronchitis, asthma, poor dental hygiene, gastric acid suppressive agents can cause, and oral steroid therapy. Other risk factors are diabetes, CVA, like stroke causing altered sensorium and bulbar palsy, and of course congestive cardiac failure. Now, when to admit? Now, if you go abroad, the emphasis is on OPD treatment because of their high healthcare cost borne by the insurance companies. So we need to be familiar with some tools that can help in risk stratification. Curve 65 is a set of 5 variables that help in bedside severity, bedside assessment of CAP severity. 1 point each for confusion, BUN over 7 millimoles per liter, respiratory rate of 30 minutes or above, SBP of 90 or below, DBP of 60 or below, age 65 or above. And if the patient score is 3 or more, it's always better to admit these patients. Smart COP prediction rule is a rule that helps to determine if a CAP patient needs intensive respiratory or ventilatory support. And you have this 2 points are given for SBP less than 90, low oxygenation, a pH less than 7.35, and 1 point each for multilobar involvement on chest X-ray, albumin less than 3.5, tachypnea, respiratory rate more than 25, below 50, more than 30, above 50, tachycardia more than 125, confusion. And high risk, now if you have 5 to 6 points and 7 points are above is very high risk. Moderate risk is about 3 to 4 points, and patients with a score of 5 or above should be considered for ICU care. So this is a fairly simple thing which doesn't need any high-tech investigations. We can predict and triage our patients, because when I have 120, 150 admissions during monsoon or only 1 or 2 beds available in ICU, somewhere we have to rationalize the thing. Now, I have purposely shown this slide of the treatment protocol, where this is obviously from European Respiratory Society guidelines. Now, the left part of it is right. In the combination therapy, ampicillin, sulbactam, coamoxiclav, cefotaxime, ceftriaxone, and for CAP, a agent to cover atypical pneumonia organism. So azithro or clarithro. Use doxy 100 milligram BD if macrolides and fluoroquinolones are contraindicated. One should not agree with the right part of the chart, though the European guidelines say fluoroquinolone. We should not use fluoroquinolones for pneumonia because we have to reserve it for TB in India. Okay, Procal has been suggested for de-escalation of antibiotics if available. Oseltamivir has been suggested for patients for severe CAP caused by a PCR confirmed influenza, and for severe CAP and acute hypoxemic respiratory failure, HFNO, NIV, and as a last resort, endotracheal intubation and invasive ventilation. So what I'll take you through is this case matrix of pneumonia cases. So starting with the first case, this is a 23-year-old male, came with fever, chest pain, breathlessness, and dry cough. He had tachycardia, a BP of 80/50, SpO2 of 88%. He had reduced breath sounds with bronchial breathing in the right axillary infrascapular region, and the chest X-ray revealed a big right lower zone opacity. Ultrasound chest also revealed a pneumonic pleural effusion. So he was in shock, he was in respiratory distress. Post in ward, he was admitted in MICU. He was uh, needed a prolonged HFNO support. He was given ceftriaxone, clarithro, and we had added oseltamivir. His BP improved with hydration, tachycardia settled with oxygen support, but he needed 10 days. After 10 days, he was on oxygen by nasal prongs. This is the time when this picture is taken, and he could be shifted to the MICU, out of MICU. So his diagnosis is a right lower zone community acquired pneumonia with sepsis, septic shock, and respiratory distress. Coming to the second case, a 29-year-old male, cough with blood-stained expectoration associated with left-sided chest pain and breathlessness. He had a history of MDR sputum positive PTB in 2016. He had completed 1-year course of MDR TB. Again, tachycardia, hypotension, SpO2 of 90%, respiratory rate of 22, conscious oriented left axillary and infrascapular bronchial breath sounds and crepitations. The chest X-ray was suggestive of a left lower zone heterogeneous opacity suggestive of pneumonia. And he had also on the right side, if you see, some interstitial infiltrates. Now, post in ward, his platelets, he had thrombocytopenia. He had a deranged PT-INR. He was given cephalosporin, sulbactam, clarithromycin, oseltamivir. He needed oxygen 6 to 8 liters by NRBM pass. The thrombocytopenia and DIC resolved with treatment. There was no recurrence of hemoptysis. He responded to treatment rapidly. He became off oxygen support within 48 hours of admission. So this is a right lower lobe community acquired pneumonia with left lower lobe CAP, right lower lobe interstitial pneumonitis, thrombocytopenia, and coagulopathy as additional clinical features, and likely due to sepsis and early DIC. Coming quickly to the third case, a 14-year-old boy, fever with chills since he was from the Dharavi area, fever with chills in 7 days. He was taking treatment from a local GP, no relief of symptoms, cough worsened, breathlessness occurred. He came to find pulse was 145, blood pressure maintained, but the saturation was just 86% on room air. Respiratory rate was 45. The RS showed right lung bronchial breath sounds. He was shifted to MICU, and you can see almost a huge lobar pneumonia on the right side. His ECG was suggestive of a sinus tachycardia. Post in ward, he had a high WBC count. His COVID influenza PCRs were negative. Fever profile was negative. He was given piperacillin, tazobactam, vancomycin, oseltamivir. He was started on NIV support. He did not settle on NIV. Intubation was needed, and gradually he needed almost 2 weeks of invasive ventilation, extubated and shifted to ward on day 15. So now you have a young pneumonia, young boy, hardly 14 years old, And these are the serial X-rays showing the progressive improvement in the X-ray shadows. So the message here is even a young adolescent can have a life-threatening pneumonia and would need a ICU support for almost 2 weeks. Okay, now we in public hospitals are fortunate enough to provide them this support at no cost. But imagine if he had gone to a private setup, 14 days billing would have been 14 lakhs. A 65-year-old male. Now let's come to the other side of the age curve. A 65-year-old male, known case of diabetes, hypertension, fever, chills, cough with sputum, breathlessness since 3 to 4 days, tachycardia, hypoxia. He had high sugars. Chest X-ray was suggestive of a right mid and lower zone heterogeneous opacity. So this was his X-ray. Doesn't look quite good. Maybe some old cocks on the upper zone, but he had a high creatinine. He had a high bilirubin. His WBC count was very high at 30,900. Platelets were maintained. Now his post-in ward, he was admitted in MICU, needed a BiPAP support with 100% FiO2, given piperacillin tazobactam dose adjusted, clarithromycin and oseltamivir. He responded well, became off BiPAP in 3 days, AKI and hepatitis resolved over 4 days, shifted to GMW on day 10 on nasal oxygen support. So this is a diabetic hypertensive as background comorbid factors, CAP, sepsis, shock, AKI, hepatitis. Case 5, a 82-year-old male. Now we go to the still more extreme. Known case of hypertension, IHD, just 3 days history of breathlessness, which came first. Fever, just one episode 2 days back. Was admitted with hypoxia. He was drowsy and had bilateral coarse crepitations. So X-ray showed right mid and lower zone inhomogeneous opacity. His creat was high. His influenza and COVID PCR were negative, but his HS trop Y was almost 28,000. So this is the patient. This is his X-ray. More shadows on the right side, but even on the left side, you had interstitial shadows. Course in ward, patient was intubated in casualty itself because he had come with severe respiratory distress. His endotracheal secretion culture showed Klebsiella pneumoniae sensitive to gentamicin and colistin. Now this is a community acquired pneumonia, but already you have a MDR GNB which is resistant to meropenem. He was given mechanical support, given a combination of colistin, meropenem, but developed shock, needed triple inotropes. We tried hard, but he died on day 8 of admission. So a community acquired pneumonia because of Klebsiella with shock, septic shock, AKI, ARDS with underlying ischemic heart disease. So the learning point here is CAP is often a terminal event in elderly individuals. We all have our elderly relatives, and they have diabetes, they have a dilated cardiomyopathy undetected, they have ischemic heart disease, and they have COPD, end stage renal disease. And in all these patients, pneumonia can occur as a terminal event, often catching us unawares, and hence the importance of at least trying to prevent a pneumococcal and influenza pneumonia with appropriate vaccination. Coming to case 6, a 55-year-old female, a diabetic, 7 days history, fever, chills, cough and breathlessness. She had a high BP, saturation was low, high sugars, bilateral coarse crepitations, bilateral lower zone haziness with left CP angle blunting. She had high, her HbA1c was 10%, high triglycerides and cholesterol, WBC on the higher side, sputum gene expert negative. So this was her chest X-ray, bilateral lower zone haziness with left CP angle blunting, and X-ray showing diffuse patchy areas of opacity, interlobular septal thickening, and post-in ward, she was put on HFNC. She was given cephalosporin, sulbactam, clarithromycin, oseltamivir added, insulin and antihypertensives. Responded well. Became off HFNC in 3 days. Chest X-ray became clear on day 7. She could be discharged on day 10. So this is our X-ray on day 7 in MICU. So we've had a good outcome despite her high sugar. So this is another case where severe diabetes, she's having high lipids, high HbA1c, infection, sepsis, but with proper ICU care, a good recovery. This is a 55-year-old male, known case of ischemic heart disease. Again, fever, chills, breathlessness, hypoxia, tachycardia. The ECG showing sinus tachycardia with left axis deviation, LBBB, primary T wave changes, and see the X-ray. The X-ray is showing right middle and lower zone heterogeneous opacity, suggestive of a lower lobe pneumonia. Responded well to piptaz, azithromycin, and so this is on a pneumonia occurring on the background of IHD. And what happens is IHD pneumonia, you can have precipitation of cardiac failure, but as I said, now this is recognized that ARDS can occur along with cardiac failure. This is a 28-year-old male who took Propaxar, that is Bagon, under the Carbomet, under the influence of alcohol, admitted with respiratory altered sensorium, respiratory distress. Now he had classic, respiratory failure, some aspiration, intubated, and admitted in MICU on invasive ventilation. 2 days later, he had the shadows in the lower lobes worsened, suggestive of ARDS. A diagnosis of chemical pneumonitis was made. But then he started developing fever spikes. The culture came Acinetobacter baumannii positive. He responded to meropenem and colistin. So what I'm coming through now is somebody who's coming with OP poisoning, chemical pneumonitis, then develops worsening of the shadows, gets a hospital-acquired infection, which is Acinetobacter, and then the picture worsens. This was a 56-year-old male with ankylosing spondylitis and immune pure red cell aplasia secondary to parvovirus. 2 days only history of breathlessness, dry cough, tachycardia, hypoxia, bilateral infrascapular crepitations, drowsy. He had homogeneous opacities in bilateral lower lobes, suggestive of bilateral community acquired pneumonia. HRCT done suggestive of a bilateral necrotizing pneumonia. He had WBC counts were high, low platelets, flu panel was negative. Orson ward responded to, he was given NRBM, piptaz, azithro, oseltamivir. But 1 week after transfer to general ward, he developed breathlessness, hypoxia, was re-transferred to MICU, and now the chest X-ray is showing new shadows bilateral. So he's developed now, hospital-acquired infection, settled with meropenem, needed 10 days, again stay back and transferred back to the general ward. So this was occurring on the background of a angstpon. Now, 16-year-old young diabetic, this is our case 10, coming with diabetic ketoacidosis, RBS of 512, urine ketones large. But what has precipitated DKA is this bilateral interstitial shadows. He had fever, breathlessness. So you have in a young insulin-dependent diabetic pneumonia precipitating diabetic ketoacidosis. So that is another end of the spectrum. But here we needed much simpler drugs. Responded to ceftriaxone, azithromycin. DKA resolved in 36 hours. Discharge on day 10 of hospital stay. Now, pneumonia in pregnancy, increased maternal susceptibility, higher morbidity and mortality. And interestingly, they say that in pregnancy is an immunological balancing act where the mother's immune system has to remain tolerant of paternal MHC antigens and yet maintain normal immune competence for defense against microorganisms. So all these causes for pneumonia in pregnancy. These are the standard drugs. However, one point is clarithromycin should be avoided for a typical cover in pregnancy because of teratogenicity in animal studies. So this was a 22-year-old prima. We saw this monsoon season, 34 weeks gestation, came from Kalyan, day 4 PNC. Emergency LSCS was done at a private clinic, delivered a 2.8 kg live female child, but had on the background some fever, chills, dry cough, breathlessness, and then yellowish discoloration of the eyes. She had falling saturation. Her bilirubin was high. Liver enzymes were around 200 to 300. So she was transferred to Cyan. She had bilateral interstitial opacities. However, if you see the chest X-ray is not bad, but her saturation was low. So we suspected a viral pneumonia. We added oseltamivir to her treatment. It was a choice between atypical pneumonia, bacterial versus viral. Is there a partial health syndrome on the background? She was shifted to MISU, and this on I think day 4, her H3N2 influenza A came positive. So this was a influenza A interstitial pneumonitis in a postpartum female. She had a uh, uneventful course and recovered. Now, this is our KEM case. A 25-year-old, Vishal will remember way back, I think, uh, there was an epidemic of H1N1. This lady came from Satara, 9 months pregnant, bad ARDS with H1N1 pneumonia. Her PO2 was hardly 78% on 100% FiO2. I think Amita also, she is the savior for this patient. So she went in labor. First of all, the MISU sisters, अरे H1N1 रखा है, हम सब मर जाएंगे. And then she went in labor. Now in KEM from MISU going down, she would have died by the time she reached the labor ward. So I said, no, we deliver her here. Again, a big union baji, but ultimately Vishal helped me to pacify them. We delivered her there. And that was not the end of the story. That's, I think, Fadnavis sir had just become CM 2 weeks back. Unexpected visit to KEM MISU, and he, think, he saw this patient, and he was quite happy that despite you could deliver a live child. And then he told Lata Mishra and Mumbai Mirror, make a newspaper report. I refused because I said, no, let her recover first. But they insisted. So this came in the newspapers the next day. She took 40 days to settle. There was a time on day 15, 16 where both the lungs were white. Her saturations were dropping. BP was 70 systolic. At the time I rang up Amita. I said, you come and see. It's now going beyond me. Just see whether you can do something to the ventilator. She was there within 10 minutes. She adjusted the ventilator. And there's one very, I want to point out regarding Amita that, the look in her eyes told me that I'll take care of her, don't worry. I didn't even have to tell her verbally ka tumhi darroz yeun baga. She was there for the next 7 days, 3 times a day, adjusting, and that same, she's got a half smile on her face when things are under her control. So, I used to be taking my round. She used to come here, adjust the ventilator. The patient came out on day 30 or 35. So she's alive because of Dr. Amita. He could be discharged on day 40. Now, just I'll skip this. The etiology of VAP is different because you have Pseudomonas, the MDR GNBs, and predisposing factors we know. Mainly, we are the predisposing factors in ICU if our care is not good enough. App in immunocompromised patients can be this full list of MDR GNBs and gram-positive organisms. You see, unlike CAP where you rely on empiric therapy, in VAP we do need a good microbiology help, either in the form of a bronchoalveolar lavage, endotracheal aspirates for smear culture, and the background of COX is always looming. So especially in pregnant patients, lot of them on postmortem turn out to be tuberculosis. Just one case, which was here, a 73-year-old male with past history of prostate cancer came with a big community acquired pneumonia. We treated him in MISU, improved over 12 days. On day 15, again deteriorated, developed bilateral pneumonia. So again, we had to change the antibiotics. And if you notice now, what is happening is the arrow points out that the pneumonia is developing a cavitation. So he developed a cavitation with air fluid level. He was now, the ET secretion showed Acinetobacter baumannii sensitive to colistin and polymyxin. Started on colistin, we attempted a bedside drainage which failed. He deteriorated and died on day 31. So this is an elderly prostate cancer, has come with CAP, has developed a VAP, cavitating Acinetobacter and has died. Now, the last two slides. What is the greatest threat or problem that a patient can face while seeking treatment? Poor accessibility of health facility, unaffordability of health service, disease-related stigmata and fear, and getting treated by quacks. This is a very interesting case which I saw just 3 weeks back. A 23-year-old male, no known comorbidities, fever, cold, breathlessness, right-sided chest pain, went to a local hospital somewhere in Kalwa Mumra area. ECG was done, which was, I'll show you the ECG. They diagnosed him as acute myocardial infarction. नसीब से उसको थ्रोम्बोलाइज नहीं किया, हेपेरिन दिया, डुअल एंटीप्लेटलेट दिया, स्टैटिन दिया, and they referred him to Shivaji Hospital at Kalwa for coronary angiography. He went there, BP 80, systolic pulse of 120. So they have written on the note, patient is too unstable for coronary angiography, refer to Sion Hospital for CABG. Now, this is the ECG. I mean, it can, what probably some ST elevation in 2, 3, and then reciprocal ST depressions in anterior leads, but nobody had looked at the X-ray. So it was a large patch of consolidation in the right lung. He came to us in shock, needed HFNC, responded to Piptas, Clarithrol, Tamiflu, and could be saved. So take-home message is pneumonia can present in different settings as a critical illness requiring ICU admission. Pneumonia in pregnancy poses a threat to maternal and fetal survival. MDR organisms make WAP management challenging. The antibiotic choice changes from empirical in CAP to culture sensitivity directed in WAP. And of course, the ICU team effort where we as a family, the chest physicians, the intensivists, the trained chest physiotherapists, dedicated nursing and paramedical staff will play a crucial role in survival. Thank you very much.
Yeah. So, sir, in the initial few cases, we saw that in community-acquired pneumonia, we are not exactly looking to isolate the organism. In which cases, in patients who are starting as community-acquired pneumonia, would you switch over to trying to find the organism and not just treat with empirical antibiotics?
Those who are community acquired on the background of a immunocompromised state, like suppose you have a known HIV positive coming with a community acquired pneumonia, invariably it will turn out to be PCP. Like I had one where there was one 450 CD4 count, but she was not responding. Ultimately, we had to put her on, and then the PCP came positive and the CD4 count was 124. And see, when they are on ventilator, you don't get the history, but then she had stopped the ART for 3 weeks. So these are the settings. And a diabetic patients, when you see a cavitating pneumonia, these are the conditions where you start empirically, you have to start, but then you would be after the microbiologist. And there was one good system which we used to follow in MICU, that Geeta Nataraj used to send her lecturer on microbiology rounds on Mondays and Thursdays, and that really helps because you get a phone call telling what organism is growing, and rather than waiting for the next day, you can immediately make alterations.
So one more question, is there, we saw some studies from the Western world where we have the most common organisms which are involved in community-acquired pneumonia, and you showed 2 studies from India. Is there any study from India which to guide local antibiotic treatment, empirical antibiotic treatment?
Use your own
antibiogram.
See, mostly as you have seen, most of the community-acquired pneumonia occurring on a reasonable healthy background will respond well to either coamoxiclav or ceftriaxone or that combination with macrolide. It's only when they come from a private setting, have central lines, and most of the studies for antibiotic would depend upon the local area geographic prevalence also. Like you saw somebody somewhere where you had MDR, GNBs occurring and CAP.
Thank you.
Regarding antifungal, role of any antifungal in this?
You have to keep antifungal in mind. I didn't cover that, there's no time, but if you have somebody who like a patient of SLE or all these rheumatological patients who now they take that tofacitinib,
Yes.
a very dangerous drug. There's one rheumatologist here.
So I myself is practicing
See, you are
rheumatology.
using tofacitinib left, right, and center. I don't know whether the RA is so severe that you have to use, but then you can have the immune system going haywire.
Yes.
So I mean, you should use it, but on the background, you should have good communication with the patient to report back to you immediately if there is fever. I'm not very comfortable with that drug.
Yes, we rarely use.
Others, of course, you need in severe RA or something as a disease-changing drug. But for those borderline cases, when you use this is a time where you have to think of, you've used that and then they've come to me with bilateral shadows like that. I have to think of pneumonias. Unfortunately, microbiology support for pneumonia is not good in most of the public hospitals.
Yes.
Because you need bactec cultures. Those bactec bottles itself can cost up to 3,000 to 4,000 rupees.
So should we start with antifungal in these cases like over time?
Take a clinic, like suppose they have hypotension, I would start.
Okay, thank you, sir.
What is your take on practical use of See, when you have most of those cases were hypotension shock. Okay, that one pregnant lady I showed came positive. See, my take is this way: in BMC, it is free. It's a reasonably safe drug. I have no time to wait for the throat swab to come positive because though we are doing it free, it will go to Kasturba and it comes back in 2 to 3 days. So I put the patients on for a CAP which is needing ICU care. I put them on. Suppose some other organism goes or he's rapidly responding, you can always stop it in 4 to 5 days.
ICU basically. You
ICU.
feel ICU. Sir, and what is your favorite cocktail for VAP when we don't have an organism?
I think coamoxiclav with azithromycin is good enough. Or you can have ceftriaxone with a sulbactam combination. Need not go higher.
Thank you.
We thank Karnik sir and madam for the
We
moment.
now request our chairpersons to facilitate Dr. Karnik sir. We now request Dr. Santosh Salagre sir to kindly felicitate our chairpersons, Dr. Amita Thawle madam. We now request Dr. Kavita Joshi ma'am to felicitate Dr. Jairaj Nair sir. Yeah, Kavita.
And the legacy of whatever is happening is now continued by Nitin. So we should also clap for Nitin.
So now moving on to our next session, where the topic of discussion will be goal-directed nutrition in critically ill patients. For this, I would like to invite Dr. Vishal Gupta sir and Karnik sir as our chair people. And Dr. Sanjeet Sashidharan sir as our speaker.
It gives me great pleasure to welcome Dr. Sanjeev. He's a very big name in critical care. Uh, he is a director of critical care, co-founder and director of True Peak Health. Uh, he is in Raheja Hospital as a intensivist and associated uh, Fortis. He's got a huge amount of publications and he's won lot of awards at the national stage. So Sanjit, over to you.
Thank you very much, sir. We are all fans of you. You must remember that. Huh? Well, I've been called to talk on a topic which is really always a back topic. Nobody thinks about critical care nutrition, but this is something that's very close to my heart, and been doing this for a while. Is there a clicker? Is there a slide clicker by any chance? Huh? Keyboard. Okay. All right. So I'm here to talk about critical care nutrition, and if you look at nutrition per se, it's definitely something that we don't take as number one when it comes to intensive care. And there is so much of goal-directed therapies happening all across. If you look at echo, there's goal-directed echo, there's sepsis, there is what to do with sepsis is an early goal-directed therapy. There is goal-directed focus. There is everything that is goal-directed. And I always feel that nutrition is something that is never goal-directed. And in my opinion, there are certain goals that we have to have when we have nutrition. And that's why the entire talk is based on goal-directed nutrition. The first thing would be to actually provide optimum energy. The second thing would be to actually encourage anabolism. I mean, I can give numerous examples where people don't really pick on weight, and in fact, they keep losing weight, and that's what anabolism is all about. I have one patient of mine over here actually who lost maybe almost 28 kilos. 22 kilos. I mean, encourage anabolism is something that we need to do as goal-directed therapy over here. The other thing is to ensure safety of delivery. They have safety of delivery. And the last thing is to improve overall outcomes. So if I would put the goal in a nutshell, it is optimum energy, anabolism, safety, and actually to improve overall outcomes. That's when it becomes really goal-directed. Well, let's look at how to provide optimum energy. Okay, so what is that? Let's take an example. You have a patient who gets admitted with a subdural hematoma after a road traffic accident. He is operated for a traumatic brain injury. I've been from Sion Hospital, so I know how quickly this is done. So that's what happens on day 0. On day 3, we can weaned off this patient from the ventilator, a regular case of trauma. He is E4, M6, V5, and then subsequently at day 7, he's made to walk and he's actually shifted out of ICU. Now, this is a very simple thing to do, and if you look at any guideline across the board, it will tell us to start at 30% of the resting energy expenditure, 25 to 30%, go up to 50% of the resting energy expenditure, and then finally go to 70% of the resting energy expenditure. This is what the optimum energy is, what is said to be done in the intensive care unit. But our patients are not like this. Our patients are definitely like this. All the cases that Dr. Karnik said, none of them were actually like this. All of them had courses that were really winding. Let's take the example of an ideal case that happens. This was not ideal. This ideal case is something like this. On day 0, you have road traffic with traumatic brain injury, resuscitation, emergency surgery, pyrexia, normal BP, tracheostomy, weaned off, stable BP, sepsis, low BP, VAP. Everything comes in together, and then this patient gets transferred after day 24, like so many of these patients that Dr. Karnik said. So it's a long, winding course that occurs. It's not a straight course. And that's why to figure out what is optimum is actually not so simple as what I told you earlier. So let's see what's optimum. So there has been a study done by Oren Zusman. I was in this unit a while ago in Israel, where we did this, and I was working with this great man. So what happened over here is that when he actually looked at all the data together, he found that giving very low energy and giving high energy was a problem. When I say energy, it's kilocalories, okay? So what he found was there is a sweet spot. And that sweet spot seems to be 70% of the resting energy expenditure. 70% of the RE seems to be the sweet spot in critically ill, mechanically ventilated patients. Now, if you go back to the study and figure out what's happening, there are 77 of their candidates, 77% of their patients in which they did this had an Apache score of 22 and they were on vasopressors. Now this group becomes very small. This is the only group where 70% of the resting energy might work and might not do harm. Okay, this is that group where vasopressors were used and where the Apache scores were above 22. What we can say for certain from studies in the past is the fact that no additional benefit is there if you were to feed them more than 100%. If you feed them more than 100% of resting energy expenditure, these people are not going to do well. That is for certain. So what is the right number that we have to give? And to understand that, there was this beautiful trial that was done in the US called the INTACT trial. Now this trial is a very phenomenal trial, I feel, because of the fact they looked at 200 sick acute lung injury patients. They looked at sick acute lung injury patients, and in one category of patients, they did absolutely what you're supposed to do. They started the patient at 24 hours with early, slow nutrition, and they graduated up by 3 to 7 days, and at 7 days, they got what they had to do. This is what was IMNT. And the other one was the standard nutritional support, which was not really guided by any kind of protocol. Okay, so they did something like this. So they did everything that was there in the guideline versus they did whatever the physician wanted to do. So this is what they did. Now, what they found was the trial was stopped at 78. They actually wanted to enroll 200, but the trial stopped at 78. Now, the question was why they stopped it. They stopped it because patients died. And if you ask me, and you look at the groups as to which patients died, it was surprising to note that it was the ones in which guideline-directed therapy was used, where the patients actually died. So this was a real eye-opener for everyone across the globe, saying that if you did guideline-directed therapy, these patients really don't survive. 40% versus 16% is really, really significant. This is what happened. And when you looked at the data very clearly, what it said was those people who died, they received more than 18 kilocalories per kilogram. So anyone who got more than 18 kilocalories per kilogram in the first week of critical illness, they had poor outcomes. That's very, very clear. They had very, very poor outcomes. So if you know what's the higher limit, you don't have to go above 18 kilocalories per kilogram. That is clear from this study. What is the lower limit? What is the lower limit? You have a high, you also have to have a lower limit. So what is the lower limit? So to find that, you have to go back almost 16 years ago. There was the Eden Omega trial, a beautiful trial that was done, a trial that actually threw out Omega Wen from the ICUs. So this Eden Omega trial came in ARDS, and what they found was, even if you give them trophic feeds, small amount of feeds in the first couple of days, these patients do as well as those patients who are fed 70% of guideline directed. So we know for certain, giving them a small amount trophically is better than not feeding at all. This is what this particular trial tells us. And when you read between the lines in that trial, the number that you get is 10 to 13 kilocalories per kilogram. So this seems to be safe in the first 5 to 7 days. This is very important for us to understand. 10 to 13 kilocalories per kilogram is a small amount. It can be got even with your propofol infusions. Okay, that's how that's the amount that you look at. And this was replicated again. If this was the only trial, no, it's not. There were many trials that came in, and this is Yasin Arabi's trial from Saudi, phenomenal trial, which actually said 40 to 60% was equivalent to 70 to 100%. That means you can go low to begin with. Don't feed your patients excessively. Overfeeding kills. Well, so this means to say, in the hyperacute, if I give you some numbers, in the hyperacute phase, okay, and the acute phase, you'll probably give 18 kilocalories per kilogram, not more than that, and definitely more than 10 kilocalories per kilogram. This is what it is when you want to make it really precise, followed by 70% of the resting energy expenditure. So if I put this in a graph and tell you what it should be, so 20 to 30% when the patient comes in a hyperacute phase, start 20 to 30% of the REE. Then as you progress further, go to 30 to 50% of the REE. And finally, when he gets out of the ICU, reaches at 70% of REE. This is probably what it should be by all the data if you put them together into evidence-based medicine and tell you the numbers. But then what's important here? The important thing is lesser is better. And most importantly, it is the resting energy expenditure. Now, if I would ask somebody from here, how do you calculate REE? What is the answer here? You would say, let us take it as 25 kilocalorie per kilogram or 20 kilocalorie per kilogram. Remember this, there's something very important I must tell you. You can't do resting energy expenditure without understanding how to measure it. And how do you measure it? You measure it by using something called as indirect calorimetry. This is very important, and it's something that is underused across the country. Indirect calorimetry is a device with which you can get the actual energy expenditure of your patients that are lying inside the intensive care unit. Let me give you an example of a patient. Okay, this is a patient that was admitted into the hospital, very cachectic. She had some psychiatric disorder because of which she was not eating her food and she'd become very thin. And then she came into the intensive care unit for a community-acquired pneumonia. This is the patient that comes in and went on a ventilator. Now, there was almost 5 or 6 days, almost 10 days, patient is not coming off the ventilator. It is just not possible. And we thought she's cachexic. We took a body weight and we gave her 25 kilocalorie per kilogram. So what happened was we had 3 attempts at failed weaning attempts. So whenever we have a failed weaning attempt, either we are not good at doing weaning, or our time to weaning was not right, or something is really wrong with the way we are doing stuff. So we did everything that was right when it comes to mechanical ventilation, and still the patient wasn't really weaning off. So then what do? We actually went back and looked at the indirect calorimeter reading. And what we found was the calories that we were providing was way higher than what was actually required. So we dropped down the calories, and voila, within 2 or 3 days, this patient actually came off the ventilator. I mean, this is amazing, actually. This is what happened. This patient came off the ventilator, and this patient was successfully extubated, clearly indicating that overfeeding creates a problem over here, and that's the reason that you should be concentrating on the exact requirements. And that's why personalizing nutrition is actually the mantra whenever you look at it. Well, let me explain to you something further. Does anybody know this study? This is the best study, and this can never be replicated. Entire world can never replicate this. This was a study where 32 civilians in World War were actually starved. They were actually starved. These people were starved because they wanted to see how much is required when they come off the ICU. So they did 32 civilians in the World War. 12 weeks they were given an adequate diet, and 24 weeks they were given a semi-starvation diet. And see, the semi-starvation diet is 1,500 kilocalories. I think that's what we give to almost all our patients in the intensive care unit. So 1,570 calories was the semi-starvation diet for 24 weeks. And then subsequently for the next 12 weeks, they were made to eat into 4 groups. What are the 4 groups? The first group received 1,930 to the 4th group that received 2,940. That means they were given graded calories. And they gave graded calories. Dr. Keyes is a very, very phenomenal investigator. He was at that time. He came up and he spoke about why and how much you require to rehabilitate these patients. And frankly, to rehabilitate these patients, he found out from his data that comes over here that you might require something even higher than 4,000 kilocalories. If you want to rehabilitate and get them to be anabolic, you need to have somewhere around 4,000 kilocalories, which is a huge, huge amount of kilocalories that you require over here. And that's what this particular data tells us. Semi-starvation, controlled rehabilitation, and eat to gain ad libitum. If you want to eat to gain, you have to have higher calories for certain. And this came replicated again and again in number of studies after that. So these are the list of studies that was done right up to 2000, where they said you should be having much, much higher calories when you're rehabilitating. And COVID gave us more answers. In COVID, they did a similar study like this, and they found that when you're rehabilitating, your requirements on the 3rd week may go up to 30.4 kilocalorie per kilogram just at the time of removal of discharge from the discharge. Now, Planck is another phenomenal investigator. Lindsay Planck is from New Zealand, and this study was done way back. And what she found was something very similar. 1.7-fold above the RE, that is 47 kilocalorie per kilogram, would be what you will do when you're getting this patient out of the intensive care in order to build up their muscles. And if you're younger, it may be even 59 kilocalorie per kilogram. It's a huge amount, 125% to 150% of the resting energy expenditure. So the point is, follow the resting energy expenditure. The only way you can do that is by doing indirect calorimetry. The closest possible would be Mifflin St. Joe this. But anyways, you go from 20 to 50 to 70, and then go higher, 125 to 150%. If you want your patient to go home, lift up their grandchild and walk with them to the grocer's shop. If you want to get that done in the next 3 months, you need to concentrate on feeding and not on antibiotics. It has to be done this way. We all sitting in this room don't want our patient to just get out of the ICU. We want them to go out, go home, take the remote in their hand, switch on a channel. Remember, this 50% of your people who go home can't even do this. Okay, it's very important that you understand that you get this nutrition in your minds. So what about proteins? Now let me tell you one study that we did. We had 62 mechanically ventilated patients. This is a very beautiful study, 62 mechanically ventilated patients, and we looked at 7 days. And we thought we did great nutrition because we do indirect calorimetry and the works. We did everything that was right. We followed 3-methylhistidine to understand how much to give proteins. We looked at the calories. We looked at monitoring. We looked at everything. And we followed them for 7 days, and we did ultrasounds. We did ultrasounds of the rectus femoris, and this is how you follow up muscle mass. You do ultrasounds of the rectus femoris. It's called the US Valid technique, where you look at the rectus femoris, the gastrocnemius, the vastus lateralis, and the vastus medialis. We looked at rectus femoris, and we started looking at the muscle size. And what we found was something very, very, very surprising. We found 0.5 centimeters of muscle loss was found in a single muscle, and almost 3 kg muscle loss within 7 days of mechanically ventilated critically ill patients. So you can't prevent catabolism. That is very certain. You can't prevent catabolism. And that is the reason don't go overboard in feeding your patients in such a way that they have the problems of feeding. Don't do that. You can't prevent catabolism. That is very clear. These patients are going to go down. You are going to try to prevent them from going as much down as it is possible. Okay. Well, this is something very important. And not only that, what we also did was we actually did their biopsy to see what is happening. So we also found that the quality of the muscle also goes down. So A, the size of the muscle is going down. B, the quality of the muscle is going down. You see the quality of the muscle also going down. When the quality of muscle is going down, it's really, really bad. It's really bad. The quality of muscle is going down. The quality of muscle is going down. And that was mirroring the number of organ failures. That was mirroring the number of organ failures. That means if your muscle size goes down, your muscle quality goes down, your organ failures are also going down at the same time. What we know is higher the proteins, lesser the loss of muscle mass, more the protein synthesis, and lesser the morbidity. So for certain, we need higher proteins. Okay, but how low is low? How low can we go? The question is, how low can we go? Well, it appears, at least from dissecting all the evidence that is there in industry, is 0.8 gram per kilogram in the first week. More than that, if you go, it portended higher mortality as compared to 0.8 to 1.2 gram per kilogram. That means you can't give less than 0.8 gram per kilogram. Now, from where does this study come? This is a large database, 455 critically ill patients. The whole population was a whole sick group of individuals. Upper chest was of 22. They were done throughout for 5 years. Looked at all of this data together, surgical, medical, all of these people put together, and they looked at two categories of people. One who got low proteins less than 0.8 gram per in the first 3 days, and the intermediate variety and the high variety. Looked at all of them. And what they found, if you gave them less than 0.8 gram per kilogram versus if you get them more than 0.8 gram per kilogram, the mortality changed. In fact, if you feed them less than 0.8 gram per kilogram, they survive lesser. Now we talk of antibiotics. We talk of so many other things that are there in the background that we talk about. We talk about resuscitation. We talk of so many other things. We should talk during our rounds even about proteins. It's very important. So if you go less than 0.8 gram per kilogram, they survive lesser. It's very important for us to understand. So that means to say, in the first couple of 1 or 2 or 2, 3 days, do not feed too much. Do not feed too much. Okay. And once you reach beyond the 4 days, you get the kind of the best outcome. So if I now put this into the same graph that I showed you, up to 2 to 3 ICU days, let them be somewhere at 0.8 gram per kilogram. Then after that, you increase it in the intermediate phase to around 0.9 to 1.2 grams per kilogram. And then from 7th day onwards, you go to 1.3 to 1.5 grams per kilogram. This is a large amount. This is not possible with kitchen diet. It is really not possible with kitchen diet. How much of a paneer or how much of a chicken you have, you're not going to reach 1.5 gram per kilogram. It is just impossible to do so. And that is the reason that you need to have formula-based nutrition when it comes into rehabilitation of these particular patients. You may manage a kitchen diet if you are in the intensive care in the wards, but when you're rehabilitating, it is really not possible. In fact, the study that came out of oral nutrition supplement is from KEM Hospital, which actually said, if you go to Dr. Reddy, Ravindra Reddy and the group over here, they did a database, which is very, very good database, actually says only when you give them ONS supplements after for at least 6 months, they actually put on their muscle mass. This is a very important data that came out from here. But here again, if you notice, the answer is lesser is better. Lesser is better. You start low, because what everyone feels is let's give high, let's give high, let's give high. Again, you can't give high. That's also very clear. You can't go high, very, very high. So post ICU, we have to go to 1.5 to 2.5 gram per kilogram of protein. So this is how you would actually provide optimum energy. The other question is, how do you encourage anabolism? We just talked about the fact that it's so difficult to get anabolic, We should at least try to encourage anabolism. Somehow we should get that muscle mass to go up. And this idea of encouraging anabolism actually comes from Burns research. In Burns research, when you look at a drug called as propranolol, which you all know as a beta blocker, it's a phenomenal drug that drops the sympathetics. So once it drops the sympathetics, it actually causes some change in the metabolism that thus causes the resting energy expenditure to actually come down. So in short, if you were to cut down the sympathetics a little bit, you may prevent the gross catabolism that is occurring in our ICU patients. So this is what they've seen in Burns research. What happens is when you go down slowly and steadily, when you go down, we start propranolol, the heart rate goes down. There is a change in the fat-free mass, and the amount of resting energy expenditure actually goes down. So it dropped the RE by a good 300 kilocalories. Okay, this means to say that you may not need to eat so much after you start propranolol, and that might prevent the anabolism, is what it looks like. Well, this is in burn centers across the world, but there are other drugs also. Okay, there are other drugs. There's oxandrolone, which is a banned steroid. If you want to have oxandrolone, it's a banned drug in the country as of now, but it doesn't do any problem per se. It is an anabolic steroid, does not cause any kind of immunosuppression, does not do anything at all. If you go to the average gym in the vicinity, you will find half of those people on oxandrolone. Okay, it is something that is freely available in the gray market. A drug that is very simple to use, does not cause side effects, no sugars, nothing like that. A drug that will probably work phenomenally well. And testosterone, a simple drug, isn't it? Testosterone is something that you can give, it's available. View the testosterone levels, if it's low, give them the testosterone. It's important to give that because it encourages anabolism. There are 3 new kids on the block which are there already, which I am using, but you might have gone to the gyms and you would have seen people jogging in creatine and HMB. These are things that is going on all across the world. Yes, it is something that does cause anabolism. It is something that is helping. There are a lot of studies saying that HMB, creatinine, and BCAA would actually improve anabolism. But remember this, it is not by eating that Arnold Schwarzenegger became so big. Okay, he became big, he was exercising also. So that is the reason that if you're going to do any of these things, you need to have a good rehabilitation program where there is strength-based and resistance-based training. So if you are going to shift your patients from the intensive care to the wards, this should be a prescription of a designer protein along with the presence of a rehabilitative exercise which is strength-based, not just walking on a treadmill, or resistance-based. These are the things that is required to an extent that the Duke University, which is one of the forerunners when it comes to critical care nutrition, they've started doing resistance-based exercises right in the intensive care unit. Right from the time they're in the intensive care unit, we've started adopting that at Rayajas. And as of now, we are actually moving our patients on the ventilator. Nikhil, you might be seeing that. We have patients sitting on the ventilator down on the with the ventilator, and they are doing exercises so that we improve the resistance-based muscle buildup. So 75% of burn centers across America uses oxandrolone. 75% across. It is not banned in the United States. I don't understand why it's banned in our country. It is used across the board when it comes to United States. And if you look at the data of all those burn centers, all of them are using 20 milligram per day for 4 to 24 weeks. This is what they are using over there. And am I using it? Yes, I am using it, but it's not in the hospital. After the patient gets out of the hospital, we do put them on oxandrolone because in the hospital, of course, my CEO will throw me out of the job if I do that. What does it do? It actually increases median grip strength. Okay, this is what it does. It increases median grip strength. We all were born to actually pick up things. That's why the grip strength becomes very important for all of us. Right from the time we went from being monkeys to become Homo sapiens to become up, the first thing we did was we held on to things. That's why as you grow older, your grip strength matters. So if you're going to climb a staircase, get down a staircase, you'll see old people holding something. That's why your grip is very, very important. So it improved that important marker. It improved median grip strength. There were fewer hours on the mechanical ventilation when they actually used this drug. There was shorter length of ICU stay, shorter length of hospital stay, and better ICU mobility score on discharge. So this is something that oxandrolone did to all their patients, most of their patients that were admitted for burns. Well, HMB, creatine, BCAA, there are so much data that has come out in the recent past that now we have a lot of companies that are actually using HMB in their formula products. So you will have many companies now at this given moment. If you open the tin that they have HMB that have incorporated in it. I doubt the validity or the bioavailability of the HMB that is being supplied because of the fact that it is a very expensive molecule and you really can't put it into that if you're going to hydrolyze it, make it a hydrolyzate. I don't understand how they can do that. And I've just embarked on a study which will probably throw me back with my sponsors because I've started a HPLC study on HMB and on all things that are there in the market. So let's see what we do with that. Okay, but there is definite role to encourage anabolism when it comes with all of these particular medicines that we have. Oxandrolone, testosterone, HMB, creatinine, BCAA, new kids on the block, but I think they are going to do well. Apart from these things, which are very simple to do. Okay, raise the vitamin D up, keep the PUFA up, phosphatidic acid, arginine, and ATP. These are things that are available now, and these can be also will encourage anabolism. The next thing we want to do is have a safe prescription. That's very important when you're actually in nutrition. We just can't do anything that is wrong. And that is the reason the safe prescription will involve safe preparation, procurement, labeling, and dispensing. These are the things that has to be done. And this is very, very important to do. At the same time, there has to be a safe administration And at the same time, there has to be monitoring and assessment for complication. And this can't be said more when it comes to total parenteral nutrition. When it comes to TPN, the biggest problem that we all face is the fact that they have problems when it comes to preparation, handling, and they end up with an infection, and that's where the problems come in. And that's the reason that when you're handling TPN, you have to be very, very clearly to make it as safe and optimally as it is possible to prevent a complication, to prevent an infection, and to ensure that metabolism remains stable. So strict aseptic precautions, keep trophic feeds on. Do not, even if you're on PN, keep the trophic feeds on. It will help the gut. Okay, it is important to keep it on. Reduce duration of central PN and a TPN. It's very important to do that. Apart from that, how do you prevent complications? It's very simple. The metabolic complications depend completely on the prescription. So the prescription is important: the dose, the duration, the rate, and the maximum volume. These are the 4 things that are required to actually get your TPN prescription right. And this is the entire story. The story is give them a rate of 0.25 gram per kilogram, amino acid at 0.1 gram per kilogram per hour, a fat of 0.5 kilogram per hour, dose of 4.52 to 2.5, 0.7 and 1.5. If you were to get this in place, which are easily available as Excel sheets on various platforms, you will know that you are in the right space. This is what the amino acids are. This is what the fats are. This is what the glucose are. We are certain that metabolic complications will not occur. Since we don't know this, and we just put an 80 ml per hour or 70 ml per hour or 100 ml per hour, that's when we start developing metabolic complications. So it's important to actually know this per se. So in short, these patients of TPN will require excellent glucose control. Remember this, you are putting the entire dextrose into the vein. Since you're putting the entire dextrose into the vein, there is going to be glucose fluctuations. So it's important that you maintain the glucose in the recommended 150 to 200 range so that there is no more infections that are coming in. There are going to be electrolyte abnormalities of which you have sodium and potassium related problems. You have to ensure that you monitor the electrolytes on a regular basis. The line side, very important to go besides the patient and check the line. Checking the line is so important because that's what prevents an infection. You have to look for pain in abdomen. And why would you do that? You would do that in order to figure out aseptic cholecystitis. This is something you like to figure out when you look at for pain in abdomen and when they are in long-term TPN. The fluid balance, because you're going to give now fluids in, so the fluid balance becomes important. And for a long term, you'll require CBC, LFT, and coagulation on a regular basis. And you must remember there's something called refeeding syndrome. Many of these patients who come into the ICU will be getting TPN on a background of having low phosphorus, electrolyte abnormalities, and suddenly the patient worsens. The worsening is thought to be something that is very different, but it's 90% of the time I feel it's refeeding syndrome, which we kind of undertreat, we under pick up, and that's the very, very, very big problem when it comes to TPN. And that's the reason that for goal-directed nutrition in critically ill patients, now we know how to provide optimum energy, how do you encourage anabolism, how to ensure safety of the delivery, and something that will improve overall outcomes. Thank you very much. And there are resources over here. And just before I wind up, there is a conference of mine coming up on 30th of November, which is called the Clinical Nutrition Bootcamp. Please try to attend that conference. It's a lot of information that comes in from there, which is cutting edge. Thank you very much.
For that excellent review of the nutrition, much neglected area, I'll say, more so in our public hospitals. Definitely, your lecture will give a good insight, and I'll encourage students to go and attend your bootcamp. Thank you so much. If audience have any questions on nutrition,
are there any questions in the audience for Dr. Sanjeet sir?
Yeah, just one question. Okay. See, the studies which are done abroad deal with people who have a background good nutrition score.
Correct.
Okay. Compared to that, say in our public institutions, we may have people who are at the lower end of the nutritional scale. So would studies in those people match with those of foreign studies?
So in fact, my observation from my studies were such that in fact we worsen faster than them. You're right, their metabolism is different, their muscle quality is different. In fact, I'm doing something called intramuscular adipose tissue content now in most of our patients. It is very different from what is there in the United States. So all the more reason that we should be much more judicious in doing what we are doing, because it's worse in our country.
Yeah, just about our critical patients who are on the ventilator. So considering that calories we have to hold on, so what we do is your trophic feeding, and to add it, to top it, to get that, you know, zero 0.8 gram per kg. So should we be giving this omega-1, dipeptidyl-1, all these kinds of
So
preparations?
0.8 gram per kilogram can be easily done through your kitchen diet also.
Regular,
if it's in a KM hospital or
RT
from a
feeds.
formula feeds. You don't require anything for 0.8 gram per kilogram. The real magic of nutrition comes after the patient gets out of the intensive care unit. The first time in the intensive care unit is actually to prevent complications. So you try to feed them lesser and lesser and lesser, but once they start getting better, coming off supports, getting going to the other way, that's when you actually start going up. That's more difficult to get 1 and 1.5 gram per kilogram. That's where it gets difficult per se. You don't need to add any modular feeds in the start of your intensive care journey. No.
For 7 days, yeah.
Yeah, for 7 days. No.
Thank you.
So I understood from your talk that the initial 3 to 5 days, giving more may not cause any benefit. But can you tell me the physiological basis of why it would cause harm?
Correct. Correct. So, you know, what happens is when you are actually in intensive care unit and you are in a critical illness, there is something called as autophagy. Now, what is known physiologically is autophagy is the mechanism that is like a housekeeping mechanism for your body that takes care of what is wrong in the body, in simple. Now, what happens is the moment you overfeed them, it switches off this autophagy. Once it switches off the autophagy, that housekeeping system is stopped and it takes a very, very long time to come back. And that is one of the reasons that you don't want to do that. The second thing is, remember this, whenever you are in intensive care or whenever anybody is coming on to stand over here and talk, there is going to be an endogenous glucose production. Any stressful person has an endogenous glucose production that happens to whenever they are admitted into the intensive care unit. That endogenous glucose production is very sufficient enough to actually tide that phase. God has created a phenomenal mechanism in our body. I don't think we should interfere with that for a couple of days. Okay, that flight and fight response that we have in our body creates endogenous glucose. Now you add up anything on further of that, that is going to become overfeeding. Remember, this liver is not working well. Whatever you're giving gets converted into fat. It becomes inflammatory. Fat is inflammatory, and that causes more amount of problems. And that is the reason that what is not required is not supposed to be given.
Do inotropes worsen the catabolism?
Yeah, so inotropes per se indicates that these patients are definitely very, very sick. There is no doubt about it. Sickness worsens catabolism. There is no doubt about it. But if you ask me, when can we start feeding regularly? Less than 0.3 microgram per kilogram is like the benchmark when we try that once you reach, that above, lower than that level, there is no problem to start feeds at all. So it's a very good question whether tetanus or these are high catabolic states. I thought COVID was a hyper metabolic state. COVID is very similar to that. We always thought COVID was hyper metabolic till I didn't show you the study, but I've got one of the largest studies in COVID actually looks at indirect calorimetry in ICU. And what looks at that is very surprising. These patients now, they go into first a hypometabolic phase. They actually start conserving. They start conserving energy. All of these cases, this is what I'm figuring out. In fact, when we are monitoring indirect calorimetry in our sicker patients, the more sicker they are, the lesser is their RE, the lesser. I mean, they are at 200 and 300 kilocalories. So I would not be surprised. I don't have so many tetanus like how KEM has. I mean, I would have seen maybe 3 or 4 cases in my entire journey in private. Okay, but in those cases also, whatever I've monitored, I found out in the first couple of days, the energy requirements are drastically low, almost less than 500 for at least 7 days. Then after that, it might start climbing up. And that is a phase when endogenous glucose production stops, most probably when the RE starts climbing up. Correct. So there is a huge relationship when it comes to insulin resistance muscle loss. You will notice that in fact my study has a subset which actually talks about those patients who required higher doses than 30 units in a day, and those patients are actually losing more muscle. So is cause and effect, I'm not aware, but we know for certain that those patients who have more insulin requirements, they lose more. And so you mean to say if you don't have indirect calorimetry? Okay. So on the evidence-based perspective to understand resting energy expenditure, the first thing would be to do indirect calorimetry. I would say that. The second thing over here would be to use something called as bioelectrical impedance analysis. It's a device that is lesser expensive. You might go to the gym, you stand on it and you get a body composition. So that body composition actually you can look at, and there is an equation called as a Cunningham equation which you can use to actually get the resting energy expenditure. That is closer. The third that is closer to that is ventilator VCO2. So your ventilators now give something called VCO2. So you take the VCO2 and multiply it by 8.14, and that will be more closer to your energy expenditure. And then if you don't even get that through, then you can go to a simple predictive equation in the intensive care unit, which is 25 kilocalorie per kilogram, keeping the guardrails in mind, which I said start at 25, go to 50, then go to 70%. Of that 25 kilocalorie per kilogram, the catch is how to get that per kilogram. The catch is there. So to per kilogram, you can't weigh your patients in the intensive care unit unless you have bags or you have harnesses that lift the patient and gets weight. So again, that becomes an approximation. So that's why I said, don't, if you want to become precise, use indirect calorimetry or BI, and if you don't want to be precise, feed them less.
We'll end the session because it was such an interesting one. So everybody had a question on that. Thank you so much, Dr. Sridharan, for that nice lecture.
I would now request Dr. Karnik sir and Vishal sir to come and felicitate our speaker, Dr. Sanjeet sir. So moving on to our next session, the topic is acute fulminant hepatic failure and liver transplant. With this, I would like to invite Dr. Mrudal Dharod on the stage.
We are pleased to invite Dr. Dharod for getting lecture. He is a consultant Department of Hepatology at Saracen Reliance Foundation Hospital. He was earlier designated consultant gastroenterologist at Wokhad Hospital. Welcome, Dr. Dharod.
I speak in this way. Good morning, everyone. So I'm Dr. Mrudal. I am at HN Reliance and I work in the liver as well as the ICU team as the assistant director. So my talk for today is acute fulminant liver failure and liver transplant. What exactly is acute liver failure? So we have acute liver failure, acute and chronic liver failure, and the cirrhosis of chronic liver failure. So when I define the term acute liver failure, it is for someone who probably had normal liver till some point of time just in the recent past and has now developed liver dysfunction in terms of coagulopathy, jaundice, encephalopathy in different combination. So the talk for today, the agenda would be introduction, etiology, how the ALF develops, what are the presentations, investigations that we need to do whenever someone presents to us as the case of ALF, what are the prognostic criteria, how do we manage these patients in the ICU, the role of liver transplantation, and the overall prognosis. So this is a typical acute liver failure. I need two important things. In a patient, there has to be some element of coagulopathy as well as encephalopathy. Historically, this has been defined as INR more than 1.5 and encephalopathy which has to be at least grade 2, grade 3, grade 4. And there should be no evidence of any cirrhosis or a prior liver disease. The duration onset of symptoms and the manifestation of this complication should be less than 26 weeks. Anything beyond that, we generally call it as a chronic liver disease. However, there have been various definitions over a period of time. We will see what are the classifications. So when someone says fulminant, acute, hyperacute, sometimes it is a bit confusing. So for me, anything with a symptom onset, whether it was like a prodrome and now has presented with jaundice and encephalopathy, if the symptom duration is like within 1 month, I will call it as an acute liver failure. If the symptom onset is less than 7 days, it is hyperacute liver failure. Anything beyond 1 month, we call it as a subacute liver failure. And beyond 6 months, it is generally a cirrhosis. Now, literature mentions multiple causes of liver failure. It can be viruses like hepatitis A, E, rarely hepatitis B, vascular causes like Budd-Chiari or a hypoxic ischemic hepatitis, drugs, paracetamol, which is not so common in India, but TB drugs or other daily is common in India. Rare cases like Wilson's presenting as an acute liver failure, though we would assume that they have a chronic liver disease underlying, and it is just presented the first time as a ALF. Pregnancy causes like HELP syndrome or a fatty liver, rarely autoimmune, and in some cases, infiltrative diseases like lymphoma, melanoma, TB can present as ALF.
So there were no symptoms till few days back. Patient develops symptoms, gets evaluated, finds there's a significant jaundice, presents to some local hospital, gets referred to you, and you find the patient having coagulopathy and encephalopathy. All these can be found in all these causes. Now these are the sub-classifications. So the initial was, if you ALF, liver transplantation, we all remember about King's College criteria. So this was by the classical O'Grady et al., Roger Williams from King's College. So this is what they defined. First 2 weeks as hyperacute, then maybe up to 12 weeks as acute. Subsequent different definitions have been there, but simple. First 7 days hyperacute, up to 4 weeks acute, anything beyond subacute, and then cirrhosis. This is important because we want to prognosticate this patient. What we have seen is patients who present as hyperacute liver failure have the highest chance of survival without a liver transplant. The liver has got necrosed fast, but there's a good chance of regeneration. On the other hand, someone who is in a subacute liver failure, there has been onset of jaundice prodrome 4 weeks back, 6 weeks back, and is now developing encephalopathy. I'm extremely worried about this patient because the liver had a chance to regenerate and still did not regenerate. If someone goes into encephalopathy in the 4th and 6th weeks, there is a very higher chance that this patient will never recover without a liver transplant. And I really want to get a transplant done in this patient as soon as feasible. Now, a very busy chart. We have the various pathophysiologies, the various causes of the liver failure at the top. How do they cause the liver failure, and what are the manifestations of the liver failure? So, just for some common causes that we see, commonly I see is hepatitis A and E in India. Sometimes yellow phosphorus poisoning. Many times it is just a cryptogenic. We just don't find a cause. Rarely it will be herpes simplex virus or cytomegalovirus. Wilson's very rare. AIH usually will present as subacute hepatitis, presents to you in the OPD, enzymes 200, 300. Very rarely they would present as ALF. And acetaminophen, we do not see commonly in India as a suicidal intent. But yes, someone who's elderly has been taking paracetamol as a lone drug or in combination with tramadol for pretty long duration as a painkiller, then the cumulative dose can they present as acute liver failure. Acute liver failure. So first thing that happens is a cell death. Whenever the cell death will happen, the enzymes will go up. So SGOT, SGPT have to go up. There's inflammation. So there is a pain, typical right upper quadrant pain. Encephalopathy develops because of cerebral edema. ALF commonly we see in young patients. Young patients, full brain, no chance of expansion. The cerebral edema develops fast, and therefore they land up into encephalopathy fast. Someone who is say 50s, 60s, sorry, this is not a judgment on anyone, but somewhere there's an age-related cerebral atrophy. So here, the cerebral edema, even if it develops, it does not increase the intracranial pressure too fast. So someone who's an elderly, we do not find encephalopathy early, even though the ammonia levels may be very high, because there is space for the brain to expand. So the encephalopathy, INR, coagulopathy. If you remember, INR was something which was made for warfarin. So when you give warfarin, we want to see how the prolonged time has got prolonged, and different labs to lab, they have different constituents. So INR is just for standardization, how much of warfarin should we give. INR will not be a complete or accurate marker of liver cell failure. So simple prothrombin time is also as good as a marker of a liver failure rather than going by only INR. But yes, historically it has been mentioned 1.5. The problem happens now whenever someone who presents with jaundice, even if he's hepatitis A or E positive, we find the INR 1.6, 1.7. We all get worried. We definitely need to get worried. But yes, he needs the medical admission. He should be in the hospital. He should be in someone with a gastroenterology or a hepatology care. But we generally get worried when the INR starts crossing the 2.5, 3 reach. But since technically anyone who is beyond the INR 1.5, not yet developed encephalopathy, we call it as acute liver injury. And if signs of encephalopathy start developing, then we would call this patient as acute liver failure. So hepatitis, liver injury, and liver failure, this would be the spectrum of the disease. Some causes like yellow phosphorus poisoning, the rat killer compound poisoning. I'm hardly seeing these patients these days, but whenever I used to see previously, so they typically present, someone has taken the yellow phosphorus on a suicidal intent, tells the family member comes to know, takes him to the hospital, they admit, they do all the symptomatic management, they do the LFT INR. Initially 3-4 days, there may be no change in the LFT, no change in the INR, and suddenly day 4, day 5, the INR shoots. Similar with paracetamol poisoning also, the INR can shoot very high, lactates can shoot very high, even if the transaminases are not very high. INR 7 and 8, enzymes may be few hundreds to thousands. Really think about yellow phosphorus or a rat killer compound, rodenticide killer compound poisoning. Even if you don't get history, you just try to poke that history to the relatives and ask, is there any other reason? Because most other causes, you will first have the transaminases going in the thousands, then the bilirubin and the INR start going up. INR coming first high is usually yellow phosphorus compound poisoning. Bilirubin jaundice, maybe at some point of time, day 5, day 6, when the transaminases is settling, the bilirubin can go up. Bilirubin maybe 5 and 6, we are not worried. But INR 3, INR 4, I'm extremely worried. How do they manifest? Initial symptoms are going to be typical prodrome symptoms, just some probably fever if it is a hepatitis A or E. Once they start landing up in your care, all the other organs can get affected. So the encephalopathy, cerebral edema, seizures, and sometimes the seizures are non-convulsive seizures. So we may not even know that the patient is convulsing. In fact, when a patient lands up to us in our ICU, if patient is in grade 3, grade 4 encephalopathy, I have intubated a patient. I would usually do a EEG just to find out whether there is a subclinical seizure is going on. And sometimes prophylactically, we also started these patients on anti-epileptic levetiracetam just to keep the brain activity as much as minimum. High heart, high output state, subclinical myocardial injury. This is common in rodenticide. In fact, if you see, I'm not sure whether how much you are seeing in the public setup, rodenticide killer compound. Mortality in the first week of illness is more from a cardiac failure because of rodenticide. And mortality in the second week of illness is more from the liver failure. Where now the INR started going up and it has not come down even after giving your NAC and everything. So first week illness is always going to be heart failure. So look at the echo, look at the cardiac function, look at the blood pressure. Pancreatitis, very rare, but yes, we have known hepatitis A and E causing pancreatitis. So patient is presented as liver failure, someone has sent amylase lipase, it can come as 1000. It's not going to change your prognosis overall, but you just need to keep in mind. Lungs, ALI, hepatopulmonary syndrome, more of in a chronic liver disease. SIRS, systemic inflammatory response. Patient has presented to you, heart rate 110, 120, blood pressure borderline, diastolic slow. You don't know whether this is infection or inflammation. So always remember, in the immediate first few days, it's always going to be more of an inflammation and SIRS. But the longer that the patient is there in your care in the hospital, and probably towards the end of the first week, second week, now that the infection starts coming. So the first few days, it's always going to be inflammation. So if patient has presented to you, you feel this is SIRS, here the role of plasma exchange and the liver alternative therapies and everything comes. From the liver perspective, coagulopathy, lactic acidosis, hyperammonemia, hypoglycemia is common. So these are the usual manifestations. I will intersperse a case that we managed a couple of years back with this presentation. So this was Mr. HC, 31-year-old male, no comorbidities, no allergies, present somewhere on 28th of November with sudden onset throat pain, diagnosis tonsillitis, treated with antibiotics, develops a high-grade fever, rash. Now someone notices a icterus, shifted to a hospital. These are the initial labs, day 30th December, just 2 days after the initial symptoms. Hemoglobin is 17, he's not a smoker. Bilirubin is 6. Enzymes are not high. I'm not sure whether this was a correct report or not at that point of time, but I would accept that. USG is showing a hypoechoic liver. The creatinine and the other organs are still well defined. What detailed history taking you need to take from the patient or from the relatives? If the patient is conscious, well and good, you can take from the patient. If the patient is not in sensorium, you need to take the history from the relatives. Always try to search for etiology. It's going to change your prognosis. It's going to change a lot of things. You need to find a cause, whether the patient has taken any medication, any prodrome, any history of travel, anywhere, anyone in the family, in the building, in the society had similar symptoms few days back, just to think whether the HIV or HIV is going on or not. Any history of jaundice in the childhood. HIV present in the childhood will never present again in the adulthood. No history of jaundice in the childhood. I'm really worried about in the young patient who is presenting for the first time as HIV. What are the other conditions permissive for ALF? Pregnancy. Female always ask for pregnancy, the last cycles. History of autoimmunity in the patient or in the relatives to think whether autoimmune liver disease is going on or not. And rule out a chronic liver disease. History of alcohol. someone who has been taking alcohol a quarter a day since last many years presents to you with jaundice encephalopathy, I will think of as a cirrhosis rather than as rather than as acute liver failure. But then we have seen someone who is a good metabolizer taking alcohol since many years, no effect on the liver, but a secondary infection like hepatitis E or something precipitates a liver failure. So take a history, rule out CLD. Definitely, as ultrasound will probably guide us whether CLD is there or not, and rule out other comorbidities. And most important, we want to find out the interval from the onset of symptoms. When was the jaundice first noticed? When was the first LFT which was reached? And now, if there is encephalopathy, so you need to make a timeline because this will define that hyperacute, acute, or the subacute stage. Now, how will you manage this patient? So, first things, yes, once you have taken a detailed history, screen intensively for any sign of encephalopathy. See, there is something called as a minimal encephalopathy in liver cirrhosis, where there is probably just altered sleep-wake cycle, patient is easy forgetfulness, change in the personality, unable to do subtraction tests. We commonly ask these patients to do 100 minus 7 tests and everything. Now, I'm not sure, we don't have literature, how much that MHE part would be important in the liver failure, acute liver failure. But yes, someone who is drowsy, someone who is falling to sleep every time you start talking with the patient, someone who has flaps, definitely this is grade 2, grade 3 encephalopathy, and so grade 2, grade 3, grade 4. If not, still try to find out whether there is any sort of subtle judgment and sense impairment. So you want to look for encephalopathy, because if you see there is no encephalopathy, technically you are labeling still this patient as ALI. You're still going to give your NAC, you're still going to do the supportive treatment, but still it changes the prognosis. And if 2 days, 3 days later it starts developing encephalopathy, then you are worried. Exclude cirrhosis, rule out contraindications for emergency transplant, search for a etiology, transfer to a specialized unit. So two things happen. Definitely we'll talk about transplantation in the subsequent slides. Maybe 70% of the patients will improve without a transplant. 20-30% patients would need a transplant. Transplant needs, it's not a simple thing where I can just decide, okay, this patient is not improving, I want to go in with a transplant. A young patient, I may not need much of evaluation from the liver transplant suitability, but for someone who is middle-aged, I want to know the cardiac and the lung status. It's not easy to get a cadaveric donation so fast. So if I list the patient today, I may need the liver tomorrow, day after tomorrow. There is no guarantee I'm going to get that liver tomorrow. So I need to start talking to this patient's relatives. There is a higher chance this patient may require a transplant. I need to identify a suitable donor in the family whom I can work up fast. It will, no matter how fast I work up a donor, it will take at least 24 to 48 hours for the workup to complete, which will include all blood tests, all your evaluations, cardiac evaluations, all the consultations, as well as the paperwork, sending it to the rotos, and getting the paperwork done, the legal thing and everything. So minimum 2-3 days are required. Now, if I am working in a peripheral center where I do not have a transplant access, I manage the patient initially, and on day 4, day 5, the patient starts deteriorating. This time I panic, I send the patient to a transplant center, and now they start evaluation for a donor. And by the time donor evaluation legal procedures are completed, the patient may be so sick that he is untransplantable. And that is why general advice is, if you feel this patient is going to require even a 20% chance of transplant, it's better that the patient is shifted to a transplant center. Tomorrow, if transplant is not required, well, good. We also want the same thing. But then we cannot start workup or evaluation at a later stage and the patient becomes untransplantable. That's why it's important, or at least be in touch with a transplant unit. If this is the patient, even if I'm not transferring the patient, tell me what the donor evaluation, what the patient evaluation can be done. What lab investigations I want to send when the patient presents first to me. So definitely, most of the times the patient who has presented to you will have some sort of reports, a CBC, LFT. If fever is there, someone would have already done your malaria, dengue, leptospira, and everything. You need to know all the causes, the viral causes. So your Hep A, Hep B, Hep B, your varicella, cytomegalovirus, Epstein-Barr virus. If someone has already come up with a report of HIV, I may not immediately send the herpes simplex, the EBV, and the VZV on the initial first day. But if someone has not come with those reports, I would like to send it everything at the same time, because some reports take time to come. HIV in the private setup also takes 2 days to come. I cannot then start sending other causes of evaluation on the 3rd day, 4th day. So I need to look for the etiology. I would send autoimmune markers also in a young patient, especially ANA, IgG, ASMA. Most important from the prognostic point of view for that patient, I want to know 3-4 important things: lactate, ammonia, sodium levels, INR. And these are the 4 things which I would monitor frequently in that individual patients. Maybe even 6th hourly or 8th hourly on the first day if I have diagnosed someone as encephalopathy. Monitor the renal output. So this patient, you see the bilirubin started going up, enzymes then was 3000s. The INR, the first time that presented to a local hospital was 12.5. They panicked, they sent to us. At our place also the INR was 14.5. Other markers, lepto, malaria, dengue, everything was negative. Ammonia was 109. All the other etiological workup, AE, EBV, HepiCore, HSV DNA, AH, HCV, everything was negative in this patient. So we still didn't have an etiology. He was someone with a high INR. This is just, probably you can just go back later on, but what are the differential diagnoses based on the ALF? A busy slide. This is again a busy slide of acetaminophen, ischemic injury, what are the typical patterns? So if I want to just say from the experience, what we commonly see, HEPI, typical prodrome, enzymes in thousands, and then 4th day, 5th day, coagulopathy start developing encephalopathy. If you see daily, most of the time it is a tubercular AKT-induced hepatitis. So we commonly see someone patient was already on AKT and now presents with symptoms simple, just a vomiting. You get the LFT done, which is deranged, couple of thousands, and the INR. You still rule out HEPI in the patient, even if there is a history of him being taking AKT. Budd-Chiari syndrome. Someone who presents like ALF but has large ascites as presentation, always think of Budd-Chiari. So this is one thing that you need to know. Wilson's very rarely would manifest first time as ALF, but yes, if you have got a cytoplasmic done, it is going to be extremely low. The 24-hour urinary copper would be on a higher side. AST-ALT ratio would be 3 times, 4 times in this patient. And alkaline phosphatase would be very low. So if you have a ALF, ALP is very low, bilirubin is higher than ALP, you always suspect whether there is a Wilson's, especially in a young patient. Some changes that I've seen, see, there was a time India was not having so much of hygiene. Hep A was common, epidemic, pandemic. Most of the young individuals, 5 years, 7 years, used to get Hep A, whether subclinical or clinical. And they never used to land up into encephalopathy, hepatitis. They used to recover at home, just jhad phuk kar liya, thoda sa ye kha liya, ganne ka juice pee liya, and they are getting better. As the hygiene is improving, Hep A is not being found in young patients. There is no pandemics or epidemics. But young patients now who are 20 and 30-year-olds who have not been exposed to HIV in the childhood are now getting HIV. And now because of increased immune activation, they are landing up more into HIV-related ALF. So this is one thing which we never used to say 10 years back. Somehow HIV has gone. The HIV, the viral load or the what we call as the immunological load, viral load that for you to develop HIV hepatitis is so high that HIV is practically non-existent. But HIV, even with some viral load, you can always get an infection. Many patients, if you send the investigations, HIV and HIV, both IgM are positive. Many times this HIV IgM is going to be false positive. It is the HIV which is primarily driving the disease, and rather than the HIV or a combined disease. So we discussed some things. How would you take care of this patient? So once the patient is presented to a specialty unit or is in ICU, I would prefer if there is someone who's ALI or a ALF, the patient has to be in the ICU setting so that a more close monitoring is done. We monitor ammonia, lactates, INR. Ammonia, any single reading more than 200 or 2 readings more than 100, 150 in our hospital protocol, we would like to start CRRT. We commonly want to see whether the raised intracranial pressure is there or not. So we commonly do transcranial Dopplers, optic nerve sheath diameters. If the patient is in grade 3, grade 4 encephalopathy, it's better to intubate this patient. Look out for infections, send our cultures. Western literature says no need to start antibiotics. But in our setting, most of the time, patient by the time presents to you probably already has taken some antibiotic, and we would expect some sort of secondary infections if the patient is already in the 5th or 7th day of illness. It's always wiser to start a broad spectrum antibiotic in the initial, and always keep on looking for cultures, surveillance cultures every 2nd day, 3rd day. You need to send. Recently, we had a case, ALF, HIV related, got better, but unfortunately, secondary infection was the reason for a mortality in the 3rd week of illness. So always keep on looking out for the infections. Always keep the room as dark as possible. In fact, sometimes even in a patient who is intubated, I would apply iPads or put in a dark black goggles. I do not want even the light stimulation to initiate epileptic activity in that patient. The more the epileptic activity, the brain edema will worsen, herniation can happen, and the patient may become non-transplantable. So anyways, this patient the ammonia can continue to remain around that 100 range. Lactates went up, listed for suprachoroidal transplant. Someone whose ammonia is not high but has signs of SIRS, probably is having some coagulopathy, we do consider plasma exchange in our setting. Plasma exchange has got a good literature, especially in the rodent killer compound poisoning, especially from the literature in the south. It's a very, there's no hard and fast guidelines. Okay, this patient needs a plasma exchange. Someone who has ammonia on a higher side, I would always initiate CRRT first. But if still there is no indication to start CRRT, if there is SIRS, if there is coagulopathy, probably I am giving the chance to that liver by doing the plasma exchange. This patient underwent 3 cycles of plasma exchange. INR did come down, but once the plasma cycles were stopped, again the INR started going up, now started becoming encephalopathy, and this is where we felt, okay, this patient is not going to recover. This was already on the 10th day of illness, and this patient did undergo transplant. So just to summarize, what all medical management you need to take care in the ICU, the raised ICP pressure, encephalopathy, coagulopathy. Do you correct everyone's coagulopathy? Practically no. The INR is more a marker of the liver failure. Unless the INR is very high and I want to do some sort of intervention like putting in a central line, art line, maybe I would just correct for that short time. But afterwards, it's just going to be monitoring INR every 6 hourly or 8 hourly. Hemodynamics, important. We'll just go through this fast. So management of encephalopathy, already I told, we keep on looking at the transcranial Dopplers, optic nostril diameters, intubate for a high-grade encephalopathy. Propofol is the best sedation to keep this patient sedated. Minimal environmental stimulation, have a head elevation. Rarely, if we feel this patient has an optimal chance of transplant in the next 2 days, but I want this patient to survive and not undergo should not be subject to herniation. Rarely people have done total hepatectomy. Just remove the liver out. For a couple of days, we can manage without the liver, because the necrotic liver is the one which is pulling on the entire cytokine storm and causing all sorts of inflammation everywhere in the cerebral edema. But this is an extremely radical decision. Only if you know that the liver is ready, the donor is getting evaluated a day more and you can transplant the patient, then probably a hepatectomy can be done as a life-saving procedure. Fluid management, just focus-based, volume resuscitation should be done. Crystalloids are good enough. Look at the lungs, maybe volumes with the diluted the albumin can be given. Norepinephrine is a good vasopressor of choice. There is no blood pressure target. In sepsis, there is a target. In cirrhosis, for refractory ascites, there is target. So there is no such target as such, but you want an optimal BP, whatever, probably a young patient, you expect somewhere to be 120s and 130 systolics, maybe that is the fine. So till until the patient is producing good urine output, there is no signs of any other severe sepsis or something, the diastolics are not low, there will be no optimal target, just maintain. Look out for hypoglycemia, look out for hyponatremia, look for lactates. I want to keep the sodium around 140 to 145, both from the encephalopathy perspective. We do use 3% saline. We do rarely use mannitol. 3% saline, 20 ml, 30 ml, 40 ml per hour also we have given. Every 8 hourly, 6 hourly, we check for sodium. Once the encephalopathy is better, then probably the 3rd day, 4th day, the sodium targets start coming down. And initiate RRT, CRRT, CVSGF is the best form. No intermittent dialysis. It has to be a sort of a continuous dialysis. Monitor ammonia. Once the ammonia starts coming down to less than 50, stays at 50, and then probably is the time that you can give a CRRT break cycle. Look out for infection. Initial few days difficult to differentiate infection and inflammation. Surveillance cultures. This is also important. What to be avoided in ALF? So benzodiazepines as sedatives need to be avoided. Avoid nephrotoxins. Paracetamol to be avoided. Anti-epileptic medicine, only thing that is safe is levetiracetam. And the antibiotics, macrolides, quinolones, nitrofurantoin, cotrimoxazole, coamoxiclav should be avoided. Now, what are the potential outcomes? Either you give a proper intervention like NAC for a paracetamol or yellow phosphorus compound poisoning and patient recovers. Antivirals for viral hepatitis, patient recovers. Or there is a spontaneous recovery because the liver regenerated and you just gave a supportive treatment. Or the patient dies. Or you are rescued the patient by liver transplant. So if you see, our patient did undergo DDLT, subsequently developed secondary refractory herpes simplex hepatitis. We initially discussed the patient should be evaluated or should be in a transplant center, preferably if there is any feasibility of the transplant and there are no financial constraints. If there is a financial constraints, fair enough, you cannot help it. But we know any ALF with coma, with AKI, higher chance of mortality without a transplantation. And the King's College or the Clichy criteria should guide us which patient is going to require a transplantation, easily available on the literature. So the Clichy criteria, factor 5 and encephalopathy, while King's College will have a lactates, encephalopathy, create and INR. Factor 5 is a good test to diagnose liver function. Somehow I feel we don't use it commonly or it's not easily available, but it was a good test to add to our armamentarium. And just last couple of slides. What are the liver failure causes where transplant is an option? So drug related, toxin related, viral hepatitis, AIH. Yes, you can consider transplantation. Ischemic hepatitis, infiltrative disease, malaria, infection, hemophagocytic syndrome. Usually a liver transplantation will not be considered. Someone who had a HCC underwent a liver resection and now has developed this thing ALF, again transplantation will not be considered. So these are the things where you do not consider transplant. 10% of patients in the UNOS data did undergo transplantation for the ALF. In our experience, almost 2/3 of the patients will improve without a transplantation. HIV, paracetamol, ischemic hepatitis, acute fatty liver pregnancy has a good prognosis with or without a transplant. HBV, poor prognosis without a transplant. Wilson's, poor prognosis without a transplant. And it's difficult to find what is optimal window. You should not be too early or you should not be too late. And always keep on looking at if at any point of time you feel that the ICP is too raised, get a CT brain done, see whether the herniation is done or not, give sedation break to see whether the patient is getting awake or not before you go in for transplantation. Rarely it has happened, patient has undergone transplantation, but never recovered neurologically. So it's always vital that before you go ahead for transplantation, you see what are the chances of the neurological recovery of this patient. So this would be my take-home messages. Always try to identify the ALF or the ALI early. Early refer to a transplant unit. Etiological workup is important. Intensive care management of encephalopathy, metabolic parameters, RRT for hyporammonemia, plex if there is no encephalopathy immediately. Early counseling, listing for transplantation. There's always a small window and try to get that window if the patient is not sick. Thank you. This was my.
Thank you, Dr. Bharat. I have one comment in
Yes,
our ICU because we also manage pregnancy coming with complications.
Yes, sir.
So we've got that subgroup of those ladies who are, AFLP or preeclampsia and HELP.
Yes, sir.
And on this background, we've seen a few deaths where the liver functions deteriorate.
Yes, sir.
And then when we've done the histopathology studies, they turn out to have some metabolic disease which was there pre-existing. And the liver is full of fat in those liver cells. So probably they have some background, either some adult glycogen storage disease or hemochromatosis.
So there are two things, just a caveat. Of fatty liver is very common now. Okay. Someone who has 20-30% in the fat, the recovery from any sort of liver injury is going to be difficult. So even if I have a 30% fat and someone who's a 10% fat, probably that person will recover more, and there is a difficult chance for me to recover. So fatty liver, somehow that steatotic liver does not improve from that insult. So with or without congenital disease, a fatty liver will take time to recover.
Yes. We are next to Wadia, and there is something called a Chinese bear syndrome. The pregnant ladies coming with Chinese bear history eating. Chinese bear.
Bread.
And hepatitis. Bear. Chinese bear. The cabbage in that is kacha, and that causes direct, and such a fulminant hepatitis. They come and pregnant ladies because they want to eat that pungent things.
Yes, sir.
And that Chinese bear wala is exactly opposite gate number of Wadia maternity. So that is what, and I have informed it to the EHO also, but they keep on coming, and they come with a real bad hepatitis when they're pregnant, particularly. Yes.
History for me. History taking is important. Yes, that's fine. Yes. Yeah. So at what level we are comfortable? Yes. So somewhere INR 4, 5, 6, we are not really usually worried about. But someone with an INR of 9 and 10, I would actually do a plasma exchange. I'm just removing the plasma and doing a plasma exchange rather than only giving plasma, because here the chances are that the patient can go into fluid overload chances. So somewhere then, if the coagulopathy is too high, plasma exchange is a better alternative than giving only correcting the coagulopathy with the plasma. At INR 4, 5, we are not really worried, provided there is no bleeding tendency. We can always do, if facilities are available, a rotum or a TEG to just see whether there is any bleeding tendency. Even if the INR is 5, there may not be bleeding tendency, because both procoagulant and anticoagulant factors would have gone down. So if you are in bit of a doubt, you can always do a TEG or rotum to decide whether coagulopathy needs correction. But rather than, I would think in the other perspective, rather than correcting the coagulation, I would do a plasma exchange to take care of the coagulopathy. So whenever we feel, the theory is whenever the cells are dying, the hepatocytes are dying, there are significant pro-inflammatory, anti-inflammatory cells, the cytokines which are come into the milieu. This is not allowing the rest of the normal cells to regenerate. So by doing a plasma exchange, I'm removing all the cytokines, the larger molecules, which cannot be removed by a normal plasma, by a normal filter of the CRT. By removing all those middle and the larger molecules, I am allowing the remaining cells, hepatocytes, to regenerate and allow the liver to stabilize. So that is the principle, remove all the toxins. Definitely the role of plasma exchange is more where you have a predefined disease like probably Guillain-Barré syndrome or where the IgM, the large molecule related. In acute liver failure, when you say the rodenticide, it's all about the cytotoxins,
Thank you, Dr. Barot.
Thank you, sir.
Stop.
We would request Dr. Karnik sir and Vishal sir to come and felicitate our speaker. Now, to felicitate our chairpersons, I would like to call Dr. Kiran ma'am to felicitate Dr. Karnik sir. I would like to call Juhi ma'am to felicitate Dr. Vishal sir. So moving on to our next session, it's a panel discussion on brainstem death, the evaluation and medical legal aspects. So for the moderator, I would like to call Dr. Nitin Sarate sir. Sir is the clinical in charge of MICU in KEM Hospital and is an NMC recognized teacher for PG students with a teaching experience of more than 11 years. He's a mentor for fellowship with 19 publications and a member of ZTCC ICU subcommittee and an MJPJ critical care consultant. Welcome, sir.
Good morning, everyone. On behalf of Department of Medicine, I welcome you all for the Critical Care CME. Now we are proceeding to our panel discussion. I welcome all respected panelists. Our first panelist is Dr. Shashikant Shinde sir. Sir is a professor in anesthesia department. He's a faculty for fellowship in neuroanesthesia MHS. He's a Red Death committee in charge of KEM Hospital. Our second panelist is Dr. Rahul Pandit sir. He's a chairman of critical care emergency in Sir HN Reliance Foundation Hospital. He's a consultant in Bathurst Hospital, Wagga Hospital, Australia. He's a member of National Task Force Supreme Court appointed. He's the chairman of Home ICU Care, Tele ICU Care, and Event Medicine. The teacher in DNB, College of Intensive Care Medicine in Australia and ISCCM. He has more than 100 original publications and 60 book chapters plus 100 plus lectures in presentation. So special interest of sir is critical care, echo, brain trauma and organ donation. Our next panelist is Dr. Neeraj Jain sir. Neeraj Jain sir is professor of neurology at CGS Medical College, KM Hospital. He's a teacher for DM neurology. His area of interest is Parkinson's disease, epilepsy, strokes, and movement disorder. He has over 25 years of experience in field of neurology. And, there are 15 international, 10 national, and 6 poster presentation. So he has traveling fellowship to Bursi for AOMC 2009 Seoul. So, and fourth panelist is Dr. Murdul Dharod. So we are shortly running out of time. So we will start with the panel questions. So, my first question to Dr. Rahul Pandit sir is, how can ICU standardize brain death certification under THOTA Act?
Thank you, Dr. Sarate, for the kind invitation as well as the involvement in the brain death and organ donation panel, because that's very close to my heart. So if we look at and answer his question directly, the whole program of brain death certification and declaration of death and organ donation have to be decoupled. So that's the first thing which all of us need to realize, that under the TOHA Act, there is a process given under which we can certify a patient dead by brainstem death criteria. So the first thing is that you need to identify a patient who is dead, certify the patient that the patient is dead. Then organ donation can become a byproduct of it. What currently most of us are thinking is that if there is an organ donation, in that context, I'm going to think of brainstem death. So if there is a willingness for a transplant from the patient's family, or if there is even a hint of it, then we start thinking of brain death. What we are not doing is we are not certifying patient brain dead. Now there is a lot of dichotomy in this. A lot of people feel that the brainstem death is only described under the TOHA Act, which was 1994 Act. It's not a universal definition of death under the Birth and Death Registry Act of Government of India. Now, the answer to that is that if anybody goes to a court, let's say you diagnose a patient brain dead, and the family member basically refuses for organ donation, and then you say, I'm not going to disconnect this patient from the ventilator. And if they go to the court is going to ask one simple question. If they would have said yes, you would have gone ahead with organ donation because you've certified the patient dead. You would say yes. So are you dead enough to donate, but not dead enough to disconnect? So that's the dichotomy. Why am I going to this? Because this is the main question which is paralyzing the thought process of all the intensivists, anesthetists, neurologists which are involved. If there is organ donation, I'll jump into it and I will diagnose them brain dead. Otherwise not. So I think we need to get rid of that. And places like KEM can lead this. Places like KEM actually have to lead this process and say that we are going to declare a patient brain dead, certify, and then if the family says no, we will disconnect the ventilator and let the heart stop. That can happen only in government institutes. And if you do it, other private hospitals, other trust hospitals will follow. If a teaching hospital is having hesitation, the government will never allow anybody else to actually mature into this program. And this is the most important thing that we need to do under the TOHA Act. We need to decouple it. And how do I identify a patient who is a brain dead donor? I use the mnemonic GIVE, G-I-V-E. Glasgow Coma Scale of less than 5 on admission. I'm talking about GIVE on admission, okay? Not GIVE on the treatment as it goes across. Patient is intubated on admission. Patient is requiring ventilatory support full on admission, and eye signs are either absent or abnormal. This person is a potential donor. He has to be given the right treatment to see if we can reverse it and save his life. But there is a good likelihood that this patient who fulfills this GIVE mnemonic may also be a potential donor. So if despite best of your treating effort, he does not improve, then you need to start thinking of a
patient to be certified as a brain death with a brainstem death criteria as per the TOHA Act.
Thank you, sir. So, what are the sir legal procedure in organ donation in the situation where the relatives denied after brainstem death confirmation? So, positive apnea test is there is positive apnea
So,
test.
if the patient's family denies, you are saying, right?
Yes.
Organ donation. That's exactly what I said. I actually covered your third question in my first answer itself. That we should be brave enough to disconnect the patient from the ventilator, let the heart stop the inotrope, disconnect the patient from the ventilator, had the heart stop, and you give the patient's body back to the relatives. I think that is what we need to mature. Once we start doing this, there should be no hesitation because, you know, same patient, if they said yes, you would have happily sent the patient to the OT, we would have taken out the organs, heart would have stopped, even the heart would have been donated probably, and you would bring back the patient to the ICU and hand over the body. But the same patient's relatives, if they say no, we are hesitant. Wow, I am not going to do that because I'm going to kill the patient. No, you have already declared the patient dead by the brainstem death criteria as per the 1994 Act of TOHA, which is the Government of India Act. So you can't say that in one act the patient will die, the other act the patient is not dead enough. So we are actually as a society, I work with the NOTO as well closely. We are trying to push for a universal declaration of death as a criteria. What does universal declaration of death as a criteria will do is on the death, I'm sure many of you would have filled in a death certificate. Right now, there is no column to tick declared by brainstem death criteria. It's only a cardiorespiratory criteria right now. So we are going to get that tick there that declared the patient declared dead on so and so date at so and so time, cause of death so and so by brainstem death criteria. So once that comes, I think all of us will feel at ease. But you all know to get one line written in that death certificate, it is got to come from the parliament. Now, I don't have a reach to the parliament directly. It has to go through a process. Okay. So that process takes number of years. So it will take a long time. But until that, you can't say that my patient will wait for the parliament to act. The patient is dead. Why are we torturing the patient's family by continuing the ventilator, by continuing the inotropes unnecessarily? So again, my humble plea to all of you here, and I implore the KEM, Sayan, Nair, JJ, to actually take the lead and start disconnecting these patients actively after declaring them dead. You may still choose to put the time of death as the second apnea test, which is what it should be, or if you are not ready, you can put it at the time the heart stop, because the heart will stop within a few minutes time. That's a different discussion altogether. But once you start doing it, it will actually ease up the entire mechanism.
Sir, please guide us on the VIP support approach for a potential donor, brainstem death confirmed donor.
So I actually go by the rule of 100. So there is something called as rule of 100. So rule of 100 means the question is that what is the ventilation infusion pharmacological protocol? Rule of 100 means try to keep your physiology as close to a number 100 as possible. So that means systolic blood pressure of 100. Try to keep your temperature as close to 100 in Fahrenheit, which means 98.6. Do not allow them to become cold. They become very cold. They become hypothermic because the mechanism of conserving heat is lost because of the loss of your brainstem function. Try to keep your heart rate around 100, urine output around 100 ml per hour. Every 100 minutes, saturation near 100%. Every 100 minutes or 200 minutes, do a sodium check. Make sure that you are treating the sodium aggressively. If the urine output goes more than 100 ml per hour, start thinking of diabetes insipidus, start using vasopressin infusion or a desmopressin spray. I personally have not used a desmopressin spray for a long time. We all start them on 0.5 or 1 unit of vasopressin an hour, and the urine output as well as the diabetes insipidus gets converted, that's treated very well. You have to be proactive. You cannot be reactive here. So you have to actually keep them warm. If they become hypothermic, getting them warm becomes a problem. If you've allowed the sodium to go to 170, 180 because nobody interfered for 2 hours when the urine output was 800 ml, 700 ml per hour, then you've actually lost a lot of ground. You will not be able to correct it back very quickly, no matter how hard you try, because the moment you give fluid, the patient is going to pass it like water. So you have to be a little bit reactive. In terms of ventilation, Treat them like any other normal patient. Why do you have to do a different ventilatory protocol for these patients? Just use same ventilatory settings what you would do for any other patient who was there in your ICU. If that patient has got a lung damage, try and use a protective lung ventilation. Try and keep your PaO2, pH, and PCO2 within the physiological range. The whole purpose is to maintain this patient in the physiological normal range. Vasopressors of choice, 85% of these patients will require noradrenaline, 85 to 90%. There are occasional donors who don't require vasopressors. That doesn't mean that they are not brain dead. It's just the mechanism that they're able to still maintain the blood pressure in the range of around 100 systolic or a mean arterial pressure of around 65 millimeters of mercury. In terms of the second vasopressor, I nowadays start using vasopressin as the first vasopressor of choice. There is one study which actually did not show, 3 years back it was published. It didn't show any difference between vasopressin as the first choice versus noradrenaline. But purely from the view of, again, 85 to 90% of these patients will have some component of diabetes insipidus. So it's easier to use vasopressin in these patients, and you actually achieve a better stability of your blood pressure as well as your fluid and electrolyte balance. And then your pharmacological management, there are 2 or 3 drugs which we reserve for patients who remain hemodynamically unstable. So one of them is thyroxine. So I would rather give IV 3-4 if it was available. It's not available here. I use it quite freely in Australia. So here what we give is we just give thyroxine 300 micrograms through a nasogastric tube. There is a problem there because these patients also have a gastroparesis and absorption may not be very clear. So you may have a bit of stasis, but that's the best drug that we have. So if a patient remains hemodynamically unstable despite your reasonable efforts, if your ejection fraction is less than 45%, then you may give 300 micrograms of thyroxine as a replacement. The second drug is vasopressin, we've already talked about, and the third drug is steroids. So steroids, generally you may give 100 or 200 milligrams of hydrocortisone just to maintain the steroid replacement of cortisol. But if you have identified that this patient will be a donor and the lungs are likely to be donated as well, in that case, give 1 gram of methylprednisolone around 2 or 3 hours before the patient goes for an organ retrieval. Lung is a powerhouse of cytokines. We all have seen in our clinical practice, you all are physicians, majority of you, that a simple streptococcal pneumonia, how bad the patient is, versus a VAP, which happens in the ICU with Klebsiella, the patient may not behave in the same cytokine response, whereas what patient comes in from a community with a pneumococcal pneumonia or a streptococcal pneumonia. So what I always say is the more sensitive the organism, worse is the cytokine response and worse is the clinical presentation. So lungs are very bad. Any pneumonia, any infection in the lungs, we see what happens to cytokines. So to blunt that cytokine response so that the transplanted lung will behave better, you give 2 grams or 1 gram 2 to 3 hours before you actually send the patient for retrieval. And that's just one-off dose. You don't do any more than that. Thank you.
Thank you, sir. My next question to Dr. Shashikant Shinde, sir. How apnea test be done safely during the brainstem death evaluation?
At the outset, first I'll thank the organizing committee to call me as a consultant over here. I'm part of KM. So what I feel is aseptic precautions are more important for all this apnea test that we take care of. We keep safe drugs or for drugs for resuscitation because of complications of apnea that can occur. We keep everybody ready for the apnea test. For those 10 minutes, we have to be watchful, monitoring the patient. Patient's normothermia has to be maintained as Rahul sir has right now suggested correctly. And second, third part of this, first is patient care, second is our staff has to be alert, monitoring. Hello. We have added EEG or transcranial ultrasound sonography to Doppler sonography to it also to confirm the perfusion of brain stem. But then we are not very particular about it, so we rely upon EEG in our setup as such. Not required as such.
Yeah.
Otherwise, ventilatory settings are to be maintained, like we give
CPAP for 10 minutes and try to maintain the PaCO2 level at around 150 or 200 level. But that is not possible. And we check out with the time monitoring. That is 8 minutes and 10 minutes. We have to be perfect in that. And we have to get those ABGs, CO2 retention, whatever is there, that we have to monitor. And once we get a positive test, we can ask the relatives or the coordinators to talk to the relatives. We don't inform about patient's condition. So to continue with this apnea test, we have to inform everyone, and there should be 4 RMPs, like including one neurologist, one intensive care intensivist, one anesthetist, and one registered medical practitioner. That is what the law says, and we follow Indian laws. So, as sir said, there is always a controversy between declaring brain death. We'll come to that question next.
So, is consent is necessary for apnea test?
That is what I was saying. This consent for apnea is not done. We don't do it. It is taken up as a part of the clinical practice. We do monitoring of the patient in the ICU. For that, one general consent is taken in the beginning only. So this is like they say. This is like taking a IV line. We don't take consent for IV line taking in the ICU. So all this monitoring which we do under apnea testing and all that is also taken up as a general practice in ICU. So there is no apnea test consent is taken.
Thank you, sir. So my next question to Dr. Neeraj Jain, sir. So how?
Can I add on to that?
Yes, sir. Yes, sir.
So just 2-3 things to add on to sir. So first of all, pre-oxygenate these patients with 100% oxygen. Make sure that you do a baseline ABG. Make sure that your PaCO2 is around 40 millimeters plus minus 5, so that you begin from it. Then, if you are going to connect the patient on ventilator and do this test on CPAP, you need to bring down the sensitivity, because what happens is they don't have any vascular tone, they don't have any muscle tone. So even the abdominal aorta pulsations are taken up by the ventilator as a diaphragmatic movement, and you will actually start that they're breathing on the ventilator on a CPAP mode or spontaneous mode. So best is to disconnect them from the ventilator, put an oxygen catheter through the endotracheal tube or tracheostomy tube, and start it at around 2 to 4 liters per minute of oxygen, not more than that. Ensure that the catheter's diameter is at least 1/3 or less than the size of the endotracheal tube. Otherwise, you will actually block it. Once you start it, for each minute of apnea, the CO2 rises by around 2 to 3 millimeters of mercury. So if you start from the baseline of 40, you'll probably need around 8-minute ABG. What I do is I continue the apnea test, withdraw an 8-minute ABG, give it to the ABG people to run it, and I continue the test. Another 3-4 minutes, the ABG machine gives us the report. And if the PCO2 has gone above 60 millimeters of mercury, which is the baseline, 40 to 60, 60 is the time where we actually say that the test is positive. Why 60? It's not a number taken out from the hat. You need to demonstrate acidemia in the blood. And acidemia is the one which actually stimulates the respiratory center. And that acidemia is taken up as 60 millimeters of mercury from a baseline of 40. In a CO2 retainer, let's say the patient's CO2 remains at 50-55. In those patients, you have to go 20 above the baseline. So the 20 above the baseline rule is only for patients who are CO2 retainers, in whom you can't bring the PCO2 down to 40 plus or minus 5. So then in that case, you go up to 20 above the baseline. So you start from 55, you go up to 75 in those patients. Then 60 is not the baseline, because you have to demonstrate acidemia in them. Okay. And then the end of the second apnea test is the time of death. As sir said, 4 people are there. One can be an anesthetist, neurologist, intensivist. It can be both anesthetists, both neurologists, both intensivists, one of each. The other 2 are defined. Other 2 are the admitting doctor under whom the patient is admitted, and the hospital administrator, which in a medical college could be a dean or a medical superintendent. In a private hospital, it is usually a medical director or the CEO. So this is how the test is done.
Next panelist, Dr. Neeraj Jain. Question for Neeraj Jain, sir. how neurologists can prevent false positive brain death diagnosis?
I think the most important thing is the clinical examination and knowing the etiology for this problem. So that's where the history taking, and we need to identify the patients who have toxin ingestion. We need to identify patients who are hypothermic. We need to identify patients who have been on ventilator support since long. So we need to take the proper history. We need to analyze all the papers and come to the conclusion that why this patient has landed in this situation, and then only we can identify the reversible causes, and then only we will avoid doing brainstem assessment in those patients. So I think we need to know the reversible causes of deeply comatose stage. That includes poisonings, that includes toxin ingestion, and for the especially for the drug overdose, we need to wait for 5 half-lives of a particular drug, so that proper the washout period is gone, and then only we should assess these patients.
So, sir, what are the national standards needed for ancillary testing in India?
Actually, by law, actually there is no ancillary testing required. Actually, it is the clinical criteria. You assess the brainstem death by clinical criteria, assessing the various cranial nerves, and thereafter you do apnea test after proper following the protocol. So actually, ancillary testing is not required, but in patients in whom, for example, if assessment of brainstem death is not possible, sometimes you can't assess the pupil because there is a surgical pupil post cataract surgery. Sometimes patient has severe COPD in which apnea test may be relatively contraindicated. In those patients, ancillary testing can be done. The usual bedside evaluation includes EEG or transcranial Doppler, which is available. But the other tests like DSA or CT angio or MR angio usually by and large are not required. So as such, it should not be required. The ancillary testing is not required except in a very rare patient in which you can't do the apnea test or you are not able to do the whole assessment of the brainstem by the available test.
For example, in panelists, four doctors are required, or if there is conflict between all four. So whether there is a role of ancillary test in this case.
So if there is a conflict of interest, if there is a conflict between the various physicians, then it can be done. But then I think by and large it is not ancillary test.
Not allowed to be used as a diagnostic tool by law right now. It's not a part of the TOHA Act. While we are saying that it should be there in special conditions, like Sir said, the most common being in trauma, if you have a high cervical cord injury, let's say C3 and above, your diaphragm is paralyzed because of the injury. How will you do an apnea test? In that condition, it will not be possible. If you have bilateral raccoon sigh, bilateral CSF rhinorrhea, you are missing out 4 cranial nerves to test. So in that case, you are not doing a complete examination. So these are the situations, or a difficult hypoxic patient where apnea test can be done. So I think these are the situations where ancillary tests should be used. But as of now, if you diagnose somebody on ancillary test, ZTCC and the Roto Soto will not actually accept that as a death criteria. So right now it's only clinical.
Thank you, sir.
Secondly, the quality of EEG also. Even if you do the ancillary test, the EEG has to be done with required prerequisite with proper technical procedure to be known. In a proper 1020 system with the placement of the electrode should be proper, because these patients are on ventilators. Sometimes you get the ventilatory artifact, sometimes you get the respiratory artifact. So a proper recording and interpretation is very important. That is very important.
Next question is, how should be the observation period considered in different clinical scenarios before evaluation of brainstem death evaluation?
I think the observation period usually is 6 hours between the two evaluations, and 2 independent evaluations should be done. First from the clinical criteria, and even if the apnea test, it needs to be repeated after 6 hours. The observation period is more to do with the more confirmatory evidence as a clinician that yes, really this patient is not in awake state. And observation period can be different in different clinical scenarios, but I think by and large we follow 6 hours to repeat the testing.
And despite everything, now you've given adequate time for any reversible causes to be done. People say after cardiac arrest, wait for 24 hours. These are not hard and fast set rules. You have to be clear as a committee, all 4 people who are diagnosing brainstem death, they should be satisfied that everything was done to rule out the confounding factor and reversible factors. And now we are only left with diagnosing this patient brain dead.
Thank you, sir.
I just want to mention about some clinical conversations which I got on the net about controversies that have been raised about apnea test and brainstem death. They always say it is a battle between legal thing and ethical thing. So legally as well as ethically to be correct is little bit difficult. And most of the people, they say we agree to disagree on this basis. So what I would suggest is, as such, we have taken a stand in our government hospital to declare dead when the flat line is observed on the line, and patient is supposed to be alive till we see that EEG is giving some positive signs about it, or some monitoring is showing good output.
Okay. Thank you, sir. I'm concluding the session by discussing this case. 17-year boy, it is the news in Times of India. 17-year-old boy seeking permission to donate his liver to save his uncle's life. The boy was 17-year-old, 9 months, and his uncle is suffering from ACLF. Despite our attempt by family members to donate, all were ruled out due to blood group mismatch and medical complication. Boy's family has filed petition in Bombay High Court seeking the permission for liver transplant. Under exceptional ground, minors are typically not allowed to donate organs without prior approval. So, it was rejected by KM organ authorization committee. So, stating that nephew is technically not adult or not near relative. So, and in this case, permission was granted by High Court for the donation in this case. So, how going further? We are going further. We are whether we are skirting the laws, current laws, to do such practice. So, boy was not fitting the age criteria. He is not a next to near relative as per law. So,
Want me to answer it?
yes.
So technically, for us, like in our action, we consider someone as donor from the age group of 18 to 55. So now this person is 17 years, 9 months. 3 months later, technically he would be 18 years adult and he would be eligible to give a consent for liver donation. So that is the first thing, the age criteria. 18 to 55 is fine. Now, altruistic donation, see, it is not completely banned by India. What they say is there should be no financial angle to it. So provided you are able to prove that there is no finances involved, then definitely for any organ donation, any live donor related, live related liver donation that we do, for all the legal work and everything, we have to submit all the last 3 years income tax, bank statements, both for the donor as well as for the recipient. And the committee, the local authorization committee, goes through everything and has to be reasonably sure that there is no finances involved. So we have had cases where the donor is like a nephew or something. The farther the relationship, it's sometimes difficult to prove because we need a DNA. Even if I have, suppose, taking from my wife's sister's son or something, I need to prove that my wife and her sister are actual sisters. There should have a live family member like a parent or something, and the genetic tree. So if there is a genetic tree which can be proved, then the courts don't mind. So just because he is a nephew doesn't mean we'll reject him. Provided we need to know what sort of a nephew he is. If someone is just like a brother's child, the government, the court can accept it. So age, definitely, the relationship has to be proved with the DNA. So we definitely do now we are doing, previously we used to do the HLA for as a marker for the genetic testing for proving the relationship. Now we are doing a genetic fingerprinting sort of thing. And altruistic donation is possible, but since we need permissions from DMER or High Court or something, so the cases would be somewhere like 2 or 3 a year, 2 or 3 a year or somewhere in the entire India. So it is not common, but it's not completely banned per se.
Okay, thank you, sir. Any question from audience? Thank you all panelists and audience.
Madam, the members are appointed, are recommended by the hospital authority, which is in KM would be the dean or the appropriate authority there, to the DHS for them to be nominated as a brainstem death committee members or brainstem death. It's not actually a committee; it is people who can do the brainstem death testing. They can be continued for every opportunity of renewal, which is 2 years, or you may want to change them. But usually, madam, we don't have so many people. Like example, for in your ICU or anesthesia or neurology department, there would be only 2, 3, 4 senior people. So what we see is that we repeat the members. At least in private hospital, once we are on the committee, we are on that committee for several years. We get renewed every 2 years.
Hello. To answer your question, madam. Hello. Madam, I wanted to answer your question by saying that I am being appointed as a member only for 2 years. After 27, I will not be member. They will have to reappoint me. So all those dean dean of the institute will take care of all that because Arogya Bhuvan, as sir said, dean suggests and then the
Basically, renewal is mandatory. Same members can be continued at the discretion of the hospital. That is not compulsory to be changed.
We'd like to felicitate.
So, sir, we do approximately 140 to 145 in Maharashtra, of which around 60 to 70 odd happen in Mumbai, 60 to 70 odd happen in Pune, and rest of the ZTCs, Aurangabad and Nagpur do around 10-15, but combining them. We had the best year was 2019, where I think we crossed around 85 donations. COVID, we came down, and now we are again slowly inching towards 60-65. But potentially 600, sir. Right now, if you go and take around in Sion Nair, JJKM, there must be at least 5 patients or 10 patients who are fulfilling the give criteria. Not brainstem, but give criteria of any point of. Abhi aap round loge to bhi milega, sir. 100%. Yeah.
We'd like to felicitate our panelists, Dr. Nitin sir, to felicitate Dr. Shashikant Shinde sir. Dr. Meghna ma'am to felicitate Dr. Rahul Pandit sir. Dr. Smriti ma'am to felicitate Dr. Neeraj Jain sir. Dr. Santosh sir to felicitate Dr. Mrutul sir. I would request everyone to come for a group photo. I'll request Dr. Smriti ma'am to felicitate Dr. Nitin sir for moderating this entire session.
For the next session, I would like to call our chairpersons. So I would like to call Dr. Santosh Salagre sir. Dr. Santosh Salagre sir is MD in medicine, MBA hospital management, FAIMR ER fellow, FICP, PGD HHM, PGD MLS, IFACE, and he's also acting HOD for Department of Medicine, SAID GS Medicine.
Yes, thank you.
For SAID GS Medical College and KEM Hospital. For the next chairperson, I would like to call Dr. Kavita Joshi ma'am. She is professor and unit head for Department of Medicine at St. GS Medical College, KEM Hospital, guide to MD medicine students under MUHS, and fellowship. She has fellowship in HIV medicine at CMC Vellore, teaching experience of more than 22 years in charge of HIV medicine at St. GS Medical College and KEM Hospital, and she has many publications in reputed journals. Welcome, ma'am. For the speaker of the next session, I would like to call upon Dr. Tukaram Jamali sir. And for the introduction, I would
So
request.
I am very pleased to introduce Dr. Tukaram Jamale, a professor and head of Department of Nephrology. Maybe decades together we are working together, and I think like Tukaram, naam hi kafi hai, isn't it? So I think I will give the session to Tukaram, and please carry on.
Hello, I would like to add that which is not reflecting here, that he has excellent command on Marathi and he writes excellent heart-touching blogs on Facebook and everything. So that's another aspect of his personality.
Okay, thank you for the very kind introduction, sir. So without any further ado, I will start with the job given to me, that is discussing with you all what we can do to prevent and overview of treatment. This is a very broad topic. I know I can't go into details of each of this, but we will touch upon most important things in each of these areas. So I'll dwell upon the proven strategies. There are some settings where preventive strategies have been specifically evaluated and are useful to prevent acute kidney injury. Considerable debate surrounds the choice, type, amount of fluid. We will dwell briefly over there. Not much into diagnosis, but in the conservative management, the role of diuretics and alkali treatment, and very briefly about the type of dialysis, dose of dialysis, and timing of dialysis. Now, as you all know, AKI is defined by this. What we focus upon many times is the retention of nitrogenous waste, but practically when we treat these patients, what is more important is the disturbance, because that is where a lot of decisions are made with regards to the conservative management and dialysis. Now, first thing in prevention is to identify patients at risk, and this is very obvious. These are the patients when in the hospital are at increased risk of acute kidney injury, and we should be monitoring them closely. And there are, of course, predisposing conditions, shock of various etiologies, sepsis, and specific surgical settings like cardiac, aortic, and surgery on biliary tract. Now, coming to the setting of prevention of acute kidney injury, there are multiple interventions and there is no magic bullet. Largely, trials of single therapy to prevent acute kidney injury have been negative. But what is proven in prevention is being alert about the nephrotoxin exposure, quickly optimizing volume hemodynamics, medication management, and some specific setting procedures related issues. The setting of cardiac surgery, this evidence to this effect comes from coronary trial. This was a large trial which evaluated beating heart surgery versus non-beating heart surgery. And there, largely the primary outcome was not very different, death, dialysis, and myocardial infarction, stroke. But as you can see here, beating heart surgery was friendly to the kidney, and lower risk of at least the mild AKI was observed when surgery was on beating heart. This was very simple initiative at one of the Cincinnati Children's Hospital, where a pharmacist kept a track of all prescription charts daily and alerted the team when there were more than 3 nephrotoxins on the board, and if somebody was exposed to aminoglycosides for more than 3 days. And this simple intervention could reduce significantly the nephrotoxin exposure as well as the incidence of acute kidney injury. So this can very well be a practice across the units, across the ICUs. Let's come to this case of a 65-year-old female, diabetic, hypertensive, chronic kidney disease. She is day 5 post-op. There is acute kidney injury. She developed respiratory distress, and team thinks about whether it is a pulmonary thromboembolism. And they decide, no, we cannot give her contrast because she is already in AKI, so let's defer CTPA. So did they do the right thing? Any opinions? So coming to the contrast associated AKI, one of the great unlearning of the last decade was that intravenous contrast is not a major risk factor for acute kidney injury in hospitalized patient. So oftentimes there are other explanations for such elevations in the creatinine, and life-saving contrast procedures, intravenous contrast procedure should not be deferred. But risk is very much there when you are using intra-arterial contrast, and there are proven interventions in this area. Use isosmolar contrast as low volume as possible and hydrate the patient, of course, when he's not already overloaded. And various strategies, types of fluid, not very different, but hydration will be effective. Avoid iohexol and do not use any of this. They are ineffective. N-acetylcysteine, bicarbonate, or many of these. Sometimes people use hemodiafiltration to remove the contrast. None of this is effective. Coming to the second scenario, the case of 24-year-old male, he was brought to the casualty. He was made to do 200 sit-ups by a police when he was caught on beach doing something. And then at admission, there was evidence of muscle injury. There was evidence of rhabdomyolysis. So what is the initial rate of fluid administration in this setting? So this is one of the very important preventable cause of acute kidney injury. And as soon as you identify these scenarios, these are rhabdomyolysis and hemolysis, you can institute immediately the hydration. Diagnosis, I won't be discussing this, but you may find CK normal or rising still. It is not reached peak as yet, and keep a watch and monitor it serially. Hydration as high as 2 liters per hour is effective in rhabdomyolysis. A smaller volume in hemolysis. Of course, this is the time when you are seeing the patient in casualty, like a stampede victim evacuated and brought to the casualty, or this scenario of the man who had evidence of rhabdomyolysis. Which fluid? Normal saline is effective and is tested over years in this area. Reassess when you have administered significant amount of fluid so that you don't end up producing fluid overload, and maintain output above 200 ml per hour. There is some scope of alkalinization of urine because there is strong theoretical rationale. Alkalinization can prevent cast formation, oxidant injury, inflammation, precipitation of uric acid, and a simple protocol can be diluting 150 milliequivalents of soda bicarb in a liter of dextrose. Separate IV line for this drip, and don't be fussy about alkalinization. If you are not able to alkalinize the urine, then stop after 3-4 hours. Or if you are finding any signs of alkalosis or hypocalcemia. No use of mannitol, diuretics, or dialysis to prevent acute kidney injury in this setting. These are the two other very common nephrotoxin exposures, and there are effective strategies available in these two areas. Proven benefit of magnesium and potassium supplement in addition to hydration in the setting of cisplatin. Amphotericin, one of the things that probably I want to emphasize here is that progressive severe acute kidney injury is rare with amphotericin, and if there is such a scenario, then you should think about other causes. Now coming to the fluid debate. Now these are the 2021 Surviving Sepsis Campaign guidelines, and I have listed them here. So there is no much debate about not using gelatin for resuscitation or starches for resuscitation either. They are harmful or useless. Crystalloids as initial fluid, yes. They have specifically recommended balanced crystalloids instead of saline. So I have some thoughts about it. I will discuss. And they also make a recommendation about use of albumin in some patients. So there are some other recommendations that you begin the resuscitation quickly. You use dynamic measures of assessment and not the static measures. So no difficulty in understanding this. this is something that again I want to discuss, that at least a bolus of 30 ml per kg IV should be given. So coming to this 30 ml per bolus, this comes from a very influential trial 2001 when I had just joined residency. This was very hotly debated, discussed, and this was an early goal-directed therapy by River and colleague. This was an emergency room trial and demonstrated a dramatic decrease in the mortality in patients who received early goal-directed therapy. It involved administering large amount of fluid, targeting various parameters like central venous pressure, mean arterial pressure, vena cava oxygen saturation. But remember that this was an emergency room trial, 3 to 6 hours after admission in the hospital, and not the admitted patients in the ICUs. And multiple trials later could not replicate as dramatic benefit as was demonstrated by Rivers. And this led to downgrading the recommendation, which was a grade 1A recommendation in earlier guidelines. Now it's not as strong a recommendation. And now more and more favor is for the restrictive fluid strategies, because fluid overload is associated with multiple complications, and strategies involving restrictive fluid administration. They did not improve mortality, but there is some benefit to the mechanical requirement of the mechanical ventilation. And this was brought up by these two meta-analysis, large meta-analysis of the trials. Now this was published a couple of weeks back, where personalized hemodynamic resuscitation using a capillary refill time. So there was a significant benefit for this hierarchical outcome of all-cause death, duration of vital support, and length of hospital stay. Interestingly, there was some benefit for kidney as well. Duration of renal support and RRT-free days also favored this personalized hemodynamic resuscitation. So probably this recommendation, which was a weak recommendation in previous guidelines, may get some upgradation now if they are revised, using capillary refill time for resuscitation. So bottom line, of amount of fluid, rational approach would be more and early use of inotropes and assessing fluid responsiveness, giving boluses that are not very large and reassessing again, giving bolus again if there is evidence of fluid responsiveness. Now there is no doubt now in our mind about no use of starch in resuscitation. There is a clear increase in the risk of acute kidney injury, need of dialysis. So no to starches. Now a lot of discussion is about normal saline being abnormal. Now people say that there is nothing normal about saline and it has an unphysiological concentration of sodium and chloride. It induces hyperchloremic acidosis, renal vasoconstriction, and increases the risk of AKI. So this was the theoretical rationale which led to multiple trials examining this issue. There are at least 5 of them, large trials done over last decade or so. These two are the large pragmatic trials which showed that there may be some benefit of preferentially using balanced crystalloids. SALT-TD did not show any improvement in the primary outcome, but SMART showed that kidney-wise it may be slightly beneficial. But this effect was not very great, and individual components of this MAKE was not significantly different. But these 3 trials, which were double-blind trials, not pragmatic trials. Pragmatic trials means they randomize ICUs, like you change the policy of using, they did not randomize individual patients. So where this was done in double-blind trials, evidence for harm of saline was not found. And as of now, I don't think there is enough evidence to say that saline is nephrotoxic. But when you are using large volume resuscitation and hyperchloremic acidosis is getting set in, you can always switch to balanced crystalloids. Guided by acid base, you can choose to alkalinize by using isotonic bicarb or use saline to acidify. And there is no acid base abnormality, you can use any of the fluids available. Now coming to the role of albumin, this is the question I will skip. So this was probably the best evaluation of albumin in a randomized controlled trial, safe trial, which did not show any superiority of albumin, whether it was ICU stay, renal failure, or all-cause mortality. This was a recent review which listed various indications for albumin use, probably abuse. None of them are supported by the evidence, and the only probably evidence-based indication for albumin in today's practice is a setting of cirrhosis with a spontaneous bacterial peritonitis. In this setting, however, there is, although not very large trials, but multiple trials have shown consistently a reduction in the mortality and renal failure especially in the spontaneous bacterial peritonitis. Effect is significant in spontaneous bacteria and even in other settings of cirrhosis and ascites. But none of the other settings are a valid indication. Diagnosis is simple, monitoring creatinine and urine output. Biomarkers are there in discussion for more than a decade now, but none of them is really useful at bedside. But when you are using nephrotoxic chemotherapy or drugs, it makes sense that we have some sensitive biomarkers, and these are two approved by FDA. These are the cell cycle arrest biomarkers. So when it comes to diagnosis, one needs to understand that not all acute kidney injury is tubular injury. Sometimes you may miss a very important vascular or glomerular disease, and we need to know where is the lesion and what is this etiology of the lesion. So kidney compartments are glomeruli, tubule, interstitium, and blood vessels. So any of this can be affected when patient comes with renal failure. And simple urine examination can give an important clue. We have seen patients during swine flu and COVID pandemic where vasculitic kidney involvement was missed because we were assigning this etiology to COVID-19 or H1N1. Now coming to the treatment, most important message here I want to give is dialysis is not the panacea of treatment of acute kidney injury. And increasing evidence supports a conservative dialytic strategy. Acidosis and fluid overload are the leading indications, and both of them can be avoided and treated before you resort to dialysis. So we are dealing with an emergency, so don't rush to start dialysis. So what is probably true about bicarbonate therapy in metabolic acidosis? Does it reduce mortality? Does it decrease the need of RRT or delays the need of RRT or decrease the risk of bloodstream infections? Okay, this is not true. Now this was a latest publication on use of bicarbonate, bicarb ICU2 trial published about a couple of weeks back. 4.2% soda bicarbonate was used. There was no difference in the all-cause mortality at 90 days, but there was significant decrease in the use of renal replacement therapy in the patients treated with 4.2% bicarb. So this is very important observation and a clinically meaningful difference in the requirement of dialysis by day 28. Time to dialysis initiation also was longer in patients getting treatment with bicarb. Another interesting thing was bloodstream infection. This was lower when patients were assigned to bicarbonate, probably reflecting lower use of renal replacement therapy, dialysis catheters, and dialysis in these patients. So this was 4.2% bicarb. Approximately 700 ml was administered over 2 days. So this will translate into about 300 to 350 ml of 7.5%, which we are using over 48 hours. Diuretics, they are not harmful. Harm of diuretic was raised by the literature where very large, almost veterinary dosages of diuretics were used historically. Now in the contemporary practice, the dosages used are smaller and these are not associated with risk. But what is the strategy that we follow is we give an infusion for 6 hours, and if there is no response, there is no decrease, no improvement in the urine output, we don't go on giving by diuretics. We just stop it and then monitor the patient. Once patient starts passing urine again in the recovery phase, you can utilize diuretics again to optimize the balance of volume, and side effects are uncommon. So why wait? Now I have a dialysis technician, there is a machine, there is a water. So why wait for a dialysis? Why not start whenever renal failure is seen? Multiple trials, including our own experience at KM, has shown that significant number of patients would recover before ever needing dialysis if we follow the strategy of watchful waiting. And this percentage can be as low as 18, which was our own experience, to about 49%. So this is a significant number of patients who will be exposed to unnecessary dialysis if we rush and start dialysis for any established acute kidney injury. This was another publication last couple of weeks back, Liberate-D trial. A conservative dialytic strategy was associated with improved recovery of kidney function at discharge. So if you dialyze aggressively, you are likely to also harm the recovery prospects from acute kidney injury. This was also our experience way back in 2013, where we found that delayed strategy favored the recovery of kidney function. So these are the worsening azotemia alone is not an indication. So indications are A, E, I, O, U. This is a mnemonic: acidosis, electrolyte ingestion, overload, and uremia, but not just azotemia. As I said, disturbances are more important than the accumulation of nitrogenous waste. So multiple trials have demonstrated that delayed strategy of initiation is to be practiced in all patients with acute kidney injury, including this meta-analysis of 2020, over 2,000 patients and multiple trials included here. So wait and watch does not mean wait and sleep. This brings in more responsibility to the treating team, and here protocol involved very close monitoring, involved nephrologists early. They see the patients, they pick up the complications and institute dialysis whenever required, and it's a team approach. It is not a consultant coming and seeing the patient and not seeing him after 3 days. This is a teamwork of dialysis nurses, nutritionists, technicians, laboratory people. So fluid overload, hyperkalemia, uremic complications, and some dialyzable toxins, clear indications. Possible indications: if you are dealing with a worsening respiratory failure, want to transfuse patient allugeric, or hypercatabolic with rising potassium. Not an indication: lactic acidosis, just rising creatinine, cytokine storm, or your habit. Underlying CKD also is an important modifier. If patient has a baseline CKD, chance of he needing a dialysis is higher. As severity of CKD goes up, chance of requiring. So we'll come briefly last 2 or 3 slides about what modality of RRT you will use in this critically ill patient with sepsis, AKI 92/40. When I ask this question in exam, people say ideally CRRT. What do you mean by ideal CRRT? So there is no ideal and non-ideal word. So we have modalities available, various modalities, and there is no clear evidence of superiority of any of these over others. And these are more important drivers of these decisions. What is your expertise available? What is the cost patient can bear? And many patients may need more than one modality. You may start with CRRT and then switch to intermittent, or intermittent started and patient is hemodynamically unstable, we switch to CRRT or SLATE. This was probably the best evaluation of CRRT, which showed not only the no superiority of CRRT over intermittent hemodialysis, but even in hemodynamically unstable patient, you can use intermittent dialysis by modifying the technique. Two meta-analysis came to the same conclusion. No difference in the mortality, no difference in the recovery of kidney function when you use intermittent. Or what is the dose of dialysis? Just enough. Target more than 1.2 kT over V in intermittent dialysis. Your machine now automatically gives this value for you. If you are using CRRT, minimum 20, but you'll have to prescribe about 25, 30 to get there. Peritoneal dialysis is very useful in specific settings of cerebral edema, heart failure, when you are not having access, and multiple children, neonates, will be eligible for only this dialysis. This will be related to contraindication. People say hypercatabolic renal failure, we cannot use PD. This was a KM experience, a randomized trial done way back in 2002, where malaria, dengue, leptospirosis, snake bite, there as well people could successfully use peritoneal dialysis, and it remains a valid modality of RRT. So concluding my talk here, AKI is preventable, don't miss the opportunity. Water is the most important toxin in acute kidney injury. So try and prevent fluid overload, use judiciously the diuretics, and dialysis is not the panacea. Try watchful expectancy, wait and watch, not wait and sleep. Just in time delivery, individualize the modality, minimum required dose. This was not covered, but follow up them after recovery. A lot of them are at risk of developing chronic kidney disease and other adverse outcomes. Arrange for their follow up. Thank you.
Thank you, Dr. Jamali, for such interesting and informative and very important topic. We have only time to take one question. Fastest finger first.
So consistent here with this case-based approach. So I think we will clap for that.
Thank you.
I would now request Dr. Santosh Salagre sir and Dr. Kavita Joshi ma'am to felicitate Dr. Tukaram sir. We now request Dr. Kaustubh sir and Dr. Vinayak sir to felicitate our chairpersons, Dr. Santosh Salagre sir and Dr. Kavita ma'am.
One of our next speaker, so we are postponing the deliberation of minutes and we will take and then we will take from.
So moving on to our next session, the topic being acid-base disorders in critical care. For this, I would like to invite Dr. Nitin Sarate sir and Dr. Neelam Redkar ma'am to be our chair people. Dr. Neelam ma'am is a professor and head of Department of Medicine at HBTMC and RN Cooper Hospital, Mumbai. She is the academic dean at HBTMC and Cooper Hospital, Medicine and Nephrology. Her special areas of interest lie in internal medicine and nephrology. She has many publications in reputed journals, both national and international, and she is an NMC recognized teacher for PG students. We welcome you, ma'am. And now we'd like to invite our speaker for the session, Dr. Trupti Trivedi, ma'am.
Good afternoon, everybody. It gives me great pleasure to introduce my friend, colleague from Sion Hospital, Dr. Trupti Trivedi, who has a keen interest in critical care. She is an excellent teacher, academician, and researcher. I know it is a pre-lunch session, but all of you please be awake to learn acid-base disorders from her, because she has been taking these lectures since many years, and I am sure she must have made this. She will definitely make this complex topic very simple. Over to you, Dr. Trupti.
Thank you very much. First of all, congratulations and compliments to everybody in KEM for this centenary celebration. And thank you, Neelam and Sarate, for kind introduction. Yes, I am from Sion, presently in KEM for this lecture. And today we are going to discuss AIMS. So that is ABG interpretation made simple. So I have absolutely no intention of doing this, what is shown after this tutorial. I'm going to do is just introduce the basics, and then we go to cases and discuss the various scenarios and how ABG is going to guide us in diagnosis and treatment. So these are the values that we get in ABG. Now, you all are aware of these normal ranges, but what we must remember that this PaO2 is actually dependent on age, at what height you are, and at what FiO2. So if someone gives me this ABG, is this normal patient has hypoxia or no? For that, I will need to know that at what FiO2 this ABG is taken and at what altitude the patient is. So we all know about this basics of ABG interpretation, when to call acidosis, what is respiratory, what is metabolic. So I will skip this. So we straight come to first case, 22-year-old female who comes with sudden onset of breathlessness. She has no fever or cough. She has tachycardia. Pulse is 108, BP is 100/70. She is tachypneic also. Saturation is 92 on room air. Chest examination, RS clear, CVS nothing significant. This is the ABG. 7.55, PCO2 27, PaO2 93, bicarb 22. X-ray, ECG, ECG showing just sinus tachycardia. So this ABG is showing obviously respiratory alkalosis. So what is the next thing? How many of you think she is hysterical? Yeah, few of you think it is hysterical. Is there anything abnormal apart from respiratory alkalosis? Tachycardia she has, she might be anxious, water. Hypoxia, yes, exactly. So PO2 at room air of 93 may be normal for some, but if you calculate A by A gradient, so next we will see that. So what is the difference between alveolar and arterial O2? If we calculate that, her A by A gradient is 24. For that age, it is little high. So she has definitely hypoxia. So we should rule out PT before labeling her hysterical. So basically what is A by A gradient? Is the difference in oxygen that is there in the alveolus and in the arterial blood. So different areas of lung have different ventilation. So on an average, there is A by A gradient. For different age group, it is different. So alveolar gas is ambient gas minus what displaces it from there. And from that you subtract arterial PaO2, what you get in ABG. Then there is a complex formula, but for room air, the formula is not so complex. 150 minus 1.2 into PCO2 at room air will give you alveolar O2, and you subtract arterial O2 from that. So I will tell you what is the difference. It is age upon 4 plus 4. That is the A by A gradient. So that is at room air. So if person is breathing on oxygen, then A by A gradient will keep on increasing. So for a person at sea level about 20, 4 to 17 is normal, but for elderly person 25 to 38 may be normal. Now, why this A by A gradient gets affected? First of all, most important thing is when it is perfusion and ventilation mismatch. So, lung disease is mainly airway disease or parenchymal disease, pulmonary embolism, all of them. So, here increasing FiO2 will help improve oxygenation slightly. But whenever there are intrapulmonary shunt or extrapulmonary shunt, the giving oxygen may not help that much, especially in extrapulmonary shunt. Second case scenario, a 68-year-old woman is being evaluated in ED for acute onset dyspnea. There are no comorbid conditions. I have not given examination findings for some reason. Now this ABG is showing acidosis, CO2 is high, PaO2 is low, and saturation is 84. Now looking at this ABG, what is obvious? She has respiratory acidosis, right? That is one, and that is hypoxia. So if we see whether it is acute respiratory acidosis or chronic. So in acute respiratory acidosis, the pH change is significant for PCO2, and in chronic it is less significant. So in this setting, since the pH is so low, it is likely to be acute respiratory acidosis. And if we look at her A by A gradient, which comes to 27, but for that age, it is not that significant. So here hypoventilation is the reason why patient is hypoxic. So here we have to look at pneumothorax, okay? Plus she has got a slight acidosis, and that can be explained by lactic acidosis. So this is how ABG helps you in solving respiratory illnesses. Now we come to metabolic parameters. So whenever metabolic acidosis is there, traditionally we classify them into anion gap acidosis and non-anion gap acidosis. So anion gap acidosis because of accumulation of organic acids, and normal anion gap acidosis is because of loss of bicarbonate. Now, if we see the principle of electroneutrality, actually in body there is no gap. It is just that we are measuring very few cations and even less anions. So it is the difference between unmeasured anions and unmeasured cations which gives this anion gap. Now, whenever we interpret ABG, most important thing, even before we see the report, is look at the patient's history and examination and what setting it is. So from that we get an idea what to expect, and then ABG interpretation becomes very, very simple. So we all know that vomiting causes alkalosis, diarrhea usually causes acidosis. If there is severe diarrhea with shock, it can cause even lactic acidosis. And cirrhosis, pregnancy cause respiratory alkalosis, and renal failure, decay cause metabolic acidosis. So if we know this, plus diuretics lead to alkalosis. So if we know this much, we know what to expect, and then we can verify whether that is there in ABG or not. So if we do step-by-step approach, first step will always be I think before this will be identification. See that you are interpreting same ABG of that patient, not of some other patient. That's the first step. Next will be history and whatever you are expecting. Then when you see ABG, first check oxygenation, ventilation, then look at pH, whether there is acidosis or alkalosis, and then find out whether that pH is being explained by CO2 or bicarb. So that is a primary disorder, whether it is respiratory or metabolic. Then if it is metabolic acidosis, look at the anion gap. If anion gap is acidosis present, if the scenario suggests, then rule out other causes like concomitant metabolic alkalosis or normal gap acidosis by calculating delta ratio, and then use formulas and see whether compensation, because whenever there is a metabolic problem, respiratory compensation should be there, and whenever there is respiratory problem, metabolic compensation. So whether that compensation is present or no, because if it is not there, that means there is additional disorder. So these are some of the formulas for compensation which we all know, that expected PCO2 is 1.5 times bicarb plus 8 plus or minus 2, and in alkalosis 0.7 into bicarb plus 21 plus or minus 2. And in acute respiratory acidosis, for every 10 rise in CO2, the bicarb will rise by 1, while in chronic it will rise by 4. So in anion gap acidosis, these are the normal causes. And if we find normal anion gap acidosis and the cause is not obvious, like diarrhea, then we might have to do urinary anion gap and see whether there is underlying renal tubular acidosis. In metabolic alkalosis, what we need to look at is the volume status of the patient. If patient is hypovolemic and has obvious causes like vomiting, you have to simply hydrate the patient. But if the cause is not obvious, see urinary chloride. If it is more than 20, that means it is chloride resistant. Hydrating patient won't help, and less than 20, then it is chloride responsive. Now this is the third case. 60-year-old homeless man presents with nausea, vomiting, poor intake for 2 days, and he had 3 days of binge drinking prior to admission. Now this is his chemistry: sodium 132, potassium 5, chloride 1.3. His ABG shows pH of 7.3, bicarb 16. Anion gap is 12. So is this normal anion gap acidosis? Normally anion gap is 12. So is this normal anion gap acidosis? Why? Excellent. So we have to correct anion gap if albumin is low. So if albumin is so low, like from 4 it has become 1. So for this person, the normal anion gap is 4.5. Okay. So this is definitely, in spite of being the value being 12, it is wide anion gap acidosis. So this could be alcoholic ketoacidosis. So correction of anion gap is required when albumin is low or phosphorus is low, or anion gap may be high if there are increase in unmeasured cations like hypercalcemia, hypermagnesemia, or multiple myeloma. Why we are doing so much about metabolic acidosis? So what if there is acidosis? Because we know that patients will hyperventilate to compensate, that's fine, but then cardiac function is diminished, and as Dr. Tukaram just now said, even renal failure, if we correct it, might get corrected. I mean, we may not need dialysis. So symptoms and signs arising out of acidosis can be life-threatening, especially when pH falls below 7.2 and bicarb falls below 10, unless it is decay. Otherwise, you treat this acidosis. Now, common causes of increased anion gap acidosis are lactic acidosis, which may be type A, which is hypoperfusion, and type B might be drug or sepsis related. And D-lactic acidosis is usually seen in surgical setting. Other important causes are ketoacidosis, poisonings, and renal failure. Now, there are many mnemonics to remember causes of metabolic acidosis, but it is always important to know the common causes first, rather than what comes first in mnemonic. Okay, now this 45-year-old man found to have at home confused and drowsy after a binge of country liquor, and he was tachycardic, hypotensive, acidotic, and these are his labs. Okay, so here his bicarb is 10, BUN is 14, ABG shows metabolic acidosis, and anion gap is high. So what next you should do? Is this plain and simple metabolic acidosis? If so, why? Or should we do something else? Yes, so we have to think, because this is country liquor, whether we are dealing with methanol poisoning. So clinical signs would be vision loss, unconsciousness, sometimes icy bleeds, coma. So here we have to see osmolality. Means how do we see osmolality? We have to do measured osmolality and calculated osmolality, because calculated is by formula which will take into account sodium, BUN and glucose, while osmolality measured will be directly measured. Usually there is a gap of 10. So if that gap is here, it is elevated 50. In this patient, the measured osmolality was high, 340, and calculated came 290. So this 50 roughly corresponds to that much of methanol. So these are the different causes of osmolar gap, but these are associated with acidosis: methanol, ethylene glycol, renal failure, and ketoacidosis. Ethylene glycol, sometimes can be adulterating some medications like glycerol and all. And without acidosis, ethanol, isopropyl alcohol, or TURP. Now, 28-year-old female came with hypokalemic quadriparesis. ABG shows what? pH is 7.28, so acidosis. Bicarb is 14, so metabolic. And PCO2 is low, but it is compensation. Potassium is low. Okay, so this is metabolic acidosis with hypokalemia. Usually in metabolic acidosis, there is hyperkalemia, but here there is hypokalemia. So here your interest will be to see whether or no there is renal tubular acidosis. But before that, you will have to see whether it is gap acidosis or normal anion gap acidosis. So in this case, this is normal anion gap acidosis. So if there is no obvious cause like diarrhea, you will have to calculate urinary anion gap. And if urinary anion gap is positive, okay, then you will think of renal etiology. And if it is negative, it is GI cause. Okay. So if it is positive, as in this case, then you have to suspect Sjogren syndrome. So in normal anion gap acidosis, the cause can be either GI or renal. What is this ammonia genesis? Roughly equals to regeneration of bicarb. So when kidneys are normal, in response to acidosis, they will excrete H ion. That H ion will bind with ammonia and ammonia will be excreted. So ammonia genesis will be normal, unaffected. So more ammonia, less is the urinary anion gap. But in renal tubular acidosis, that is not possible, and that's why urinary anion gap will be positive. Now, this is a previously well 55-year-old female who came with complaints of severe vomiting for 5 days. On examination, she has marks of hypovolemia, postural hypotension, tachycardia, diminished skin turgor, and electrolytes are showing slightly lower side potassium. Fluoride is also low, and ABG shows this. So bicarb is 9, so there is acidosis, okay, and PCO2 is 22. So based on history, whenever a person is vomiting, metabolic alkalosis should be expected. But if that vomiting is very severe and has led to hypovolemia, lactic acidosis, acidosis is also possible. So here pH is less and patient is acidic. And if you go step by step approach, then there is metabolic acidosis is there, and low CO2 is compensation. Now if we calculate anion gap, it is high. So wide anion gap acidosis. Now compensation is adequate in this patient. But if hagma is present, high anion gap, but whether she has additional metabolic alkalosis or no, if you want to know that, then you will have to calculate delta ratio, and for that you have to take delta anion gap upon delta bicarb. If it is more than 2, then there is likely concurrent metabolic alkalosis, and if it is less than 1, then there is additional normal anion gap acidosis. So in this patient, the final assessment would be mixed elevated anion gap acidosis and metabolic alkalosis, both, because of vomiting and hypervolemia. So this is the delta-delta ratio which we spoke about. Now metabolic alkalosis, you have to see basically two things, whether it is chloride responsive or chloride resistant. So patient is hypovolemic, chloride responsive, and in those patients urinary chloride will be low. But if urinary chloride is high, more than 15, then likely patient has some endocrine cause or milk alkali syndrome. Treatment of metabolic alkalosis is hydration mainly. Okay? If it is chloride responsive. If it is not chloride responsive, then you have to stop the culprit agent and treat the underlying cause. Now, 22-year-old female came with attempted overdose and unknown amount of multiple tablets she has taken, and she is in respiratory distress. This is her ABG. pH is nearly normal. PCO2 is 19 and bicarb is 14. So she has respiratory alkalosis and metabolic acidosis. What is the possibility? Salicylate. Excellent. So if we see, it is wide anion gap acidosis, and this patient ASA level was high and salicylate poisoning. Now 60-year-old male admitted for AWMI. Suddenly saturation drops to 86%. Pulse 88, BP 140, 80, RR 18. ABG on 3 liter is this. PO2 is 126. What is the likely cause? Why saturation is dropped? Very good. So whenever there is a saturation gap, because this is very important in ABG, saturation is not actually measured. It is calculated based on PaO2, while pulse oximetry measures saturation. So whenever there is a saturation gap, you have to think of abnormal hemoglobin. Now this is the last case, not the last slide, but last case. And it is for actually all PGs who are working in EMS. 62-year-old diabetic DKD on diuretic comes with swelling and redness of leg for 7 days. And in surgery OPD, he was treated for cellulitis. And now he has developed breathlessness. Pulse 112, BP 11670, RR 24, chest is clear. ABG shows pH of 7.45, PCO2 25, PO2 55, bicarb 15. Okay. Chloride 95, creatinine is slightly high 2.2, but he is DKD. HGT is 180, US UK negative. X-ray shows cardiomegaly, mild, but ECG LVH, but these are same as previous. I mean, there are no fresh changes. So there is a fight between surgery and medicine resident, whether patient should go to medicine side or surgery side. What do you think? Why medical side? ABG is abnormal, the cause is sepsis. So they PT. Why PT? Excellent. Hypoxia is there. Yes, very good. So we have to again here see what is the see in this patient there is respiratory alkalosis because of sepsis, and bicarb is lower than expected. So there is metabolic acidosis also, and high anion gap acidosis is there. Delta ratio is 2.4. Additional metabolic alkalosis there. Maybe is on diuretics. Okay, but A by A gradient, if you calculate, it is 65, and for that age normal is 17 to 31. So it is worth ruling out PT, so he will come to medical science. So life is a struggle, not against sin, not against money, power, but against HINs. And if you have any further doubts, there are facilities available. Thank you very much.
Thank you, Trupti. It was extensively covered in a very short span, and I hope all the residents here must have definitely benefited. One or two questions if they have. Where did the patient go finally? Medicine or surgery?
Patients always come to medicine.
I remember Madam had said in her farewell speech, it is very difficult to say elective medicine. I remember that slide, Madam. Sir ने क्या बोला? हाँ, yes, yes. Okay, thank you, Dr. Trupti, for an excellent lecture.
We now request Dr. Nitin sir and Dr. Neelam ma'am to felicitate our speaker, Dr. Tripti Trivedi ma'am. We now request Dr. Santosh Salagre sir to felicitate Dr. Neelam ma'am and Dr. Nitin sir. We now request Dr. Meghna ma'am to felicitate Dr. Nitin sir.
Already, right? Okay, now what we have done, we have a short lunch break. So we have divided the speakers, chairpersons, and all the faculty members from various institutions will come to us with the department, and all the my younger colleagues will go in the central room, quick lunch, and we will come as if we are on duty, right? So we will have a, and then Dean Madam is coming here at 2 o'clock. So before that, we will be all here, right? So we have typical during emergency EMS lunch break. Come on, chalo. So all the faculty members come with us, all teachers, all the we have a washroom here also in the department.
हाँ ठीक ये हाँ अभी 10 खुल रहा है हाँ ठीक है चल निकाल
There is a minister meeting with the madam. So what we are going to do is we have the pleasure of inviting our own madam, Maulik madam and Karnar sir. Please do the honors of inaugurating this particular with a round of applause. So, madam, please come. You are our. So it's and madam only has requested that please take Maulik madam and Karnar sir, and she had to go. She had to go because of ministers meeting. So that's the only thing. Come, sorry. So yes. Now you take over. It's our pleasure. So
So now we have the pleasure to welcome Dr. N.D. Maulik ma'am and Dr. Salagre sir. Dr. Santosh Salagre sir will be giving the welcome bouquet to Maulik ma'am. Now we would ask Dr. Nitin sir to provide the welcome bouquet to Dr. Nitin. Dr. Dilip Karnad sir. For lamp lighting, we are being joined by Dr. Prakash Jayamdani sir and Dr. Neelam ma'am.
now start the session.
Group photo for that.
Please come. Prakash, take it. Prakash,
thank the organizing team for giving me this chance to inaugurate it, even if it is by default. It's just that I happen to be here. I want to say one word about Nitin. He's looking so refreshed, younger, fairer. I wouldn't have recognized him, but it's nice to know when your students grow up and prosper. Everyone will prosper as per time because you move from younger to older and move up the faculty and whatever. But I never thought he would go into ICU, and so whatever are the responsibilities given to him, I'm happy that he's doing a good job. We did see ICUs change in KM from Dilip Karnad to Karnik to Vishal, and now I think it's Nitin, and just wishing you all the very, very best. So congratulations to him on your centenary celebrations, and I'm sure you'll go to much higher, greater heights. Thank you. Thanks.
Thank you, ma'am, for your kind words. For the next session, I would like to invite our chairpersons, Dr. Nitin Sarate, sir, and Dr. Neelam Redkar, ma'am. For the next session, I would like to invite our speaker, Dr. Prakash Jiandani, sir.
Good afternoon, everyone. Our speaker, Dr. Prakash Jandani, sir. Sir is a consultant intensivist in Critical Care Asia Multi-Speciality Hospital, and he's a recognized teacher in Hall Fellowship in Critical Care by National Board, recognized teacher for Diploma and Fellowship in Critical Care by ISCCM, and he has 40 years of experience in critical care. So he's a life member member of Indian Society of Critical Care Medicine. He has participated in research in critical care and published numerous national and international papers. Over to
Thank you. At the outset, I would like to thank Dr. Nitin Sarate for giving me opportunity to speak here. When he told me to speak on this topic, I thought that probably it reminded me of the last oration I had given for my Maharashtra Criticon, where I had spoken for 2 hours, and at the end of the talk, I said if I have to sum my talk in one line, the major job of an intensivist is to only take a decision whether to पानी देने का या पानी निकालने का. That is the major, and people take it very, very lightly. So see, I came from an era, if Dr. Karnad will remember, in the 90s, 2000, we were trained. बीपी कम हो गया, फ्लूइड दे दो. कितना दे दो? देते रहो जब तक बीपी ऊपर नहीं आता है. यूरिन नहीं आया, फ्लूइड दे दो. So the fluid was the magic therapy for everything. So as Paracelsus said, that all things are poison and nothing is without poison. Only the dose permits something to be poisonous or not. So ultimately the question was that we were using fluids for everything. Urine output went down, we gave fluids. Patient looked sick, we gave fluids. BP fell down, we gave fluids. So ultimately the panacea for all the problems in the ICU was to give fluids for everything. Like other drugs, it is the dose of fluids that makes them poisonous. So is it really true that drugs, fluids can be poisonous? And when we talk of hemodynamic monitoring, I can talk of a lot of big things, and I would like to give credit to Tata Hospital. Again, Dr. Karnad will vouch for it. For the last 30, 40, 50 years, I remember, the best hemodynamic monitoring workshops are conducted by Tata. I think all people who do MD medicine should compulsorily attend the Tata Hospital workshop for hemodynamic monitoring. It is fantastic. It clears your thought process, and they are excellent.
and they are excellent since I just can't remember, backdated when it is. And every year they will have a conference on hemodynamic monitoring, which I think all people who do MD medicine, you need to spend 1 day to attend their conference of hemodynamic monitoring. So what is hemodynamic monitoring? Is the measurement and analysis of cardiovascular parameters like blood pressure, cardiac output, heart rate, and effectively the basic thing what we need to evaluate is that how to go about improving tissue perfusion. Now, if you see what is the endpoint of hemodynamic monitoring, why are we doing hemodynamic monitoring? Hemodynamic monitoring includes monitoring blood pressure, cardiac output, vascular resistance, and other parameters. The basic purpose of hemodynamic monitoring, I think the first and the foremost, is to identify whether a patient is stable or unstable. So monitoring, if you are monitoring a patient, you would probably pick up an abnormality earlier than before when it becomes manifest. The second thing is, when we are treating patients, hemodynamic monitoring also would guide your therapy. It ensures tissue perfusion, and also at the end of it, when we are adjusting or altering hemodynamic variables, we need to see the effect on therapy, what it makes a difference. The types of monitoring could be invasive, non-invasive. We have upstream markers, we have downstream markers. The mainstay of monitoring at one point of time, again in way back in 90s, was the pulmonary artery catheterization. So I left Sion Hospital in 97 and I joined Leelavati Hospital. It's a very interesting story. So in the first 7 days, there was a patient admitted, and I saw the patient, and at that time the concept of an intensivist was very, very unusual. The physicians were gynecologists also, forgetting endocrinologists, cardiologists, even gynecologists were the physicians. So a patient was admitted, and I called up the physician and told him that this patient is admitted and we need to intubate the patient and put a pulmonary artery catheter. This is in 97. He said, "Do not touch my patient." I said, "Okay." So he came, saw the patient, he said, "We'll intubate the patient." And yes, he said that theoretically, yes, you are correct. We need to put a PA catheter. But you people who come from teaching hospitals, you only know how to speak big things. You read in the books, you come. Trupti will vouch for it. I never read anything. I was only a worker. So he said, "Can you put a PA catheter?" I said, "Yes." So what I want to tell you is that even 97 in Sion Hospital, we used to put PA catheters. So you can do it now also. Unfortunately, over the period of time, in 1996-97, the same time, Connors published a trial study which showed that the mortality in patients where PA catheter was put was much higher than where PA catheter was not put for the comparative illness. So what he said is that it is the PA catheter which is killing patients rather than saving patients. Now, if we read the last 3 lines, that when we put a PA catheter, we take 3 presumptions or assumptions that the data from the PA catheter generated will be accurate. That is the first thing. But the most important thing was that whether the interpretation of the data is more important. So subsequently in 2003, 2004, luckily, there were 2 trials, Sandam and I don't remember which was Pacman trial, I remember, yeah. Pacman trial came in 2004 where they clearly said that the mortality was not high in patients where PA catheters were put. And when they analyzed the data, why the mortality was high, it was not related to the technical complications of the procedure. It was purely related to misinterpretation of data. It was doctors were not educated enough to interpret the data and take the correct decisions. So we should not throw away the PA catheter, and the PA catheter has a very important role even today in monitoring. There are 2 subsets of patients where even today, till 2010, we were putting PA catheters routinely, and I don't remember offhand we had a technical problem with the PA catheter. But there were 2 subsets of patients. Of course, you will see patients coming with CABG will have a PA catheter, but of course the number is going down. But there are 2 settings where compulsorily we even today put PA catheters. Is one, patients with ARDS, patients with a severe ARDS with shock, patients with ARDS with pulmonary hypertension with a right heart dysfunction. So anything which interferes in the circulation, starting, so if you see the circulation, we have the right atrium, right ventricle, pulmonary artery, left atrium, left ventricle, aorta, and the pulmonary veins. So if there is a continuity maintained between the right atrium and the left atrium in the entire circuit, by and large, other pressures would be adequate. But if you have a fault somewhere, you have a severe TR, then probably the other pressures would not be reliable. So that would be the indication of putting in a PA catheter. So ultimately, when we see that what is the basis of hemodynamic monitoring, it is resuscitation. Resuscitation is basically mainly aimed at ensuring optimal oxygen delivery to the tissue. Oxygen delivery depends upon the cardiac output and the oxygen content. Cardiac output depends on the heart rate and the stroke volume. Stroke volume depends on the preload, force of contraction, and afterload. So, what is shock? This is the clear-cut, very common definition of shock, which I will not go into details. So, the oxygen delivery, if we take the oxygen content to be normal, the delivery of oxygen to the tissue, which is DO2, and the oxygen uptake, which is VO2, which is the uptake, is totally, if one variable is content is constant, it is depends on the cardiac output. So as the cardiac output keeps on dropping, as the cardiac output keeps on dropping, you realize that the delivery of the oxygen also keeps on dropping. But the body has built-in protective mechanism that even though the body ka oxygen delivery may fall down, the uptake continues to be constant till a point of time is reached where when it falls further, the uptake also reduces, and this is the critical point where you start getting lactic acidosis. So this is the critical point of the whole thing. Now, this is what is the actual definition of life. This is from science, and I have told you 100 times. Life is defined as the ability of a cell to generate ATP. A cell is alive if the cell generates ATP. If the cell does not generate ATP, the cell is dead. So death is defined as inability to generate ATP. There are certain cells which vary in their ability to generate ATP under anaerobic conditions. So what happens progressively in shock? When the stroke volume falls, the cardiac output falls, the oxygen delivery to the tissue falls, and eventually it stops. So the cells would get damaged and the cells would die. Now, it depends on the ability of the cell to generate ATP under anaerobic conditions. So if you see the brain cell is the worst of the lot. It will not sustain hypoxemia or lack of oxygen. It will be able to generate, see, when we see glycolysis, we generate 2 molecules of ATP in glycolysis and 36 molecules of ATP in the Krebs cycle. Under anaerobic conditions, Krebs cycle is out. What we have left is the only glycolytic pathway where we generate 2 molecules of ATP for 1 molecule of glucose and oxygen. For 1 molecule of glucose, sorry. Now, the brain is a hypermetabolic structure. The ATP demand is huge. So it can survive for 3 minutes, 4 minutes, 5 minutes with 2 molecules of ATP. Then it starts decaying. In 10 minutes, the brain cell is dead. The same thing is with the heart. And surprisingly, I'll ask you a simple question. What do you think is, how do we give PR basis? Dr. M.B. Agrawal is here. He will start laughing at me. I remember Seth told me once that you will not pass MD. So blood has an indefinite capacity to produce ATP under anaerobic conditions. That is the reason why you can store blood in the blood bank for a prolonged period of time, unlike other tissues which cannot be transplanted. So the red cells have a very long capacity. Means even under anaerobic conditions, the red cells can make ATP. So before we go into the monitoring, what we need to understand, I always say that ultimately all monitoring is an extension of physiology. And unless we do not understand physiology, we would not be able to do any progressive monitoring. So cardiac output is equal to heart rate, stroke volume. Stroke volume is preload, force of contraction, afterload, and the chronotropy, of course. And importance in this is what we need to go back to is what is called the Frank-Starling law. The Frank-Starling law is very clear. The force of contraction of the heart is directly proportional to the end diastolic fiber length. Now, end diastolic fiber length actually depends on the left ventricular end diastolic volume. Now, since it is very, very difficult to measure volume, what we take is pressure, which is as a surrogate marker for volume. So when we say left ventricular end diastolic pressure, left atrial pressure, pulmonary capillary pressure, pulmonary artery pressure, right atrial pressure, right ventricular pressure, we are actually using it as a surrogate marker, assuming that there is a linear relation between pressure and volume. So once we increase the preload, the stroke volume will increase. The second thing is, if we increase the force of contraction, stroke volume increases. And lastly, if we increase the afterload, the stroke volume would reduce. So if we need to increase the stroke volume or the cardiac output, we need to not increase the preload. We need to optimize the preload. That is the first thing. We need to increase the force of contraction of the heart, and we need to reduce the afterload. So one of the reasons why, so when we say preload, as a clinician, I understand as a physiologist it is very important. But as a clinician, what we need to see is, when we assess the preload, we need to understand whether this preload, this heart will respond to a increasing in the preload. So if I increase the preload, will the cardiac output or the stroke volume improve? So if you see, what is assessment of, so ultimately when we monitor 10,000 parameters, you know what we are monitoring? A single thing. What we are only looking at, whether this car stroke volume will increase with optimizing the preload. So ultimately, all our major of all our monitoring parameters are basically related to seeing whether there is a optimization of the preload. Now, also we need to understand the heart-lung interface, which is very important in understanding all the data. So whenever, and majority of this data arises from patients who are mechanically ventilated. So mechanical ventilation, sorry, again I'm. So mechanical, yeah. So mechanical ventilation, during inspiration, the pleural pressure increases, the transpulmonary pressure increases, the RV preload goes down because the RV filling is impeded because of the increased positive pressure. There is an increase in the RV afterload. So ultimately what it culminates is that at the end of systole, the pulse pressure maximum is generated at the inspiration. So ultimately, I am cutting it short. What I have said, once the intrathoracic pressure reduces, the preload on the heart reduces, and automatically the stroke volume comes down. So that is the dynamic alteration which occurs, which produces the coupling in the respiration and the heart contraction. So coming now to what we are going to measure is what is important. So what we measure ultimately when we do hemodynamic monitoring, of course, we measure the pulmonary artery occlusive pressure. But over the last 20, 25, 30 years, I do not remember putting a pulmonary catheter for the last 3, 4, 5 years. So something has replaced the pulmonary artery catheter. We'll come to what has replaced. That before that, routinely we were using pulmonary artery catheters. But if pulmonary artery occlusive monitoring is an invasive monitoring. It is a very difficult monitoring. It is very difficult to put catheters, PA catheters. It takes less than a minute to put a PA catheter. So it is not difficult at all. So it is a very wrong concept. Technically, it is a very difficult job. It's a very simple job putting a PA catheter. CVP and the right atrial pressure. These are static monitoring pressures. So what are we looking at? That when we measure the CVP, I remember my days in Science. We used to take out the line, distal port, watch like this, kitna hai? 5 centimeter, 7 centimeter. We improved in Cyan a bit. What we did was, on the IV stand, we would put a scale, fill it up with saline, and open the stopcock and see what the thing is. But lately, we have been using transducers to measure the CVP. Again, if you see, why I am telling you is that there is a hesitation of using transducers. The first hesitation is, do we not have monitors? I'm not sure. I think we have monitors which are capable of achieving hemodynamic monitoring. The second thing is, in the old times, Dr. Dilip Karnad will remember when we were using reusable transducers, it used to be a big headache. Today we have disposable transducer circuits and the cost will not exceed 800 rupees a day. Now the cost of a bactroviral filter on the ventilator, which we change regularly in KM, am I sure? Correct, we are changing the filter, is 800 rupees. The cost of a transducer is just 800 rupees. So it is not that it is beyond our means in terms of technology or finance that we are not able to use a monitoring device to actually measure. Then what are the dynamic measures of fluid responsiveness? So these are static measures which we'll come to how effective they are. We have the systolic pressure variation, we have the pulse pressure variation, we have the stroke volume variation, respiratory variation in the IVC diameter, and we have the passive leg raising test. Now these are very, very important. So as we go, the first question arises, does central venous pressure predict fluid responsiveness? So majority of the times, why do we see the CVP? If the blood pressure is 130/90, no one bothers to check the CVP. So we would check CVP only if the blood pressure falls down, if the urine output falls down, or if the lactate is going up. Correct? We have altered mentation. So there are three endpoints easily which we titrate where we need to optimize the stroke volume and the cardiac output. So does the CVP correlate with intravascular blood volume? Very clearly it has been proved that CVP has no correlation with intravascular blood volume. And the second thing is that if we see the response to fluid challenge, it is only in 56% of the patients where the CVP would actually, on a basis of a low CVP, you give a volume and the patient's stroke volume, cardiac output, pulse pressure, whatever improves. So CVP is not a very good indicator to measure for the preload. And more important, measurement of the preload ultimately does not translate into any therapeutic intervention which is beneficial. So CVP is not a good indicator. Again, this I will not go into the details of this, a very complex slide. Now, so the second thing what we monitor is the arterial pressure. The only pressure measurement which is reliable, consistent is invasive arterial pressure monitor. Non-invasive pressure is not reliable at all. Again, as I told you, majority of the times the cost would be the cost of a simple 20 gauge cannula and a 800 rupees transducer. The cost, if you have a monitor, what additional cost is entailed is one cannula and 800 rupees. So if we see what we have the anacrotic wave, which is the upstroke. We have the dicrotic wave, we have the dicrotic notch. So the upstroke or the systolic pressure. So I was in Sci and I remember I used to teach people that how do you differentiate what are the types of shock? Only on the basis of a blood pressure. So the systolic blood pressure would reflect the stroke volume. The diastolic blood pressure, everyone is aware, reflects the peripheral vascular resistance. The pulse pressure, which is the difference between the systolic and the diastolic, reflects the stroke volume. And lastly, the mean arterial pressure reflects the driving force or the pressure head which actually perfuses tissue. So the systolic pressure we use for monitoring, diastolic we use for monitoring, pulse pressure we use for monitoring, and the mean arterial pressure is the target which we want. By manipulating these three pressures, what we want is the mean arterial pressure to reach at this level. So when we say in septic shock, the goal of therapy is to maintain a mean arterial pressure of, you can stop me when I'm finishing, I'll go fast, when 60, 70, 80, whatever we want. So these are the exact phases of the blood pressure curve. So blood pressure monitoring is not very difficult. We commonly use the radial artery, the femoral artery. I have cannulated axillary artery. It is not difficult at all. And we, of course, not there in the books. What we used to do, we used to actually use the distal most, the dorsalis pedis for cannulation also. So standard what is used is the radial artery and the femoral artery. So when we measure blood pressure, it is a fixed variable. It is not a dynamic variable. Whereas the systolic pressure, so unless you do not have an arterial line, how are we going to measure systolic pressure variation? So there is no way to measure systolic. So when people talk of systolic pressure variation, if you are not putting in an arterial line, we will never be able to generate a waveform where we are able to actually derive the systolic pressure variation. A systolic pressure variation of more than 10 indicates that this patient will respond to volume, and a systolic pressure variation of less than 5 will indicate this patient is not going to be volume responsive. So we have what we have is basically we have the pulse pressure variation, the systolic pressure variation, and ultimately all these parameters would only be generated if we are able to generate a arterial pressure. So a pulse pressure variation of more than 13% indicates this patient will be volume responsive. A stroke volume variation. Now, a stroke volume variation is not only do you need a arterial line, you need a monitor which is able to actually calculate the stroke volume. So what are the limitations of when we say the dynamic parameters? Now, always this one slide we'll take, the limitation of dynamic measure is that they are not in spontaneous ventilation. So when we talk systolic pressure variation, pulse pressure variation, all the variable dynamic parameters are only in ventilated patients. You do not interpolate the data from a ventilated patient to a spontaneously breathing patient. It is not reliable in cardiac arrhythmias. It is not reliable when the lung is very stiff. It is not reliable in an open chest. It is not reliable in an intra-abdominal work. It is not reliable in a high respiratory rate. It is not reliable in heart failure. So if you notice that majority of the settings where we actually, so that is where we go back to the PCO2, why the pulmonary artery catheter mortality was high, because we do not interpret the data generated from these values. So if you use the data generated on pulse pressure variation, stroke volume variation in all these settings, that data is going to be wrong. So what is the single parameter, if I was told, which will obviate all these? So of course, one is the end expiratory occlusion. The same thing it applies to. At the end of expiration, hold the ventilator for 15 seconds, measure the pressure and stroke volume and everything will go up. But a single important thing which obviates everything, which is very simple, which needs no cost, which needs an arterial line, is, of course, one thing is what has replaced? Why we have reduced using invasive pressures? Nowadays, we don't even use the CVP monitor. The reason is because with the advent of ultrasound, the utilization of invasive measures has really gone down. What we see is the IVC distensibility index in ventilated patients. We see the collapsibility index in non-ventilated patients as a measure of VA. Again, these are various algorithms which we will not go into the details. Now, this is the single most test which has no limitations. Ventilated, non-ventilated, high pressure, low pressure, high volume, low PEEP, high PEEP, arrhythmia, atrial fibrillation, no atrial fibrillation, low tidal volume, high tidal volume. It has no variables. A passive leg raising test only needs an arterial line. You just need to raise it by 45 degrees. The advantage of a passive leg raising, it is an endogenous fluid challenge, or it is a mini fluid challenge as we call it. The problem is when we have a very borderline lung, we have a poor LV function, where you are worried that even a 300 ml volume challenge is going to be hazardous. That is what you do. You just raise the legs by 45 degrees, hold them for 30 seconds. If there is a positive response of more than 10%, these patients will respond to fluid. So ultimately, what is most important is that a simple test which is easily available is, and of course there are a lot of other parameters which we can measure but for all these parameters we need a device. So what is our most important thing is when we are manipulating the preload, what is our target? Our target has always been to improve tissue perfusion, to decongest the lung if the lung is full. So पानी देना है कि पानी निकालना है. So what do we monitor? So all these markers are upstream monitors. These are upstream monitoring parameters are ones which we manipulate. We manipulate the stroke volume. But at the end of it, whether monitoring the stroke volume, where they are changing, increasing the volume, actually is it helping the patient? So in the old times, of course, it has been mistaken that there are simple things which we can actually monitor. But if you ask me a single parameter in the old times, which over the time has become totally deviant. When we used to measure urine output 25 years back, it was called a poor man's cardiac output. Today, the urine output is a holy grail for the nephrologist. Kidney fails or does not fail does not matter. Urine आना चाहिए. Whereas ultimately, one of the best markers to see if tissue perfusion, which is the best marker according to me, is a simple urine output. If the urine output is good, your renal blood flow is good, your cardiac output is good. But the nephrologists don't like it. They will come and add furosemide. I think you saw AKI guidelines. Dr. Jamale presented that furosemide actually, if you see the KDI guidelines, increases mortality in acute kidney injury. It prolongs the recovery of acute kidney injury. It is not indicated to be used excepting for a fluid, adjusting fluid balance. So if you have fluid overload pulmonary edema, that is different. So urine output is one. The second thing is the lactate. If you objective measurement, if you want for ensuring, so you have a lactate which is 5. You have done some manipulation, whatever. You have added fluids, you have added noradrenaline, you have added vasopressin, you have added an inotrope drug, dobutamine, and your lactate comes down. Then means it is successful resuscitation. So that is the second thing, and there are multiple other parameters. The simplest thing what we do is, check the peripheral temperature. I remember we were taught that you start examination from the foot, feel the foot and gradually go up and see how high, up to the knee it is cold, ankle it is cold, how much cold it is. We used to use the difference between the rectal temperature and the skin temperature to assess the difference. So going back to what I started with, that the lakh duho ki ek dawa was fluid. But as Paracelsus said that anything in excess is harmful. So the harm of giving excessive fluid, if you realize, is edema formation, organ congestion. I have taught people, edema is only cosmetic, don't bother about it. I was totally wrong. 25 years back, I told everyone, edema is only cosmetic. We should not worry about edema. We should keep on giving fluids. In 25 years, we learned that that thing is totally wrong. Organs get congested, organs fail because of over congestion. There is a dilutional coagulopathy, hypothermia, dilutional anemia, electrolyte disturbance, n number of and I can show you n number of studies which actually prove that overhydration is actually more harmful. The classical example I can give you is if you read the American Association of Gastroenterology AAG guidelines for severe acute pancreatitis, 2008. The fluid requirement used to be phenomenal, 200 and 250 ml per hour. They revised the guidelines 10 years later where they found that when you use a large volume of fluid, the mortality was higher because of ARDS and because of abdominal compartment syndrome. So ultimately, as I said, that everything has to be with the right checks and balances. Monitoring arterial pressure is not very difficult. CVP we don't need to monitor. And again, as I told you, the last time I ended with a single line. I will end this lecture with a single line. One line. Life is very simple. We have complicated with all these things. And this is what Daniel Lichtenstein told me once. Daniel Lichtenstein is the one who has written the book on ultrasound in the ICU. He said, life simple. Huh? Patient come, BP low, put probe. If B line is present, don't give fluid. If B line is present, give fluid. Less than 3 seconds. So simple thing. What is the purpose of giving fluid? The purpose of giving fluid is, or monitoring all this is, to give fluid to improve organ perfusion. At the same time, you don't want to worsen pulmonary edema. So as long as there is no pulmonary edema, there is no contraindication to giving fluid. So today what has happened is with the use of ultrasound in the ICU, majority of the monitoring parameters are becoming progressively redundant. And that's all. Thank you. And I'm sorry I have exceeded my time.
Thank you, sir. It was an excellent and very informative lecture. Anybody has any questions? We can take postgraduate students, those who are working in ICU. Any question? No. Rahaj.
But I told you,
Sir, my one question, in resource limited settings, how would you monitor? Like when there is no ultrasound?
Which can be they will using reusable circuits and Simon will using disposable circuits because I proved to the PNC by using disposable circuits and filter with every patient we were saving 1 lakh. So by preventing infection, we were saving a lot of money. The cost of antibiotic 1 day was equivalent to what was needed to prevent infection. So it needs to put in effort. And that is the reason I said, if we are able to change a filter every day, which is 800 rupees, we can as well put a transmission. That is the precise reason I told you is that is the reason I said that there, and you need a Gelco. Gelco is freely available in the corporation. And in 95, 94, when we were putting PA catheters in cyan, we can easily do it now.
Thank you, sir.
Thank you very much. I told you we don't use a transducer for the CVP for a long period of time. See, as I told you, we have replaced it with the ultrasound mediated devices. So what I told you, I've not put a PA catheter for a very long time because whatever information we derive today, we are able to generate everything with the ultrasound machine, non-invasive, whatever. All these parametering devices, what we get from the invasive measures, we can actually generate all the data and more reliably and in a lesser time. Of course, unlike these measures where you have a continuous display, it is intermittent. You can only generate at a point of time. So the advantage of doing all this, so if you ask me what are the major reason where you would monitor everything, I told you the reason. You had bad lung, bad heart combined, COPD, pulmonary hypertension, RV dysfunction, TR. These settings you would monitor everything, otherwise we don't need to monitor anything with the ultrasound machine. With a simple IVC diameter, IVC distensibility, IVC collapsibility, the lung ultrasound showing our presence or absence of B lines would exactly tell you how much fluid to give and how much to remove. Thank you.
We now request the chairperson, Dr. Nitin Sarate sir, and Dr. Neelam Redkar ma'am to felicitate our speaker, Dr. Prakash Jandani sir.
Moving on to our next session, the topic is critical illness in pregnancy. For this, I would like to invite Dr. Santosh Salagre sir, Dr. Kiran Mahajan ma'am, and Dr. Meghna Vaidya ma'am as our chair people. Dr. Kiran Ahare ma'am, working as an associate professor in the Department of General Medicine at Seth GS Medical College and KM Hospital, her areas of interest lie in rheumatology, in charge of medical equipments concerned with the ICU, and her key interest in medical education and teaching. Welcome you, ma'am. Next, we have Dr. Meghna Vaidya ma'am, Associate Professor, Seth GS Medical College and KM Hospital. She was a former assistant professor in the medicine department of LTMMC. Her areas of interest lie in neurology and intensive care. She is presently in charge of the geriatric OPD and attending the rheumatology OPD at KM, NMC recognized teacher for UG and PG students. As the speaker, we would like to invite Dr. Dilip Karnat sir to take over the session.
Yes, so if you see the change, all these sessions there were 2 chairpersons. But for this session, there are 3 chairpersons. The reason is my own PG teacher, Dr. M.B. Agarwal sir is here. So that is one thing which is really making us nostalgic. And sir, here, 80% of the crowd is from Sion. So that is another thing. And about Karnat sir, all of us here, we are sir student. So clap for sir. I don't see anything from this slide I need to read. Sir and both sirs sitting here who are there, they have taught us medicine. And that's why sir doesn't like that he getting introduced. So I respect you, sir. And we want to listen from you. So I'll stop here and the session is yours, sir. Thank you so much, sir. Yeah.
Thank you, Santosh. It takes me back maybe 20, 25 years when I used to stand here and teach. So it's a pleasure to be back. I'm going to talk to you on critical illness in pregnancy. And so a little bit about why or how important this is in critical care. Yeah. Okay. So in any ICU, about 2% or little more than that percent of patients are actually pregnant patients. And they have a totally different physiology. So although the number is small, they form an important subset where you need to really be good at understanding what is going on and only then be able to treat them. Of all pregnancies, about 3 to 8% of pregnant women require to be in the ICU at some stage of the pregnancy. Okay? And maternal mortality, though high, is decreasing over the last 20 years or so. The importance is to understand the abnormal physiology in these patients. Okay? So whatever changes take place in terms of adaptation of physiology to pregnancy, results like, there's increased cardiac output, there's hemodilution, there are changes in coagulation, respiration, and so on. So all of these to some extent compromise the physiological reserve of these patients. So whenever there is any intercurrent illness, they tend to decompensate very fast because of lack of physiological reserves. The other is changes in immunity. So there are changes in immunity which kind of induce a tolerance to different kind of antigenic composition of the fetus, right? So this is supposed to predispose to infection. So many infections tend to be more severe in pregnancy. But there is also a positive side to this, in the sense that many patients with autoimmune disorders, once they become pregnant, the autoimmune disorders tend to do better during pregnancies. But then once they deliver, they tend to flare up in the postpartum period. As I said, a lot of pre-existing medical diseases decompensate, and there could be obstetric disorders which come up for the first time during pregnancy, which are related to the pregnant state itself. We tend to think that intensive care stops with delivery. Everything gets better after delivery, but there are many conditions which appear for the first time in the postpartum period also. So this is a chart which shows obstetric emergencies and how they occur in the different periods of pregnancy. So we have a different set of disorders which come up in the first trimester. The two most important ones which are worth discussing are ruptured ectopic pregnancy, which presents as hemorrhagic shock, and a lot of times there's no history of this patient being pregnant. So it's like unexplained hemorrhagic shock in a young lady in childbearing age group. We must think of ruptured ectopic. The other which we are seeing increasingly commonly is the ovarian hyperstimulation syndrome. This is seen in women who go in for IVF pregnancies. Okay, so in order to generate a lot of OVA, these people are given a lot of hormones which stimulate the ovary, and as a result of this, there are various physiological changes which take place. So once they conceive, it's not like the treatment is over, medicines continue. These people come with leaky capillaries, hyperdynamic circulation, so they'll have edema, they'll have big pleural effusions, ascites, increased cardiac output, very severe tachycardia. Over a period of time, they get pulmonary edema and so on. So these are all important disorders which we see in the first trimester. In the second trimester, is relatively a good period, very little or very few obstetric disorders in this period. But the third trimester again is a very crucial period, and you can see a whole list of disorders which we see. In the postpartum period, the biggest problem is postpartum hemorrhage and obstetric shock. This is about medical disorders. Okay, so medical disorders can happen because there is increased risk of severe disease for some of these conditions. So it's quite a big list there. We don't need to go into many of these in detail. And there are some pre-existing disorders which worsen in pregnancy. For example, patients with valvular heart disease, patients with chronic kidney disease, or those with liver cirrhosis can have worsening of their condition during pregnancy. As an example of why it's important to look at various aspects in pregnancy, let's look at what can happen due to infections in pregnancy. So there are some infections which have no consequences whether the patient is pregnant or not. For example, hepatitis A. So it tends to be equally severe in non-pregnant women. So the presence of pregnancy really doesn't add or worsen anything for the patient. Similarly, it has a negligible effect on the fetus. Okay, there are some disorders which are harmful for the mother. For example, hepatitis E or malaria or influenza like H1N1 tend to be much worse in pregnancy. So it's harmful for the mother to get these disorders during pregnancy. There are some conditions which are harmful to the fetus. For example, many severe viral infections can cause harm to the fetus, placental insufficiency. There are some which can be teratogenic, right? And there are some infections which can actually cause in utero infection in the fetus, like parvovirus B19. There are some conditions which may be harmful to both, like malaria and septic shock, right? Some of them, if the infections are in late pregnancy, can be transmitted to the neonate. And some of them may cause chronic problems in the neonate, not just in the immediate post-delivery period, but even long term, right? So whenever we think of severe illness in a pregnant patient, we need to kind of look at all these various aspects. So I'll just discuss a few patients to illustrate some of the points about care of these patients. So this is a 24-year-old primiparous woman with a normal antenatal history, shifted to the ICU for sudden onset of convulsion at 32 weeks of gestation. On examination, little bit slurred speech, otherwise unremarkable neurological examination. There is tachycardia, hypertension, systemic example is unremarkable. Okay, so what are the things which come to mind? Let's look at the lab parameters. Okay, so little bit of thrombocytopenia, mildly raised creatinine, liver enzymes are normal, coagulation is normal, uric acid is 7, and proteins, urine proteins are 2+. So what's the first thing that comes to mind? Yeah, okay, so eclampsia, right? What else could it be? Stress. Anything else? Okay, so basically, you need to think of non-obstetric disorders also, right? So this patient's ANA was positive, 1 in 1,000, dsDNA was positive, and only after you ask in detail you get this history, that in the past this patient used to have recurrent oral ulcers and photosensitivity. So as I told you, typically these symptoms tend to get better during pregnancy, but once in a while there can be a patient who comes with an SLE crisis in pregnancy. Another woman with 33-year-old, 30 weeks of gestation, history of hypertension since the previous 3 weeks, started on labetalol, urine protein 1+, low-grade fever, headache for 3 days, but better now, had abdominal pain, nausea, so consulted the obstetrician with whom she was following up. Again, mild hypertension, tachycardia, okay, but then this patient was already hypertensive on medications. Okay, so these are the labs, right? So thrombocytopenia a little more, okay, raised BUN but not too much raised creatinine, liver enzymes are elevated, okay, urine protein 1+. So urine protein 1+ was there earlier also, right, before this. So now what? So again, logically you will first think that this is a patient who is now getting preeclampsia, but then the important thing is this low-grade fever, right? And somehow the liver enzymes seem a little too high for preeclampsia just starting up. right? Okay, so this patient, we did a ultrasound, there was bilateral pleural effusion and little bit of ascites. So having seen that, then retrospectively you send a dengue test for NS1 and that was positive. Okay, it's not like somebody thought of dengue first and sent the test, but when you see pleural effusions, thrombocytopenia in the appropriate season, you have to think of dengue, right? Okay, so another lady with twin pregnancy, hypertension, BP controlled, had hypochondriac pain, nausea, vomiting. Okay, blood pressure is relatively normal, tachycardia. Okay, these are the lab reports. Okay, so what could it be? Come on, so based on these two cases, we know we've got to think of obstetric conditions as well as non-obstetric conditions, right? Medical disorders. So here you can see that, the patient has proteinuria, mildly raised creatinine, liver enzymes are elevated, a little bit of thrombocytopenia. Anyway, the patient was relatively stable, right? So this is day 1 labs, the same as what we saw. These are day 2 labs. Okay, now this patient also complains of visual blurring and headache. The hemoglobin drops from 11 to 8.5. Okay, but there is no blood loss, right? Platelets have dropped further, liver enzymes have gone up, bilirubin has increased. INR is now 2.7. So what could it be? Hepatitis or HELLP syndrome. Yeah, okay. So what would you do? So look for the viral hepatitis you should rule out. So you do hepatitis B, C, IgM for hepatitis A and E. They are all negative. So by exclusion, you come to a diagnosis of HELLP syndrome or fatty liver, right? There's no way to differentiate between those two. Okay, a lot of people say the difference or trying to differentiate between them is theoretical because the treatment remains ultimately the same to deliver as soon as possible after stabilization, right? Okay, so in these patients, we need to have a stepwise approach, otherwise things can go wrong. Okay, so this is a 6-step approach which we commonly follow in managing these patients. Okay, so the first thing is this a medical or an obstetric cause? Yeah, so we've already seen those 3 examples where things could have gone either way in terms of a diagnosis. The next thing is to, in a critically ill patient, start supporting the failing organ, right? Then you need to think that, is there a risk to the mother if the pregnancy is continued? Or should we terminate the pregnancy or deliver the patient, depending on at what stage in the pregnancy this patient becomes critically ill, right? If we decide to go ahead with delivery, should it be a vaginal delivery or should it be by a cesarean section? Okay, the next step is to optimize the patient's organ function in time for delivery. And then the last is to anticipate postpartum problems and then think of how you want to manage them. So this involves a lot of teamwork. It's not like one person deciding. You need to have an obstetrician who takes a call on monitoring the fetal well-being, looking at what stage, whether this patient is going in labor or not. You need an intensivist to take care of organ failure for these patients. You need a neonatologist to anticipate whether the fetus is mature enough to be taken care of after delivery. And an anesthesiologist in case it's decided to take this patient up for section for early delivery, right? Okay, so is there a risk to the mother or fetus if pregnancy is continued? So most obstetric disorders improve rapidly after delivery, right? Severe preeclampsia, eclampsia, then fatty liver of pregnancy, HELLP syndrome. The mainstay is to deliver as soon as possible, right? So fetal well-being should be monitored. So sometimes if there is fetal distress, then delivery may be required even though the mother is relatively stable. So you deliver for the benefit of the fetus. In the first instance, we deliver for the benefit of the mother. Right? A lot of times the time taken to stabilize the mother's organ dysfunction may actually compromise fetal outcome. important caveat is that maternal survival takes precedence over the fetus's survival, right? So always the priority is to stabilize the mother as far as possible. But the ideal thing would be to deliver at a time which is optimum for both, right? Mother as well as fetus. At times, to allow fetal maturity, obstetricians will advise tocolytic drugs. Yeah, some of them are mentioned here. So all of them could have some adverse effect on the mother. So we need to keep that in mind when dealing with such patients. Okay, so will the maternal outcome improve with delivery? So which are the conditions where the mother's outcome or survival improves with delivery? So that's a list over there. Severe preeclampsia with organ failure, eclampsia, acute fatty liver, HELLP syndrome, placental abruption, status epilepticus. The next one is important, okay? Cardiac arrest after 24 weeks of pregnancy. So if you go through the ACLS protocol, it says that if a pregnant lady after 24 weeks has a cardiac arrest, you start CPR and ACL as per the ACLS program or protocol. At the 4th minute, okay, if there is no return of spontaneous circulation, then while you are doing CPR, the baby should be delivered. Okay, ideally within the 5th or the 6th minute. Okay, so you need to have an obstetrician there at the time of CPR, and this person has 2 minutes to deliver the baby. Okay, so this delivery is not for the fetal well-being, but the chances of successfully resuscitating the mother is much better if the fetus is removed. Right? So this is a sort of guideline which is quite strong. I mean, it's not like may or may not do. It's recommended that you do this as far as possible. Okay, and the last is severe chorioamnionitis. Okay. So whether to do vaginal delivery or C-section. So what are the various points important at this stage? So the first is a decision, of decision to delivery time. That means you want to deliver in how much time? 1 hour, 2 hours, 4 hours, 6 hours tomorrow morning. So that should be very clear so that all members of the team know that, right? The intensivist knows, the obstetrician kind of decides the time. A lot of times the neonatologist, anesthesiologist, everybody knows that, okay, we have 4 hours, right? That's important. Okay, then mode of delivery, type of anesthesia, you have to balance the risk and benefit, right? Okay, so a lot of times vaginal delivery is not feasible because it takes too long and the time of delivery is unpredictable. So more than 70% of critically ill patients get delivered by cesarean section. Okay. Now typically when you do a cesarean section in pregnancy, the preferred mode of anesthesia is spinal or epidural neuraxial anesthesia. But in critically ill patients, it can worsen shock. In patients with coagulopathy, you can't do that. Right? It worsens respiratory distress. In patients with seizure, again, it's not possible. So there are a lot of reasons for not doing it. By and large, there is an increased risk of intubation and respiratory complications when giving GA in pregnancy. But for critically ill patients, in spite of this risk, it's the preferred mode of anesthesia. Right? So again, the coordination between all team members is critical for this. Okay. So the next step is optimization of organ function. Okay, so the key word here is optimization. It is not normalization. Okay, a lot of times this sort of tussle goes on between the intensivist and the obstetrician, saying that platelet is just 70,000. Give me platelet count more than 1 lakh. Right? So it's not like we want 1 lakh, 1,50,000. It's a matter of optimization. So you go by the guidelines. Right? So typically, if the count is more than 50,000, you can do surgery. Yeah. If you have to give spinal anesthesia, then you need a platelet count more than 80,000. But in this case, as we said, that's not an option. So we don't try to correct things to perfection. We optimize things as much as we can. What are the things that need optimization? One is airway protection, control of the seizures. Yeah. Respiratory depression may be there because of some of the drugs which we give these patients. For hemodynamics, put the patient in a left lateral position or displace the uterus laterally to increase venous return by reducing IVC compression, fluids, transfusion, vasopressors. For seizures, the treatment is like Maxalf, anticonvulsants, and so on. Yeah. So coagulation and thrombocytopenia are common in a large number of patients with obstetric disorders. So we need to be sure which are the blood products which we need to give these patients. Okay, now this is one situation where apart from the normal coagulation tests, there is some role of doing thromboelastography as well, because that may give you sometimes a better picture of how much to correct, whether you're correcting adequately or not, and so on. Right? And take care of electrolytes, calcium, glucose, acid, base. Important thing is when a critically ill patient comes to the ICU, if we are going to think of delivery, then to give this patient 2 doses of dexamethasone or betamethasone, because ideally they should be given 12 hours apart. Okay, so it's not like you wait till you decide to deliver and then give it. By then it will be too late. So you give the first dose as soon as the patient comes in. Yeah, you can give the next dose 12 hours later, and that hastens fetal lung maturation. A single dose of IV Maxalf is often given because it is neuroprotective to the fetus during premature delivery. Okay, so what are the issues in the postpartum period? Main thing is to assess for vaginal or abdominal bleeding. Okay, a lot of these patients may have DIC which needs to be corrected even after the delivery is done. The other is sepsis. Okay, we need to look at what is the source of sepsis. A lot of these patients may have been in the ICU, may have been intubated, may have central lines and so on. So whether is it a line related sepsis or is it actually a infection in the genital tract? A lot of times the most difficult thing as far as obstetricians go is the decision to re-explore the patient. So which are the patients who need to be re-explored after they have been delivered by cesarean section? So one is persistent hemorrhage. The second is if there is an adherent placenta which has been left behind, because that surface continues to bleed. Rupture of the uterus, if there is a pelvic collection, whether it's a hematoma or an abscess, would require drainage. Right? Okay, seizures may occur in the postpartum period for the first time. Okay, so a lot of patients who are epileptic may have good control throughout pregnancy, but may get a first seizure after delivery. That's probably related to loss of sleep, changes in the sleep-wake cycle, and so on, which reduce the seizure threshold. Plus, some drugs may have been missed because the patient was ill by mouth or whatever in preparation for delivery, and right. And postpartum eclampsia. So eclampsia occurs in 15% of women for the first time. The seizure may be in the postpartum period. Okay, then care of the breast, conditions related to RH isoimmunization. These patients are at increased risk of thrombotic disease, so they may get DVT, cerebral venous thrombosis, and so on. Okay, many medications specifically required. One is Maxalf for eclampsia. Should be continued for up to 24 hours after delivery to prevent this seizure in the postpartum period. Okay, DVT prophylaxis, some of them may need oxytocin to be given if there was a atonic kind of PPH and now the uterus is contracted. The last is Sheehan syndrome, which is postpartum pituitary necrosis. So this typically occurs in patients who have had a severe episode of hypotension, have been resuscitated, delivered. After a period of stabilization, this patient may go into shock again. Okay, and this is now because of endocrine problems related to acute pituitary insufficiency, right? So the treatment of, so they'll manifest as hypotension, hypoglycemia, and the treatment is to give them what? Which is the drug of choice? Lack of which pituitary hormone will cause shock suddenly. Yeah. Okay, so they need to be given steroids, right? So the immediate thing is to replace steroids. You can also give thyroid replacement. Okay? And sometimes it happens like a chronic thing, you know, it happens slowly over a period of days or weeks. So if that happens, then the main manifestations are either diabetes insipidus or lactation failure because of failure to produce prolactin. Okay, so that was a kind of brief overview of critical illness in pregnancy. Thank you.
A very excellent and informative lecture by Karnar sir, and it's always a pleasure for us to listen to him. Any questions from the students?
A pregnant lady with pre-existing epilepsy, current protocols, what are the protocols? Do we replace the medicine or just continue with what is going on?
Raj, unless the patient is on phenytoin, there is no need to replace. Okay? And as to which is the best anticonvulsant, there is still controversy. All of them have some possible teratogenic effects or whatever, but most of them fall in the category where it says that it is better to continue if the patient is controlled on it. The second thumb rule is to give the lowest dose required. So if this patient has not had a seizure in the last 2 or 3 years, you can probably reduce the drug dose by 1/3 or 50% during. So the reason was that this patient had been seen just like a week before and there was nothing. It was not like this patient had hypertension or all biochemistry was perfectly normal. So all of this to suddenly become abnormal in a week's time. And it was not even that this was very close to term. Towards term, things can develop suddenly, but 26, 28 weeks, if something comes up suddenly, then it may not necessarily be preeclampsia. Yeah.
Sir, regarding CNS vasculitis first case, in the mid of the term, you said that we can't deliver anything. How to manage apart from steroid or something? What can we offer that patient?
Yeah, okay. So basically this patient settled with steroids, but the other option is to give IV immune.
Thank you, sir. We'll like to request our chair people to felicitate our speaker, Dr. Dilip Karnad, sir. We'd like to request Dr. Nitin Sarate sir and Dr. Vinayak Pai sir to felicitate our chair people, Dr. Kiran Mahajan ma'am, Dr. Meghna Vaidya ma'am, and Dr. Santosh Salagre sir.
Before the announcement of last session begins, and sir also will be joining us. So there are two events which are coming. 30th November, that is Sunday, we have a full day hypertension CME with MMC credit points. So those who want to connect to it, obviously for the PG students, we already sent the message. They can obviously contact me because I'm the organizing chairperson for that. And all those who are in any way connected to KEM, we have a reunion of all the medicine department KEMites who are faculty and PG students. So we invite all of you on 13th December, again a Sunday, for a session which is going to be nostalgic. So the details will be there. Smriti is there and all our faculty members know about the event. So those who are connected to KEM in any way as a faculty or PG students, most welcome to connect to us because we want all of you to join for that reunion, centenary reunion. And you know that medicine department was established in 1925, right? So 100 years of this department and we are going to celebrate together. So with that, over to you for the next announcement.
So we move on to the next session. I would like to call our chair people for that. I would like to call Dr. Mohan Agarwal, sir. So now I would like to call Dr. Kaustubh Salagre, sir. Dr. Kaustubh Salagre, sir, is Associate Professor and Head of Unit Department of Medicine, St. GS Medical College. Professor Additional and Head of Unit of Department of Medicine, St. GS Medical College and KEM Hospital. He is in charge of the palliative care services and more than 10 original articles and case reports in reputed journals, API, MSc, journal body member, and more than 14 years of teaching experience. Welcome, sir. Now I would like to invite our chairperson, Dr. Juhi, ma'am, and from the Department of Medicine, St. GS Medical College and KEM Hospital. Welcome, ma'am. Now I would like to call our speaker, Dr. Chandrakala, ma'am, will be introduced by our chairperson.
Good afternoon, everyone. As we come to end of the last session of today's CME, with all pleasure, I will like to invite Chandrakala Madam for this session. Madam is Professor and Head of Department of Hematology, and I think most of the hematological patients of our department are taken care by Madam. So, and we frequently disturb her for the various emergency patients. She has done fellowship in leukemia, bone marrow transplants. Her areas of interest are clinical immunology for more than 10 years. She has been attending the updates in the field of management of hematological cases regularly and actively involved in publication, delivering lectures in various CMEs and conferences. So welcome, madam, for this today's session.
Thank you, Dr. First of all, I would like to thank Dr. Nitin and organizers for inviting me to give a talk. And in the next maybe 15-20 minutes, I'm going to talk on thrombotic microangiopathies in peripartum period. And Karnar sir has set the ball rolling because already sir has discussed some of the cases like HELP, preeclampsia and eclampsia. So I'm going to continue the same thing, which is also a part of thrombotic microangiopathy in peripartum period. So these are my agenda for my talk. Know the TMA causes, clinical presentation, importance of early diagnosis. Why should we diagnose early? And how can we diagnose early? Because many of our patients can't afford the fancy investigations. And what are the principles of management of TMA in pregnancy? So this is the definition of TMA as per the International TMA in Pregnancy Committee. TMA is a broad definition of thrombocytopenia, MAHA, and end organ damage. Only three things: MAHA, thrombocytopenia, end organ damage, that constitutes TMA. And why it's important in pregnancy or peripartum is we have to, because there are overlap. You have HELP, or TTP, or a HUS, or a TTP. There is overlap and always a confusion come to a conclusion, diagnosis. And we are dealing with two lives. One is whether it is any effect on maternal life for the fetus, what are the drugs we are giving, and how we manage this TMA will have to consider both mother and the child. And therapies also depending on whether it is teratotoxic or whether it is teratogenic or which is fetal toxic or how does it work for both mother and the child. That has to be kept in mind when you are dealing with TMA in peripartum period. So the definition is TMA is a pathological term. It is not a clinical term. It's a pathological pattern of endothelial cell swelling, detachment of the basement membrane, thrombi in microcirculation, and the kidney in double counter. So this is mesangiolysis. This is about a pathological term, TMA. And the clinico-pathological triad, or a clinical pathological triad which is used to diagnosis, again thrombocytopenia less than 1 lakh, hemoglobin less than 10, LDH more than upper limit of normal, undetectable haptoglobulin, and cystocytes. Why platelet count is 1 lakh? Normally we consider as 1.5 lakhs. In pregnancy, almost 20 to 30% of the pregnant female will have a thrombocytopenia that is gestational or the dilutional thrombocytopenia. So the platelet count is 1 lakh used in pregnancy, TMA, and organ injury. The creatinine also used is like more than 90 micromole per liter or 20% more than the baseline. So these are the few definitions which is used for the diagnosis. So what are the TMAs we see in peripartum period is we have is some of the things which is specific to pregnancy are related to pregnancy. Some of them are associated with pregnancy. So TMA, this is non-specific to pregnancy, like a DIC, antiphospholipid antry syndrome, or a catastrophic APLA, it's called as CAPS, or hemolytic uremic syndrome. So these are all non-specific to pregnancy. It can be seen any other than pregnant female or a pregnancy. So which is specific to pregnancy is eclampsia, preeclampsia, HELP, and acute fatty liver. And TTP is either can be pregnancy related or pregnancy associated. So these are the things which is TMA. These are all the things which covers the TMA in pregnancy. So coming to the incidence, preeclampsia is quite common, 1 in 20, whereas TTP is 1 in 2 lakh. So this is the incidence per pregnancies we see in these patients. Apart from all these things, your DIs, sepsis, postpartum hemorrhage also can lead to TMA. So what are things in which trimester and how do you suspect what the patient has? Is the patient, if it is presenting after 20 weeks of gestation, then you think of all eclampsia, preeclampsia, and the HELP syndrome or acute fatty liver of pregnancy. If the patient has come with a TTP, can present any trimester pregnancy. TTP can present. HUS most common in the postpartum, but can present any trimester. So there are nothing like hard and fast rules, but there are some things like postpartum patient is delivered normally and has come after 3 days, then HUS is most likely you think of. And if the patient has come after 20 weeks, then think of more of PE, and then any trimester, TTP is the diagnosis we can think of. So this is the what trimester they present. So pathophysiology is, I told you about the eclampsia, preeclampsia also is considered as a TMA. So you can see in this picture is there are anti-angiogenic and angiogenic proteins, and when there's a reversal of these, that gives rise to TMA. And in TTP, we have ADAMTS deficiency, either immunogenic or non-immune. There will be deficiency of this, and they will have a large BWF multimers, which causes the platelet adhesion and the micro infarction that leads to TMA. And in HUS, it is mainly complement mediated with complement activation or the absence of anti-complement factors that leads to the TMA in these patients. So we have a definition of each condition. We defined as preeclampsia, eclampsia, and HELP syndrome that you all know. So again, everybody thinks of how HELP causes TMA. This is one of the mechanisms which has been very well studied. Is there is altered immune system of the mother and defective trophoblast infiltration and even the vessel abnormality. So all this causes a complement activation, and the patient can have a TMA in the HELP syndrome. So coming all the TMAs, HELP syndrome is one of the commonest cause in pregnancy, and it accounts for 0.5 to 1% of all the pregnancies. And the mortality with HELP is almost like 1.1%, and perinatal death rate is also 7 to 34% in HELP syndrome patients. So again, the pathophysiology and the markers which we can use, this is a new marker which can be used. It is available also, but we don't use, I don't know, I have not seen any pregnant lady getting this marker done, but it can be easily used to differentiate between the HELP and the other conditions. So this is the marker which can be used, is SFLT and the platelet growth factor ratio. And if it is less than 38, it rule out the preeclampsia. If it's more than 85, then it's impending, and you can admit the patient and monitor the patient. So this is actually almost about 4,000 or 5,000 rupees. Its test is available, and it can be used to monitor these patients. So coming to the case, this is a 21-year woman presented at 28 weeks of gestation in a first pregnancy, and routine blood test received about 35,000 platelet count, raised blood pressure, and fetal distress was seen, and enzymes are not markedly, it's about mildly raised, about enzymes is 100, and creatinine, urine protein creatinine ratio is 432. So the diagnosis in this patient, can it be, what are the possibilities in this patient? What are the possibilities in this patient? It can be either pre-eclampsia, eclampsia, or it can be a HELP. Potentially, we can think of HELP. All these things can be considered. So, can we see such a low platelet count in eclampsia, pre-eclampsia, HELP? We don't see such a 35,000 is too low to condition these conditions. So, usually it's in the range of 50 to 1 lakh. So, that's the reason we have to think, actually, we have to think something beyond all these conditions. So, this is how we differentiate between TTP and the HELP. So in this patient, TTP cannot be ruled out. So we need to work up for some other investigations like LDH, haptoglobulin, all these things has to be done. So because the platelet count and the creatinine, urine creatinine protein ratio is the two things which we have to think that it may not be always eclampsia in this patient. So these are some of the markers which will tell us about what is the diagnosis, most likely diagnosis. The one important marker is ADAM-TS levels. If it's less than 10%, very easy actually. See, it is very difficult to convince our patient to get this test done. So we don't have a luxury of doing this test easily. So, but we have other markers which will help us in the diagnosis. But ADAM-TS1 is the one which will help us to diagnose the patients of TTP if it is less than 10%. So TTP, again, I mentioned it's a life-threatening thrombotic microangiopathy, severe thrombocytopenia, microangiopathic hemolytic anemia, widespread microvascular thrombosis because of absence of ADAM-TS levels. That can be either immune or the non-immune. We have congenital deficiency of ADAM-TS levels, and we have antibodies to ADAM-TS levels. So it is deficiency less than 10% is a very biologic marker specific for TTP. So this we are marking 100 years of TTP diagnosis in 2024, and this was also called as Moskowitz syndrome. And then initially it was described as acute febrile pleomorphic anemia with hyaline thrombosis of terminal arterioles and capillaries. So what is the importance of TTP is the mortality of TTP without treatment is 90%. 90%. We have seen patients actually. Before the diagnosis patient, we had a patient who has come to the hospital and she was 32 weeks of pregnancy. She had thrombocytopenia and patient received multiple platelet transfusion. Patient died within 48 hours. So it's important is to diagnose this patient and treat early. The mortality in TTP without treatment is 90%, whereas with proper treatment, the mortality drops to 10%. See, that's the only thing. If you save one life with this, once you do a plasma exchange and do think of this TTP, this will about 90% to 90% will be reduction in the mortality with this. Coming to epidemiology, TTP accounts for about 10 to 15% of all the TTPs we see. Pregnancy as well TTP is about 10 to 15%. And it cannot be always immune. You can also see congenital TTP can also be seen in pregnancy, and it's almost about 24 to 66% in different studies has been reported, and it can present at any trimester of pregnancy. It can be many things, TTP, either congenital TTP, primary or autoimmune. These are all the causes of TTP, but at present we are only thinking of immune and the congenital in pregnancy associated TTP. The clinical manifestation is gastrointestinal symptoms, weakness, blurry, bleeding or purpura, neurological symptoms. It can vary. We had a patient who had come to us. She had come to refer to us with an AHA, and she had a severe asthenia, and patient was admitted in the hospital. In the night, she was talking irrelevantly and laughing, and she was pouring water in other patients. That was the only clue that she was diagnosed with TTP and started with plex, and within 1 or 2 plex, you can change the marked difference. The patient will, the altered sensorium becomes much better. So the classical pentad, which we described in the books, is present in only less than 10%. So you don't expect all the pentad in patients of TTP. And see, these are all the symptoms. It can affect any organ. The patient can have CNS injury. The patients can have a high troponin levels, elevated cardiac arrest, or pancreatitis. We had a patient again referred from GI as pancreatitis requiring multiple transfusions. By the time patient diagnosed TTP, patient was not able to get the treatment. So these are all the things we have to. Patient has pancreatitis, or patient has thrombocytopenia. With any of these things, we have to think of TTP. Again, the classical pentad of what we study is hemolytic anemia, thrombocytopenia, fever, acute kidney injury. Neurological findings are less than 10%. Criteria, are we going to wait for pentad? These are all the pentad. No, we are not going to wait for the pentad. We require only two things. Two, microangiopatic hemolytic anemia and thrombocytopenia is enough to diagnose the patients of TTP. Don't wait for the pentad. It's only for the book description. For the treating the patient, only two things are enough. If you are clinically, you are correlating the patient, then these two things are, you have cystocytes, spirocytes, and platelets are absent. So this will show that patient is a TTP. How to suspect? So there are other things which is like our own we can do in our center is the plasmic score. It is plasmic score. It will tell us the probability of having the ADAM-TS levels less than 10%. The probability. It's not a diagnosis of TTP. It's the probability of having ADAM-TS levels less than 10%. So you have platelet count, hemolysis, no active cancer, no organ transplant, MCV, INR, and creatinine. So these things can be used. And if somebody has 6 to 7, definitely start the plex. That's very important. 5 points, you still think patient is like more neurological symptoms, then you can still think of starting the plex. But if patient is low risk, don't start the plex. So these are all the many markers. If you don't have that much, also we have something called as French score, which is also very evaluated with a very good negative predictive value and a positive predictive value. And there are only 3 markers which has been used, and it also probability of a likelihood of having the ADAM-TS less than 10%. So use any of these 2 things, suspect and treat the patient. So these are all the investigations, the peripheral smear, and these are all the hemolysis. The coagulation parameters will be normal in patients TTP. So this patient which I mentioned is the patient I showed you is 78 weeks with 35,000 platelet count. So these are the parameters. 9.2 is hemoglobin. The WBC count is this much, 35,000. And other investigations, see, LDH is high, haptoglobin is low, and indirect bilirubin is 3. And again, see, the coagulation parameters are normal. So in this patient, the most likely what we think, see the smear. So the patient has a hemolysis and cystocytes. Then we can think, we have started the patient at plex and patient improved. So one more differential diagnosis which comes into picture always is TTP and HUS is, if patient has more neurological symptoms, we think of TTP, more kidney injury, we think of HUS, because the treatment is different in both the conditions. And if you have ADAM-TS levels, that is the luxury we can treat the patient. Principles of treatment of TTP is plex with the steroids. Everybody we start on steroids. We can't. It's very difficult to diagnose between. It's not difficult. It's for us too difficult because we can't get the antibodies done or we can't get the ADAM-TS levels. So we start plex with steroids every patient, and then we can. This is a recommendation for the plex, how much to give, and fluid replacement and treatment should be provided once a day. And this is how the plex can be done. 1 to 1.5 volume exchange can be done. So the patient which I showed you, diagnosis of TTP was made and started on plex, and patient delivered at 28 weeks of gestation, LSCS, and no platelet transfusion was. Platelet transfusion is absolute contradiction. Unless you have a patient with the intracranial bleed, you don't give platelet transfusion. High dose steroids, and but this patient had ADAM-TS levels less than 5, and there was no antibody. If you have a patient, you can do everything, do the antibodies and ADAM-TS levels. If antibody is negative, if it is less than 10, then you can think of congenital TTP. That's how you can diagnose. This was diagnosed as congenital TTP, and patient was managed. So the next patient is 34-year-old female, healthy, delivered healthy male at 38 weeks of gestation, very uneventful pregnancy, and she was discharged home. 3 days postpartum, she came with asthenia with a BP of 158/92. Physical examination was normal. So investigations you see, the platelet count is better, hemoglobin is 8.2. Again, the patient had hemolysis with the creatinine high. So the patient is postpartum, so creatinine is high, hemolysis is there, then you think of more of a HUS in this patient. So the patient was again started on plasma exchange with no effect on creatinine and platelet count. So this is if the start is plex and no effect, then more commonly we treat with, it considers HUS. How do we treat HUS? Yes. So you think of yogi, complement inhibitors are used. So pregnancy associated HUS is a relatively rare disorder, and it's compared to the TTP, it's a rare disorder. It happens about 16% of all atypical HUS cases occurring in women. The estimated incidence is about 0.5 in 10 to the power of 6. So how do we work up this? Complement levels you do, and complement factor H and complement factor I you have to do, and you can do the anti-complement factor antibodies also. So these are, and ADAM TS levels again to confirm at the diagnosis of TTP HUS, you need the ADAM TS levels, and this is how you can confirm the diagnosis of HUS. Then how do you treat? This is a complement inhibitor. This is available in our country now. Eculizumab is available. And this is a patient, how it was treated is, again, he started on patient eculizumab. Plex was given, no improvement. And then patient was started on eculizumab. And you can see the creatinine is beautifully coming down. Platelet count is improving in this patient. So algorithm for initial workup is, patient has come to you as TMA, blood pressure is high, proteinuria, liver enzymes, or if you get a ratio of SFLT with the platelet growth factor ratio, then you can think of diagnosing either PE or eclampsia help. If you don't have this ratio also, we can, other parameters will help us in the diagnosis. Then we have the next is ADAM TS levels and the plasmic score, and then you can diagnose as TTP, either congenital or the acquired TTP, postpartum hemorrhage, and sepsis has to be ruled out. Then we have something called as acute fatty liver pregnancy. Again, TMA secondary the sir has shown you regarding the autoimmune condition that also CAPS is like catastrophic Appler syndrome is still a diagnosis in patients of pregnancy with TMA. Okay, so these are all the things which can be done for the initial workup of these patients. So to summarize, the treatment is, if you're suspecting preeclampsia, help delivering the baby is the only treatment option in these patients. Or if you're suspecting if levels are less than 10, then you diagnose TTP and then you can give the Plex. If levels are more than 10, then you can think of HUS, and it can be started. Eculizumab can be given in this patient of thrombotic microangiopathy of pregnancy. And there is a new treatment which is available, and then the capitalizumab can be given, and recombinant ADAM TS level, recombinant ADAM TS protein is available that can be used in patient non-pregnant, but in pregnancy there are occasion case reports which have used this drug. Rituximab is another question always. It is usually better to avoid the rituximab, but if patient has say not improving on steroids or the Plex, then you can consider risk versus benefit. Capitalizumab is a novel humanized nano antibody targeting VWF that blocks the platelet VWF aggregation, and this is a drug which is approved, but it's not approved pregnancy, but rare case reports are available. So congenital TTP, you just have to give plasma infusion every 2 to 4 weeks. That's the treatment for these patients, only when the levels are low. So there are occasional case reports of using a recombinant ADAM TS protein, which is available. It's not available in our country, but this is can be used, and you can see the patient is beautifully responding with ADAM TS13 protein. Subsequent pregnancies also you have to be careful. If you're diagnosing immune TTP, there are chances of recurrence in about 30% of the patients, and close monitoring is the only one. If you suspect, if it's a congenital TTP, definitely the patient has to be started on prophylactic plasma infusion in this patient of congenital TTP. And there is a lot of advance which has happened for the last 100 years from the diagnosis of TMA or the TTP. Is we have come to capitalizumab, recombinant ADAM TS protein, which is available in the market, which will help in the management of these patients. So to summarize, don't delay plasma exchange if you're suspecting TTP. Don't give platelet transfusion. TMA, if you're suspecting like eclampsia, preeclampsia, or a severe dysfunction with severe features, then mainly conservative deliver the baby is the only thing. And heparin is avoided. Unless platelet count, if it's improved on Plex, you can give heparin in this patient. Aspirin is the drug of choice for prophylactic preeclampsia and eclampsia. And don't ignore the relapse risk in second pregnancy. Monitor these patients and treat accordingly. So TMA in pregnancy is characterized by the MAHA and the organ injury, which comprises of all these disorders. Diagnosis relies on the diagnosis laboratory evidence, and prompt differential is vital since management differs in patients of all the TMA. Help is for delivery we should do, and plasma exchange will TTP, and this will make a difference. If you miss the diagnosis, there are chances the patients will die. Early treatment or better diagnosis early recognition and target therapies key to improve the maternal and the fetal outcome in patients of TMA. Thank you.
Thank you, ma'am, for this wonderful lecture. Now, ma'am, only one doubt is that like there are this is the spectrum of a disease, and what will you recommend immediately? Like we see a patient with having thrombocytopenia and anemia. So what should be immediately started? Like any particular thing, because patient might be having hypertension also, so we may suspect it could be eclampsia related thrombocytopenia, or whether it is thrombotic microangiopathy. So how do you tell us to approach for this? What should be immediately done?
Patient has neurological symptoms or patient has cystocytes in the peripheral smear. Any of these two things, we advise Plex. So definite hemolysis is there or neurological symptoms, and Plex is the one which we advise.
We now request our chairperson, Dr. Kaustubh Salagre sir, and Dr. Juhi Kawale ma'am to felicitate Dr. Chandrakala ma'am. We request Dr. Meghna ma'am and Dr. Kavita ma'am to felicitate our chairperson, Dr. Kaustubh Salagre sir, and Dr. Juhi Kawale ma'am. Kavle ma'am. Dr. Juhi Kavle ma'am.
So before they propose vote of thanks, I think all of you will agree that this was a really a good engaging day, and the kind of speakers, chairpersons who came here, the contents which were given were beneficial to our all PGs and to the practicing physicians. So all of you will clap when I say name of Nitin Sarate. Pai, because the last 15-20 days they were really working hard. Vishal Bhist, which I used to give him prompter my, I was doing remote control on him, what to say and what not to say, and Satish Gosavi. Obviously, the team of MICU PGs, and this is not only on behalf of me, but Nadkar sir had particularly messaged me that we want to congratulate this young team of our intensivists. So congratulations, Nitin and team. Over to you for the conclusion. Yeah, thank you.
We have now come to the conclusion of this enriching CME. I request Dr. Vinayak Pai sir to come forward and deliver the vote of
Thank you, Vishal. So at the conclusion of today's critical care CME, it is my privilege to deliver the vote of thanks. So first and foremost, I would like to tender our gratitude to the esteemed Dean Madam, Sangeeta Rawat Madam, and also to Dr. Maulik Madam for gracing this occasion with her presence. We would also like to extend our special thanks to Dr. Santosh Salagre sir, who very graciously stepped in place of our HOD M. Nadkar sir. And we are grateful for your participation in the CME and for representing our department with such enthusiasm and commitment. And a very big thank you to our esteemed organizing secretary, Dr. Nitin Sarate sir. Your dedicated effort and meticulous planning and leadership have made this whole event possible and successful. Our appreciation goes out to each and every one of our faculty, speakers, and chairperson for dedicating your time to this event. And warm acknowledgement to all our participants
without whom this event would not be possible. And lastly, our thanks to the anatomy department and the support staff and the sponsors and the supporting staff, including our photographer and the audio technicians. Thank you.